So it is important that our local doctors, local public, and our oncologists who are practicing here, they should know what is happening elsewhere in the rest of the world, and are we updated enough? So over a period of 4th July, that means today and tomorrow, we are going to have this ASCO, American Society of Oncology, updates on GI cancer, lung cancer, and genitourinary cancer. And tomorrow we are going to discuss cervical cancer and breast cancer too. Now, we also have very interesting panel discussion on lung cancer and cervical cancers. Now, why this Ranchi Cancer Summit is different? So we have doctors sitting with us, we have NGOs, we have respected member of Jain community who through their philanthropy, they are doing a lot of work. We have dental students where we are also focusing on the preventive oncology. Now, Ranchi Cancer Summit is different that it doesn't only allow interaction between oncologists only. Here we have interaction with the masses, with the community. And when you see, we have almost 1,300 registration done for this summit, from MBBS to BDS and everyone else. So again, a warm welcome from the organizing committee. And without wasting time, we will start our first session. Thank you.
Thank you, sir. Thank you so much. So to begin with the session 1 on GI cancer, I would like to invite the chairpersons to chair the session. Brigadier Dr. Alok Chandra from Ranchi, Dr. T.M. Singh, Bokaro, Dr. Shekhar Swaroop from Ranchi, and Dr. Colonel Madan Mohan Pandey.
Good morning, everybody. A very warm welcome to this conference. It's nice to see a full hall over here. And I'm sure you are in for an academic feast over a course of 2 days of Ranchi Cancer Summit. I am extremely grateful to Dr. Satish and the organizing committee for inviting us over here. For the first talk, we have Professor Dr. Ghanshyam Biswas, who's Senior Consultant Medical Oncology from Sparsh Healthcare, Bhubaneswar, and he will be speaking on ASCO GI 2026 outlooks. I now invite Dr. Ghanshyam Biswas to deliver his talk, please.
So good morning all. Thank you, Chairperson. Thank you, Dr. Satish. Thank you, Ranchi. So I am the opening batsman for GI malignancies, so which is very common in this part of the country, in the eastern part. So let's have a look what has been there in last 1 year. So we'll try to cover the gist of the topics in next 20 minutes, and rest can be covered in the panel discussion. So the learning objectives, because it is very difficult to keep update of ASCO, ESMO, and then the small meetings. So the new standard of cares across gastric cancers and GE junction, colorectal cancers, and hepatobiliary and pancreatic. So biomarker-driven treatment, matching therapy to molecular subtype, practice-changing phase 3 trials. There are many, but to name a few are Breakwater for BRAF mutant, CRC, then Matterhorn for curative gastric cancers, then Horizon GEA01 for HER2 positive metastatic gastric cancer, and COMET again for a colorectal cancer. So emerging targeted therapies like KRAS G12D, so which had a standing ovation this year for pancreatic cancer, which has seen probably in last 3 decades a double survival benefit. Then a new class of FGFR2 inhibitors in cholangiocarcinomas and bispecific antibodies. So future directions, ctDNA is coming in a big way in many of these tumors, to start with at least in cancers like colon. Then AI has taken place in every aspect, nook and corner.
Organizers, please see the slides are not running. Yeah, Dr. Biswas, it's there now. You can go ahead.
Yeah. So future direction, ctDNA, AI, and precision oncology flow. So top practice-changing trials in gastric cancers, there are at least 3. So one is Horizon GE01 for HER2-positive metastatic gastric and GE junction. That is a HER2 bispecific antibody, that is janditamab. Gastric Matterhorn, there is an update of EFS and OS, which is perioperative durvalumab plus plot. I'll also touch upon another newer IO, that is serplulimab for Ostrom 006, similar trial design like Matterhorn in a curative setting. Colorectal cancers, Breakwater, that is for first line BRAF V600E MCRC, and colorectal Comet. So whether only immunotherapy or immunotherapy plus chemo plus minus BEV. And pancreas, KRAS G12D studies, so early phase targeted inhibitor data, and cholangiocarcinoma, FGFR2, that is refocus, which is a next generation FGFR inhibitors. And hepatocellular, there is a negative trial, which is important, and there is also a positive trial, that is Emerald 3. So hepatocellular, that is Keynote 937. So in the colorectal cancers, so BRAF mutant and MSI high. So the first, that is BRAF, that is Breakwater update from 25, then 26. So investigational arm was encorafenib, cetuximab, and chemotherapy. So normally we used to treat this BRAF mutant before this targeted therapy with chemotherapy plus minus bevacizumab, and for a fit patients, triplet with a bevacizumab. So the Breakwater update in 26 shows that there is a higher overall response rate. So 40% versus 62, which was 1.5 times in favor of the triplet. So longer PFS, again, favor of the triplet, and also a longer OS for the first time when triplet was used along with the targeted therapy, and there was a better disease control. So this confirms that targeted therapy plus chemotherapy as the preferred first-line therapy for BRAF mutant V600E metastatic CRC. So we are moving from chemotherapy plus minus BEV, doublet or triplet, to a triplet regimen in a BRAF mutant, which constitutes around 5 to 8% of metastatic colorectal cancers. So in the era of precision, for any metastatic colorectal cancer see today, so at least they should have 5 biomarkers, which are KRAS and NRAS, that is known as ALRAS, BRAF, HER2, and MSI. So these 5 are must. After that, you can add NTRK, KRAS, G12C, and pole D also. Then comes to COMET trial. So MSI high, metastatic colorectal. So MSI high constitute 4 to 6% of again a metastatic colorectal cancers. So the keynote study 177 showed that immunotherapy has a better PFS than a chemotherapy. So now, should chemotherapy be added to immunotherapy? Now, so there was a paper recently, the meta-analysis in the lung cancer space, even for a high PD-L1, so probably, so we are moving from chemotherapy, from target immunotherapy to immunotherapy plus chemotherapy. So this was, the experimental arm was Atijo, which is an anti-PD-L1, Folfox or Capox, plus minus bevacizumab. So this was a triplet arm. Then this triplet arm, as compared to only immunotherapy, showed that so improved PFS and higher response rate when you are adding this chemotherapy to the immunotherapy in a MSI high population. Coming to gastric cancers, in a HER2 targeted, we know that so in a metastatic gastric cancers, the proximal tumors you can get at around 15 to 20% of HER2 positivity. So in a metastatic gastric cancers, besides HER2, so CPS and MMR and Claudin 18.2 in a first line becomes important. And the second one will be perioperative chemotherapy. So HER2 positive metastatic gastric cancers, since last 2 decades, we know that chemotherapy plus anti-HER2, that is trastuzumab from the TOGA trial, was the standard of treatment. So now this ASCO, we understand, so there is something beyond that. So janditamab, which is a newer drug, anti-HER2 specific bispecific, along with chemotherapy, plus minus tislelizumab. So this trial was irrespective of a PD-L1. So again, this was a 3-arm study, 1:1:1, so where tislelizumab was not mandatory versus the standard arm of trastuzumab plus chemotherapy. So this showed that the regimen containing janditamab, so whether you are with tislelizumab or not, they improved median PFS, they improved median OS and deeper response compared to only chemotherapy plus trastuzumab. And the triplet, which showed janditamab, chemotherapy, and tislelizumab also showed a OS advantage. So potential new standard of care in HER2 positive metastatic G-junction and gastric cancers. So how janditamab is different? So it is a bispecific HER2 antibody. It binds with 2 HER2 domains and increases avidity and receptor clustering. More potent receptor blockade, probably that's why more responses, and enhance immune-mediated cytotoxicity by the ADCC. So perioperative, so we have moved from anthracyclines to FLOT, and then modified FLOT, and then so D-FLOT has become a new standard because we have improved on the pathological CR, which was in the endpoint, and also event-free survival, and also OS after a long time. So improved EFS maintains surgical feasibility, no increase in operative complications. But we have seen those who have used FLOT and also D-FLOT, but post-operative, 60% patients may not be completing with chemotherapy, and that's how another presentation one there in the ASCO of serupilumab, that was Austrian 006, that showed that post-surgery, you may not give chemotherapy. So they have used in a neoadjuvant setting a different regimen from FLOT, that was SOX, with serupilumab 3 cycles, post-surgery only serupilumab for 1 year. And that shows that adjuvant therapy was completed in more than 70% of the patients, and also these trials showed improved PCR, EFS, and also an OS. So pancreatic cancer, which was probably the talk of the town, talk of the whole world, and everybody, every oncologist is being asked about this drug, but which is not in the commercial ground today because these are early phase. So for the first time in 3 decades, so KRAS, pan-KRAS inhibitors is showing a big difference in the survival for a difficult to treat disease that is pancreatic cancers. So metastatic pancreatic cancer is difficult to treat, so be it a nab-paclitaxel based gemcitabine based treatment or a FOLFIRINOX. So 50% of these patients after doing an NGS, you will find a KRAS G12D. And so the realistic therapeutic target is that, so if you target this with a pan-RAS inhibitors, which is a new class of drug, so promising disease control, manageable toxicity, need a bigger phase 3 trial. So future biomarkers in pancreatic cancers, while we have been struggling for last so many years, so KRAS, especially G12D, and DNA damage repair, which we see in around 15% of the patients, HRD, ctDNA, and organoid guided therapies. So FGFR2, so next generation inhibitors for a cholangiocarcinoma, again a difficult disease to treat. For a metastatic cholangiocarcinoma, today NGS is must, besides HER2/neu, besides IDH, so you can pick up in 3 to 5% of patients of FGFR2. So there is a drug called frugatinib. So there is a drug called frugatinib. So higher responses and longer disease control if your cholangiocarcinoma patient has an FGFR2. So that's why the molecular profiling is so important. Adjuvant pembro after curative therapy in a resectable SCC or after a local ablation. So this trial failed to show that there is a benefit of pembro. But there is another positive trial in the SCC space, that was MRL3, which was unresectable SCC, but they were fit for a loco-regional therapy like TACE. So TACE along with STRIDE, that is durvalumab and tremelimumab, showed a benefit in terms of PFS. So these are cross-cutting themes. So ctDNA, artificial intelligence, and precision oncology. So a major theme, ctDNA. So we have moved from liquid tumors to solid tumor in terms of MRD, in terms of treatment escalation and de-escalation. So the clinical application being the colon cancer surveillance, rectal cancer surveillance, early relapse detection, and adjuvant decision making, especially in stage 2 disease. So here in GI oncology, digital pathology, radiomics, and treatment predictions, and clinical trial matching. So the personalized oncology pathway, so molecular tumor board is important. So those who have not in the institute, so there are virtual based pan molecular tumor board in the country. So NGS is becoming a must. So at what length, how many markers you want? So that's a question. So liquid biopsy is gaining importance when you are asking for a repeated NGS, especially colorectal cancers. For a serial NGS on each progression is going to help you and dictate you, and that's what the adaptive treatment is. So the 5 big messages are: biomarker testing is important. So gone are those days that you see a disease, you put a biopsy needle and diagnose and start treatment, because biomarker is going to make a change. Targeted therapy is expanding, immunotherapy moving earlier, ctDNA entering into the treatment space, precision medicine is the future. So in advanced GI cancers, comprehensive molecular profiling is important. Choose targeted therapy whenever an actionable alteration exists. Look for a clinical trial in a nearby place. Use immunotherapy based on a validated biomarkers. So rebiopsy at progression, or if not possible, then liquid biopsy. Enroll into a clinical trial whenever possible. So likely guideline changing. So jandatamab based, which is a HER2 specific bispecific drug, probably will change the first line outlook of gastric cancers, HER2 positive. Triplet encorafenib, cetuximab, and chemotherapy for BRAF V600E, which has increased the responses and the survival. Wider options of perioperative like durvalumab plus FLOT, or for those patients who are not tolerating post-op chemotherapy, probably we have to look at regimen like SOX with serpilumab, like Ostrom 006, increasing incorporation of ctDNA in the colorectal cancer management, and broader use of comprehensive NGS across GI malignancy. So that's from my side. Thank you so much.
Sir, can you speak something? Thanks, Dr. Biswas. And this is for knowledge of our younger colleagues who are sitting on the back, what we have discussed about. ASCO is basically American Society of Clinical Oncology, which conducts summit every year. And this year it was held from 29th of May to 2nd June. And what is the gist they have discussed in that about the various cancers treatments of the present modality. एक्चुअली मैं हिंदी में कहूँ तो वो समिट हमारे कैंसर ट्रीटमेंट का दशा और दिशा को निर्धारित करता है. What it is coming, it is in fact they are developing in the what is in the experimental stage also. So basically what Dr. Biswas has told about the biomarkers studies, targeted and immunotherapy. So these three basic things were discussed in the summit. And now the question is open to the audience if anybody wants to, anybody wants to clarify it.
Now it will work. Yeah, can you able to hear me, sir? Sir, you have mentioned about ctDNA role in the colorectal cancer. So how much it is clinically able to make the changes or adaptability? How much ctDNA can able to use it in the clinical practice while you are having the
So first of all, it is very difficult because we are unable to have the Indian version of ctDNA because that's the cost part, and Dr. Prashant is also here. So you'd rather say, so till that time, so most of us probably will only have an academic part. For those 5% patients who can afford everything for 3.5 lakhs, 4 lakhs at a serial every 3 months or 6 months. So for stage 2 colon cancer, so there is no doubt. So there will be 30%, 40% patients who will be unnecessarily receiving chemotherapy, maybe an oxaliplatin based or a 5-FU based. For those patients, so definitely you are going to de-escalate. For those patients who had a positive ctDNA, so definitely you don't want to miss them, and these patients can go into an incurable stage. So where, so treatment escalation is going to help. As of now, probably that's the benefit in a colorectal cancer. For other cancers, so we are still on. So probably in cancers like breast also, and there are many other cancers. So it's still an experimental thing.
Okay, thank you, sir.
Please.
Any other comments? I must thank Dr. Biswas for very detailed.
I have one question.
Yeah, ma'am.
Morning, sir. So we've been talking about the success of immunotherapy a lot, and most of the times we see that all the herbal treatments are sidelined for the reason that they're not enough clinical trials that has happened and all. But especially in case of immunotherapy, I am of the understanding that if at all there are enough researches done when it comes to herbals, we are very much now going towards plant-based medicines and the benefit all these herbs have to improve your immune system and all, which basically supports your body to destroy the cancer cells. So don't you think there has to be enough, not just because they are not working enough, but because there are not enough clinical trials as far as plant-based medicines or these herbs are concerned? Don't you think that they will be further adding to the success of immunotherapy?
So there is no doubt on that. So we are talking in a Ranchi Cancer Summit, so where there are medical oncologists, surgical radiation, there are interventional radiologists. So medical science and oncology in particular is a platform where everyone should come in one place. So if I talk about the herbal medicines, they don't want to align with the allopathic medicines. Allopathic people doesn't want to align with the Ayurvedic medicines. But if you just say in your heart and heart, somebody gets a cancer in your family, so everybody vouches to that. So starting from alkaline water to an herbal medicines off or off the record, so everybody takes. So there is probably a benefit of everything you know or you don't know, but it has to be in the time of evidence-based medicine, so probably you require an evidence. And only there are platforms we have been seeing in the country, there are many XYZ people who promotes that even mammography, doing a biopsy, doing a chemotherapy is just an useless thing. So it has to be proven into, so we don't start treatment on a phase 1, phase 2 trial because there is so much buzz about pancreatic cancer using these KRAS inhibitors and everybody is asking. So many of our oncology colleagues has put on their WhatsApp status, please don't ask about the Russian vaccine. So people think the Russian vaccine of 40 patients is just in the market and you can use that patient. So same thing is with the pan-RAS inhibitors. So ultimately it has to go into 300, 500, 1,000 patients clinical trial. There are many trials in the past who had a beautiful responses in the earlier studies has failed when it was tested in a bigger cohort. Yes, Dr. Prashant?
Yeah, so I'll just make a comment. What Dr. Ghanshyam told is all correct only. The bigger problem is anyone come with the Ayurvedic medicine or herbs. There's no data. What we need to work, and I truly believe that it can make miracle, it can change the whole practice. But unless you're not going to do the experimental data, trial is far-fetched. What Dr. Ghanshyam is telling that we will go phase 1, phase 2 trials, but at least we need to do the cell-based assay. Simple cell-based assay, you show that, okay, it impacts the proliferation of the cell, colony formation, invasion. All these assays, when you settle, then you go for the animal studies. So I think there is an unmet need that all these claims, when we make about the plant, herbs, we need to do much more experimental data to move ahead. Yeah.
I think just to add, Meenakshi is a very active social worker and she is involved in cancer care and she is actively involved with us through fundings and through various support programs. And I think she is early morning, she is coming and attending this session. And we also have Dr. Sanjeeva from IIT Bombay, who is into active cancer research and recently he did a very good pamphlet on proteomics. So Dr. Sanjeeva, I would like to get your views, what this government or what Prime Minister's office thinks about this herbal treatments. Yeah. I think many in this IIT have been in forward. All the Instagram clips which you see, it all goes to his and they verify through their terms and ultimately it comes to us, the purified form, purified version, and Dr. Sanjeeva is behind all this. So he has traveled from IIT Bombay, he heads the research there. To Sanjeeva.
Thank you, Dr. Satish, and congratulations for putting together this wonderful meeting. My first visit here in Jharkhand and Ranchi, so delighted to be here. As Dr. Prashant mentioned, that we need to establish the mechanism and know how any of these plant, herbal, or even Unani medicine, many of these actually work well. For that, proteomics is one of the very important way, or metabolomics is a very important way to establish the molecular mechanism of action. So many times we take experimental projects where they have made some claim, but they would like to see the mechanism of action. Is that really intended, or just kind of many things are happening and additional information which they can obtain. So one need to really establish that, and cell-based assays followed by more molecular omics-based analysis will definitely prove and pave the path towards a clinical trial for these many formation. I think India is very rich in many of these information, and if we can really establish credential of science and mechanism, many of these can actually go to the clinical trial, which is otherwise that are being hampered as of now. Thank you.
Thank you so much. Thank you for a very enlightening session.
Satish, have you heard a doctor from Calcutta, and what he is advising is metabolically and immune correction approach to the treatment of malignancy. and he advises totally against any chemotherapy. And only he advises that it should be metabolical corrections by the means of diets and obviously some other things. So I don't know, he's running a hospital there.
Thank you.
So she's really popular and there has been success stories. We do not deny that. What I'm trying to say is that there has been adverse effect also, because most of the time maybe the method of taking these herbs uh, are not supporting your body, or maybe there are better methods to do it. I'm saying there hasn't been enough clinical trials. I see merit in these kind of herbs. India is very rich. You know, we've been talking about sea buckthorn. A lot of people come and ask me, does sea buckthorn really help? And I in turn shoot that question to Dr. Satish. And
So I'll just add to it. There is a system of collaboration, at least armed forces where I belonged. In Armed Forces Medical College, we have established a department of Ayush, and we are welcoming collaborators who are willing to collaborate. We have got an Armed Forces Oncology group where we are collaborating in such alternate and complementary system of medicines. So unfortunately, people who become popular do not want to collaborate. So here we are sitting in a collaborative manner. I'm not saying I'm a gastroenterologist, so I'm the top person or something like that. So collaboration is important, any system. Whether we researchers in basic sciences from IITs or people from alternative and complementary systems of medicine. And just going on social media does not make something correct. Making it popular does not make it correct. So we have to have a scientific bent of mind. We have to encourage our patients to have a scientific bent of mind. Please ask questions. We are willing to answer them. But please, no such social media kind of a comments. And unfortunately, what happens that such comments, if they come through us, it gets amplified even more. So I think we are running short of time. We will just invite the next set of moderators for a panel discussion on latest clinical abstracts. I have the honor to invite Dr. Animesh Agrawal, Consultant Medical Oncology from Apollo Hospital, Lucknow. Dr. Shekhar Kumar Kesri, Director and HOD Radiation Oncology, Paras HMRI, Patna. Dr. Mohit Sharma, Director and Head of Department Medical Oncology from Marengo Asia Hospital, Delhi. Dr. Nilesh Mani, Assistant Professor Radiation Oncology from AIMS, Patna, Bihar. And Dr. Mayank Shekhar from Pulse Hospital, Ranchi. He's a surgical gastroenterologist. Yeah, sure. For the next session, we also have Dr. Sandeep Kumar, Consultant Surgical Oncology from HCG Abdurazak Ansari Cancer Center, Ranchi. Dr. Abhishek Jaswal from Pulse Hospital, Ranchi. Dr. Nagarjuna from Agilus Diagnostic, Fortis Hospital, Bangalore. Dr. Selambarasan from Datar Cancer Genetics, Maharashtra. And Dr. Sushma Padmaja, Chief Scientific Officer from Medio Mixed Diagnosis and Bioresearch, Bangalore.
Good morning, everyone. So it already has been a very invigorating discussion, and we move on to a panel discussing the, I think the slides are not visible correctly. Yeah. So we move on to a panel discussing the abstracts and the data that Ghanshyam sir just touched upon, and I mean, obviously it had to be touched upon. I mean, there are entire presentations on each abstract, but we'll try over the next 30 minutes or so to actually talk about this data and see how we can implement them in practice and whether all of it is implementable in practice at all. Yeah. So a very rich panel. Okay. Television. Yeah. Well, while this is getting set up, I'll at least briefly set up how how we plan to move on with this panel. Essentially, we have four specific sites that we will be talking about: colorectal, gastric, pancreatic, and hepatocellular carcinoma. While there has been a whole lot of data that has come up in all of these sites, we'll be talking about around 7 or 8 of eight of these trials and how they impact our practice. Yeah, still only partly visible, but okay. So the first on the list will be colorectal carcinoma, and both of the trials that I will talk about are those that Ghanshyam sir has already mentioned. So that makes our job easier as we move on. But now I will need my panelists to be able to see my slides. Please, you had something? We have, that's what we're waiting for. So while we are waiting, first of all, a great shout out to Dr. Satish. Can't see him here, but excellent organization. Already has an excellent crowd so early in the day. And thank you, chairpersons, for asking us to be here. Yeah, colorectal carcinoma, the COMMIT trial, as Ghanshyam sir mentioned, it was about atezolizumab. So the use of atezolizumab for metastatic colorectal cancer in the first line. Yeah. So the use of atezolizumab in the first line for metastatic colorectal cancer, it was a 3-arm trial. So the first arm was FOLFOX-Bev, the standard of care, and the other 2 arms were a FOLFOX-Bev with atezolizumab, and the third arm was atezolizumab monotherapy. When the Keynote 177 data came out, pembrolizumab was shown to be superior to FOLFOX-Bev, so that arm was closed. 100 patients were eventually randomized, and unfortunately, it seems like atezolizumab is not helping very much. The monotherapy arm PFS is just 5 months, as against 24 months for chemo-atezo, and the OS curves we can see are frankly crisscrossing and overlapping all through. But this is disappointing, especially because other immunotherapy drugs seem to be doing well. Pembrolizumab, nivolumab, and ipi-nivo combination all have excellent overall response rates and PFS. The lowest number is 16 months, and the highest is in excess of 4 years. So, Mohit sir, would like to come to you first. So, I mean, given this data, I mean, which immunotherapy drug are you going to be using in your clinic?
For sure, checkmate HSW, Nivo plus IP.
Okay.
Very good PFS. I think crosses 50 months.
Sir.
So definitely we'll go with checkmate HSW.
Yeah, actually, I mean, it's not even not even a competition anywhere. It is by far the best.
No competition.
Yeah, yeah. But Dr. Nagarjun, I would like to your comment here. So BRAF and MSI, and I will come to why we also have the breakwater data. So BRAF and MSI, how frequently do we actually encounter these alterations? Okay. But Dr. Silabarsan, I got a very interesting point out of there. He says that MSI pehle mangte clinician, baki cheez baad mein. I can tell you in my practice, my first cheez is biopsy NGS ke liye bhejo. I want the RAS, BRAF, NTREC, everything upfront. HER2, now up to HER2 bhi chahiye mere ko. I want that as well, along with the MSI. So, what is your experience? You are working with a genomic lab.
Yeah. So as a clinical genomist, I can throw two different answers towards it. Whenever you are having BRAF mutation, actually you need a tendency towards the targeted therapy, not the immunotherapy. But now, especially colon, it's a bit of different. There is a one separate data is there. BRAF mutated versus wild type, when they tried immunotherapy, is not much difference are there. But having said that, BRAF V600E mutation, when it will come is the first question mark we need to ask. In the MMR gene, actually, if you look at the subset of that MMR gene mutated, MLH1, if it is a promoter mutation, then the next question you are going to ask is the BRAF mutation. So that is where we need to check it out whether BRAF is there or not. Most likely BRAF will come in the right side colon cancers, most likely. So you can try it out, tramatinib or encorfinib based, cetuximab based treatment combination rather than going for immunotherapy. If you are decided to go for immunotherapy, kindly ensure the MSI is high. Especially, there are two subtypes of MSI is there. MSI complex L is there, MSI complex S is there. So S complex is going to be the low response when it comes to the L complex. So the complex is nothing but the four genes are going to be there, MSH2, MSH6. That forms one complex.
Right.
And the other two forms the other complex.
Yeah.
So when it's the MSH2 and MSH6 is lost in your IHC and BRAF is there, definitely the immunotherapy is going to be respond to the thing. If that is not lost, you tend to more focus on the target.
And how frequently do we find them together? The commutations?
So MSH2, always you will go with MSH6.
I meant the MSH complex and BRAF.
Only 5 to 8% you will see most likely, or lesser than that only. It's not more commonly you will see both of them are come together.
Okay.
So 5 to 7% you will come see.
You had something to say.
So regarding the molecular biomarkers that we're talking about, there are different ways that we also identify MSI. So either you by IHC, like what Dr. Silamarasan said, and then there is also the NGS method of detecting high mutation. And what in our laboratories, finding an MSI high through NGS is rare. So that doesn't happen much. It's a very rare scenario which I would have seen in many of the reports. But like what he said, certain mutations like BRAF, they also respond well to immunotherapy. So the markers for now immunotherapy is broader. It's not only MSI, we can include other markers which have some trials, which have good response to immunotherapy, I think is being added. And MSI as a whole, in India, I think looking at it from the NGS aspect, we are finding it very less. But then there might be more in the IHC method. So there are different methods of identifying the biomarkers, and I think everything is accountable for that.
Right. Sir, one more point to add. In this BRAF or MSI mutated one, you need to check whenever you are going for immunotherapy, check it out any Wnt signaling pathway is activated or not. When I say Wnt signaling pathway, it's very difficult to explain. Or otherwise, I will say in a simple term, APC mutation or beta-catenin mutation is there. So then go for the dual immunotherapy, which is the next one is there for you. Yeah. So that will be more effective whenever Wnt signaling pathway is activated. Don't go for single agent of immunotherapy, go for dual immunotherapy. That is also well proven. Now strong literature evidence data is also available for the same thing. Okay.
As Mohit sir mentioned, the Checkmate HSW is quite frankly, it's in a league of its own. But sir, is there any patient, Mohit sir, for whom you are tempted to add chemo along with the IO to begin with? You want an initial response maybe?
See, for most of the patients, you can omit chemotherapy. But for the vast majority, it can be omitted. But for the minority, for the high-risk minority, the chemotherapy is non-negotiable. It has to be given, and those high risks may be, high tumor burden disease, right-sided tumors, BRAF mutant tumors. So in that, chemotherapy is non-negotiable. That has to be added.
Okay, so what I'm hearing is that testing is not as straightforward as we think it is. Read the report carefully, talk to your molecular biologist or molecular pathologist, and eventually when you have a final answer, you choose your therapy, immunotherapy alone is typically going to be sufficient. For the rare patient, or at least for the well-selected fit patient, chemotherapy might also be the way to go in combination with immunotherapy. But then comes the breakwater trial, and which is why I delved so much into the BRAF and MSI co-mutation, because that is actually a phenomenon. We do find it. So breakwater, of course, as Ghanshyam sir talked about, encorafenib plus cetuximab along with chemotherapy for patients with BRAF mutations. Of course, we know that BRAF mutations will render cetuximab or EGFR inhibition useless. And if we include the BRAF inhibition along with the EGFR inhibition, the effect turns out to be dramatic. We find that the PFS is much, much better, a hazard ratio of 0.5. The curves are separating early and they stay separated for a while. That was with FOLFOX. Then a cohort 3 was also enrolled later on. And we find that even with FOLFIRI, the quantum of benefit remains very, very effective. And the OS has matured for FOLFOX. Hazard ratio of 0.5 by any stretch of imagination is excellent, a doubling of median OS from 15 to 30 months. And for the cohort 3, the OS data is not yet mature, but the PFS data is just as impressive. So, Mohit sir, this is the new standard of care?
Yes, this is a new standard of care, definitely. And why should we subject the patient to toxic chemotherapy when we have a target available and we can target it, provided we do MSI also?
Of course, and that is the next question for you. So when we have the co-mutation, and because we know that BRAF and MSI high will coexist, so what are you doing? Are you using a checkpoint inhibitor or are you going breakwater?
Then checkpoint inhibitor.
Checkpoint inhibitor. I think that's the consensus across that I get a feel when I talk to others as well. That if we have co-mutations, then we go to checkpoint inhibitors, and second line maybe we can go to breakwater. An honorable mention to circulate. We do not, for paucity of time, we will not be going into the depths, but it was already briefly discussed as well. The ctDNA tumor-informed testing for adjuvant therapy of resected colon cancer. So HCC, the EMERALD-3 data. So we already know that for HCC, where the disease is not resectable, but there is good liver function, the lesion is traceable. So to speak, it is eligible for TACE, so good liver function, child A disease. These patients were randomized to receive either TACE along with immunotherapy dual, or TACE along with immunotherapy along with lenvatinib. So a fairly well-structured trial. This was the main, and the PFS is better. No surprises there. We are adding an effective immunotherapeutic drug into the first line along with TACE. You add up therapies, you are getting a good progression-free survival. And so for both, the STRIDE plus TACE and STRIDE plus Lenva plus TACE are both better than TACE alone. So, again, no surprises there. And OS data is not yet mature, but for both comparisons, OS also does seem to be trending better. However, as far as the absolute numbers are concerned, we find that addition of lenvatinib does not add much to the overall response rate, around 40% in both cases. It does not seem to add much to the PFS. Median PFS remains around 13 months in both cases. And while the OS data is not yet mature, at least numbers seem to be very, very similar. So first, coming to you, Dr. Abhishek. This regimen actually starts with immunotherapy first and then moves on to TACE. So, would you be comfortable, earlier the case has been discussed in an MDT, we have decided the lesion is eligible for TACE. Would you be comfortable sending him to me, कि डॉक्टर साहब आप पहले immunotherapy दो, फिर हम TACE करेंगे?
In the background of the EMERALD study, proves definitely the overall survival and progression-free response rate as compared to TACE alone. I would definitely go ahead with immunotherapy combined with TACE, but there should be adequate gapping, as in there should be minimum 2 days of minimum 7 days of interval between combined immunotherapy and the TACE. And if we are including lenvatinib as well in between as sandwich therapy, we need to have 2 days of interval between TACE before and after the scheduled immunotherapy.
Okay, so is there something in your mind where you think this patient should not be going for immunotherapy? You would push for it? We should go for TACE for this patient?
Not as such. It is a liver-mediated disease with preserved liver function, and the performance status is good. I think we can combine immunotherapy and TACE in view of the better response rate and survival.
Okay, but Dr. Shekhar, TACE is all the rage in the West, but in India, I think we do have much easier access and much cheaper access to SBRT, especially with Ayushman. So, What's your take here?
Yeah, Dr. Nimesh, that I don't think this is the competing with each other, SBRT versus TESS. Either I'll better to say that this is complementary to each other. What I would like to say, this SBRT has got an excellent local control. There is no doubt about it. Even the 2024 randomized control trial, RTOG 112 also has shown even that SBRT, then they have given the sorafenib systemic therapy and given the overall survival also was quite better in that as compared to systemic therapy alone. But what I feel that as compared to TESS, that as you have to select the cases, what all the cases that will give you the results with, by giving the SBRT. If anyway that there's a portal vein thrombosis, you are not going to give the test. If there's the tumor sitting on the superior surface of the liver, dome of the liver, you can't do any kind of treatment. You have to give off SBRT. So near vessels and tumor size, if tumor burden is very high, means size is quite bigger, more than 5 centimeter, you have no options, you can give. Another thing is, for the test especially, multinodular SCC is the indication. There the test you can definitely employ, but if there is the unifocal size is quite less than 5 centimeter, nearby vessels, portal vein thrombosis, SBRT is the prime indications, you can choose for it. And there are some specific indication as well. While you're bridging the liver transplant, some patients have to do hepatocellular carcinoma, there are the two mainstays of treatment. Whatever options you discuss, there is the surgical resection, either you go for the liver transplantation. And the SBRT definitely has shown that tumor progression is quite reduced once, because liver transplantation is going to be delayed, you know. The procedure is going to take time. So definitely you are going to introduce the SBRT at that particular time. TESS is also beneficial, but SBRT definitely takes the upper hand in our setup especially. And expertise must be there in the institution, and institutional practice must be followed. That is there.
One thing I would like to add that, as sir said, that only specialized cases should be taken for SBRT. And by comparing both, TESS always have a superior hand because it can be repeated. And while referring patient for SBRT, you must keep in mind that it should be, the size should be less than 5 centimeter. We can take 1 to 3 tumors. And the residual tumor volume, apart from GTV, it should be approximate 700 cc.
So, Mohit sir, OS yet to mature, PFS promising, practice changing or not?
Yes, this can be practice changing with critical caveat. Means we have to choose the patient wisely. It is definitely, what I can say is that is practice changing for the fit patients.
Right. Okay. So, if
for decades we have been dealing with, TACE, and we are relying on TACE, and we know that the patient is going to progress very soon.
Right.
Now this trial Emerald has broken the ceiling. Now we have an option of combining STRIDE with TACE with or around 30% benefit, giving 30% benefit to the patients. So then definitely it is a practice changing for fit patients.
So select your patients well, talk to your MDT, talk to your IR. If they are okay with it, they are comfortable sending the patient to start immunotherapy, but be very, very careful, because the hepatotoxicity with dual IO is the biggest challenge. So select your patients very, very carefully. Child A, ऐसा नहीं कि B7 को उठा लिया, which we sometimes do in our practice, but then those patients cannot go for TACE, because that is going to be a challenge later on. Those patients will deteriorate, that liver function can go haywire very easily. So select the patient well, but then this population can definitely go ahead for that. Yeah. Keynote 937, honorable, I'm keeping it as an honorable mention. I mean, this is reinforcing as in, for patients who have undergone definitive therapy for HCC in terms of surgery or ablative therapy, there is no role of adjuvant systemic therapy in the form of immunotherapy. Multiple trials have now shown this, and Keynote 937 is just the latest in a long line. Moving to gastric carcinoma, so Critics 2 was a phase 2 study that was also presented at ASCO. Trial design was fairly straightforward. Patients were to receive neoadjuvant either chemotherapy or total neoadjuvant therapy, so 2 cycles of chemotherapy and CTRT, or the cross regimen, so CTRT followed by surgery. And these are the numbers that they eventually were enrolled. And the at least the EFS and OS seems to be the best in the total neoadjuvant therapy arm, that is chemo followed by surgery, chemo followed by CTRT followed by surgery arm. However, this is just a phase 2 trial. There is only 1 year EFS and OS numbers. The one phase 3 study that we have in this zone is Top Gear, very, very similar trial design, and the chemotherapy was standard. So in Top Gear, most patients received FLOT, and here most patients received DOC, which is not a standard of care. So Dr. Nilesh, have you used CTRT in CS stomach?
Only very few patients, and those who has a bulky disease and not amenable for surgery. So
and after critics?
After critics, it is not a standard of care, but for such cases you can think of, because there is no overall survival advantage. But you can see that pathological complete response you can achieve it with neoadjuvant chemoradiotherapy, but it should be reserved for selected patients. Especially it is more beneficial to the site when it is located near G junction.
But yeah, please, sir.
Pre-op RT in gastric CA, especially what earlier we used to select some cases, like once 3-4 bulky tumor is there and some nodal burden is quite high, at that time to get it resectable or something, that we do use pre-op RT for, but not very often, it's very rare. Another thing is, I would like to add here in critics 2 trial, that is quite wonderful for us especially. They have given the pre-op chemoradiotherapy, and here one point is very much should be considerable. They have given the very low dose, 45 grain 25. That is quite tolerable dose. At progression-free survival is still, it's the phase 2, but progression-free survival has been really a wonderful. Even the pathological complete response, if you see, that is quite good. If you see that arms once they have used chemoradiotherapy. So that is quite wonderful trial. I think we will wait for another powerful study to come, but still that is quite wonderful and promising with the chemoradiotherapy in CS to make it operable and pathological complete response as well.
But I would like to ask the surgeons on my panel here, because at least at my institute, my surgeons really hate it when the MDT says कि पहले RT दो फिर surgery के लिए भेजना है.
So the issue is with radiation in upper GI tumors, say in the stomach, dissection is not an issue. The issue is to maintain the continuity. The main issue is the healing of the tissues. If you do anastomosis, the healing will be impaired. So say in the rectum, if you do ultra low resection or low anterior resection, we can do the diversion elastomy, so that we get the healing time. But in the upper GI, say in the stomach or in the esophagus, we don't get such type of diversion. Though we can put fracas tube for feeding, but the issue is the main healing. So say in the esophagus, in the mid esophagus, the anastomosis in the neck. So it doesn't come in the radiation field. So in the esophagus, there is not an issue. But with the stomach, I will really little bit skeptical in using pre-op RT rather than.
Dr. Mayank, similar?
I'm going with Dr. Sandeep. When we are using radiotherapy, radiations, especially in gastric areas, the issue with the surgeon is going for anastomosis. Any leak out there becomes a high output fistula, and to manage it with endoscopic means like putting a negative wound pressure, it is not of much use. I have done it. It doesn't help. It only helps when the area is very small and it is surrounded by an enclosed cavity like peritoneum and all. In a large greater sac, if it leaks, you are in soup. So the practical question which I face in my practice is that a patient is coming from a very low socio-economic status with a hemoglobin of 4 or 5, history of melena, loss of body weight. Now you are supposed to do an endoscopy, because unless and until you do an endoscopy, take a biopsy, you are not able to prove the disease. It can be a benign from CLD, it can be malignant from CS stomach. You have done the endoscopy, found a high tumor involving the incisura. There is a altered heme in the stomach. Now you have taken the biopsy, you know that this is a malignancy. With such a high load of the tumor, it will be a node positive malignancy. The problem comes that patient which is coming from remote area can only have 3 to 4 units of blood अभी बहुत हाथ पांव जोड़ने के बाद. So having a from 4 to 8 or 9 blood, उसके बाद आप क्या करोगे? Would you like to go for a resection in those patients? Because if it bleeds next time, they will not give you the time for surgeon, or you will go for neoadjuvant chemotherapy or anything sort of that. That is the practical problem which we are facing in this regard.
Right. So a lot of real world problems coming to the fore here. May I just interrupt you for a moment? Because of paucity of time, we will be closing it after this particular segment itself. So this is the last slide of this entire thing.
Yeah,
but,
yeah.
But Mohit, yeah, so this is, we'll just close it after this particular slide.
Okay, we are doing, you are doing quite well, but we are also enjoying it, but the time is the constraint, so please finish it.
We are finishing it after this. We are finishing it up. So please go on, you were saying something.
See, for the distal tumors, definitely no. That's why this trial, they've used the very good dose, 45 and 25 refractions. Previously, the modern radiotherapy dose, with the old dose schedule, definitely you are going to have such problems. But with the modern radiotherapy techniques, you have very good benefit with the plan of the such kind of, you can reduce the complications. That's why that is very feasible trial, and later on definitely is going to work with it. Absolutely. And that's why there is no severe complications, as like, and surgeons also have shown in this trial. Right. What I do remember, if anybody remembers something like that. But whatever the trial data and result on inference is definitely showing in favor of sequential chemoradiotherapy after induction.
That is why we have tumor boards and panel discussions.
Correct. Thank you.
So that these arguments can happen in real time. This is how we do well for our patients. But final comments from you, sir, because frankly, personally, I am a bit skittish about this study. The chemo was not standard of care. There was no perioperative immunotherapy. So, Mohit sir, what about your opinion here?
So you asking me, are you happy with the control arm?
Yes, because I mean, your opinion here, sir.
See, if you ask me, am I happy with the with the current study design control arm, because in this 2026 immunotherapy era, then definitely answer will be no. But if you ask me, am I happy with the control arm, considering the foundation that this has laid, the total new adjuvant therapy study design, then definitely the answer would be yes.
Okay. So the answer is a qualified. This may possibly be practice changing, but possibly we need phase 3 data. In the interest of time, we will just say thank you.
Thank you, Animes. There was a good panel discussions, and we also liked and enjoyed it. So my and audience, I think one question will be pertinent. So what ASCO conference or summit 2026 had given direction about, are we following it already, or we are still doing our own way?
So sir, for most things, we actually wait for the actual agency approvals before we incorporate it into practice. Unless, for example, if it's the American data, first the US FDA must approve it, and then it should be approved by the Indian regulators, drug regulators.
Yeah, that I know, because though I am a surgeon, but I was director of a Tata Cancer Hospital over here.
Sir.
And during my time, a high-profile officer was admitted of government side, and we had to import KRAS inhibitors for him. And that was few years back. And still it's not available with us, isn't it?
So KRAS inhibitors, sir, some of them have become available.
You mean DGA approved?
So not
no, that's why. It is CDSO improved. This improvement is still not there.
Sir.
So what is the roadblock for that?
So the KRAS data, at least in colorectal and in lung, it's not very impressive so far. It is, in fact,
that was for pancreatic cancer.
So
in fact,
the whole reason the pancreatic data is so exciting for everybody is this is the first time we are getting such a magnitude of benefit. Doubling of OS is unheard of in the KRAS.
Okay.
Yes,
So thanks a lot for, we'd like to hear more during our lunch breaks
Sure,
from
sir.
you all of you. Thanks a lot, please. Thank you.
Thank you. Thanks, Dr. Satish, for organizing such a huge program. And it is going twice in a year. Definitely, it is a great thing that we all come together and definitely enjoying the extravaganza of the educations. It is a sponsored program. Thank you, the sponsors, for providing the opportunity of saying the redefining outcome of the bladder cancer, the evaluation of the PAD-safe in the first-line therapy in the locally advanced or metastatic urinary bladder carcinoma. 1L is the first-line therapy for that. This is a disclaimer. Definitely we have to go because there is no conflict of interest of saying there's results. It is an open-label randomized phase 3 study of the EV, enfortumab vedotin. Kindly keep in mind, we'll say the EV in most of the time, in combinations with the Keytruda or pembrolizumab versus chemotherapy, commonly gemcitabine, in previously untreated naive, chemo-naive patients of the locally advanced or metastatic urothelial carcinoma. Urothelial carcinoma, we know for the long years of that, urothelial metastatic carcinoma, glioblastoma multiforme, these are the various carcinomas. We don't having much of the treatment options that much. So getting a new medicine or new pharmaceutical agents definitely add a boost on that. This is the study design of the EV302 design. The patient population was done. I'm not going through. You can see this is previously untreated or the chemo-naive patients of the metastatic urothelial carcinoma. With the eligibility for the platinum is there, and EV and P. EV means this medicine, and enfortumab vedotin, and the P for the pembrolizumab. Though PDL1 or the inhibitor-naive patients, definitely the glomerular filtration rate should be more than 30 ml per minute for the good kidney functions. And ECOG score or the Jubrod score should be less than 2 because the patient should be ambulatory and having the good health status. We have divided bifurcated it in the 886 patients to the EV plus pembrolizumab, and no maximum treatment cycles for the EV definitely, and maximum 35 cycles for the Keytruda is provided. The treatment until the disease progression is considered in case of the blinded central review data, and the clinical progression and unacceptable toxicity as per as the investigator's choice is when the completion of the maximum cycle is being considered. Now the chemotherapy on the other hand is being provided, definitely the cisplatin eligible patient or the platinum eligible patients is cisplatin along with the gemcitabine, and maximum 8 cycles to be given on the day 1, day 8 basis. The primary endpoints is the dual primary endpoints, most commonly the progression-free survival. You are giving the chemotherapy, no progression of the disease or the good response is being considered as per as the BICR, and overall survival is also considered in the dual primary endpoint. Definitely in the secondary endpoints, we have the RECIST criteria, the overall response rate, and definitely investigator assessment, safety, toxicity, adverse effect is being considered. EV302 is already you have said, it is a phase 3 study, open label study, and done in the multiple locations. And stratification factor include the cisplatin eligibility, eligible or ineligible, the nephrologically most commonly, PDL1 expressions, high or low, and hepatic metastasis. Later we'll discuss that PD1 is not that much important in this case. Cisplatin eligibility and assignment, dosing of the cisplatin versus carboplatin protocol defined. Patient received 3 cycles of the 3-week cycles of the EV, 1.25 milligram per kg, commonly 100 milligram is being given, and day 1, day 8 is being provided, and definitely Keytruda without any dose modifications by the weight or the body surface area, it is 200 milligram on the day 1 is being provided in this case. Now the key demographic and the baseline disease characteristic, we are having this more or less as a maximum number of the patient was the male patients, having the most of 77%. I'm not going in the tidbits of the things. You can easily see. This is the geographic locations of the mostly in the American, European, and Scandinavian country, and the rest of the world is being taken. But most commonly it is in the European data, having this 38 or 44% of this inclusions of that. Summary of the dispositions is 30% of the patients having this PET-safe and Keytruda arm remain on the treatment at the time of the analysis, and patient recruitment was done accordingly. Mostly 1.8% patients have completed the response, and the disease was progressive. In the EV plus B data was 34.5%, which is alarming, and 16% for the chemotherapy. Though the risk of the progressions or the death was reduced by the 55% who received the this PET-safe and Keytruda, And definitely this curve is being showing there's improvement of the data. Data is being showing that the near about the improvement of the overall response rate and the risk of the progressions. Subgroup analysis was done as per the progression-free survival as per the BICR. PFS benefit in selected pre-specified subgroup was consistent with the result of the overall populations. We can see from this chart that the favors that the good response and the good safety profile with the EV plus P compared to the chemotherapy. We all know that chemotherapy having nephrotoxicity, and definitely gemcitabine having typical thrombocytopenic related events. Overall survival, the risk of the death when you are giving this kind of highly costly, this kind of the anti-nectin therapy along with the anti-PD-1, the risk of the death was reduced by 53% in the patient who received EV plus P rather than the chemotherapeutic agents. Definitely it is a small data, small sample size data, but we have to be, not to be generalized, but we have to consider that definitely the EV plus P is a more or less safer. Subgroup analysis was done as far as this is the cisplatin eligible or ineligible, hepatic metastasis, visceral metastasis, or the primary site of the origin in the upper tract of this kind of the involvement. These all show more or less in compared to the chemotherapy, the survival benefit, overall survival, these are the better. Definitely, I was saying in front before that whenever there is a PD-1 positivity or the CPS score we do, we have a chance of the probability of the more responsiveness to the therapy of the various immunotherapy or IO agents. But in this kind of the cases, we have seen that PD-L1 high or PD-L1 low combined positive score is being the more than 10 or less. It is showing a good result and survival benefit is not affected that much. Now the pan-Asia subgroup and long-term follow-up was also done, and all show more or less as a good data of the good overall survival with the EV plus P. Definitely it is a costly therapy, cannot be affordable by the each and every patient. Overall survival and progression-free survival across the subgroup with the diabetes or progression-free survival patient with diabetes patients, overall and progression-free survival shows a good things, because at the age, most commonly urinary bladder carcinoma, you will find it is not occurring in a very early stage. It most commonly occurs in near about 50 years above. So definitely the comorbidities including the diabetes and the other metabolic syndromes will be present. So it is a very risk factors. But definitely we are having a spike of the hyperglycemia in some of the cases when we are starting the EV. We are seeing that if the glomerular filtration rate is less than 60, with the baseline or glomerular filtration rate is less than 60, and whatever the baseline, the overall survival and progression-free survival is showing a good results, and definitely less than 30 we don't consider. Subgroup analysis was done. The confirmed overall response rate as far as the blinded interval central review, we are seeing that EV plus P having the complete response in almost 29% of the patients and partial response in 38 or 40% of the patients compared to the chemotherapy. What is the meaning of that? You started the chemotherapy or you started the immunotherapy EV plus P, and then you see the mass which was existing or the metastasis which was having as far as the response evaluation criteria in solid tumor showing a good response, reduction of the mass, and as far as the RECIST criteria, it is showing abolitions of the mass, it is a complete response, partial response, very good partial response. These are better in case of the immunotherapy and anti-nectin therapy is being provided. Duration of response by the BRCR in responders who show that you are having a tumor which has recurrence or initially, which is having the disease, and after that you start the chemotherapy or immunotherapy, and the response durations, maintenance of the CR or PR, once it achieves the complete response, the maintenance of this is being better with EV plus P. Duration of the response by the cisplatin eligibility is being also tried on this. So patients with the complete response or partial response, in case of the enfortumab along with the Keytruda, showing the maintenance of the complete response or partial response. We should note that partial response initially occurs, then after the complete response, and this all can be maintained with the chemotherapy also at the cost of the toxicity, which is the main important thing. Time to response and conversion from partial to complete response. Median time of the objective response was 2 months near about with the EV plus P chemotherapy, and it was 4.3 even for the complete response of the therapy. There is a kind of the twist is there, I will later explain. In the EV plus P, the chemotherapy arms, we are seeing that near about the response evaluation set was increased, and in patients achieving complete response initially, experiencing partial response, the rate is 88 out of the 133 patients. So median time from the first PR to CR was 4.5 months with EV plus P and 6.1 months in chemotherapy. So median time to objective response was similar in case of the chemotherapy and EV plus P arm. Most patients achieve PR, then achieve the complete response. Duration of the response is being also explained in this curve. You can see the probability of maintained complete response after 2 years of the first documentations was 74.3 in case of the EV plus P compared to the 40% in case of the chemotherapy. What is the meaning of that? If you are having a metastatic urinary bladder cancer, if the patient is affordable, you started the immunotherapy and you started the chemotherapy. In case of the chemotherapy, the maintenance of this complete response, good patients, your patient is showing and coming to you in a regular basis and saying that I am good, not having any recurrence, is more or less 40% if you give the chemotherapy and near about 75% if you give the EV plus P, but the pocket is important. The cost of the treatment is very important, and we have to discuss after that. Now the overall survival in patient achieving the complete response. If the patient, you are having the chemotherapy cancer, which is having the metastatic or locally advanced, whatever it be, you are giving the EV plus P immunotherapy, the overall survival is improved after achieving the complete response. You should understand the things. You are having the patient, the disease is gone, but patient is also gone. That is not the case. The patient is alive and the disease is gone. The summary of the subsequent systemic therapy. 59% patients with the chemotherapy arm receive subsequent PD-1 and L1 inhibitor, and this is very common in our countries or in outside also. We started with the chemotherapy initially. As long as patient got the confidence and the toxicity is hampering, the patient is getting your treatment confidence and toxicity is hampering, you can then discuss about these continuations with the help of the PAP and various kind of the patient assistant program. You can convert from the chemotherapy good response to the immunotherapy or in the increase in the size also. Treatment related adverse effect, very importantly, when your medical representative comes to you and also from the studies, they will say if you giving the EV, sir, the rashes will be there. Skin rashes, because we are new exposed to this medicine. So skin rashes is very common. Commonly, enfortumab vedotin, if you give, does not cause any kind of the reactions or like that. We also avoid giving steroids before any kind of the checkpoint inhibitors or IO because of the masking. And in case of the Keytruda, if you are giving for the 35 cycles or whatever it be, after 4 to 5 cycles or 4 to 6 months, you can develop some kind of the pneumonitis kind of the things. So it is for the Keytruda, which is P, and EV for you are having a rashes, which also can be controllable. More frequent, the treatment related adverse effect, TRAE. I always ask them to not to use the short term for the all of us. TRAE is a treatment related adverse effect, most frequently is being occurring, and overall it is acceptable toxicity. Bridging the trial to the real practice, this is the last slides, that EV plus P show a tolerable safety profile. It is a good medicine, easy medicine, not that much your body surface area dependent, nothing like that, and it is a very careful initial monitoring is important. Real world patient consideration is very important. As we have said, we have to consider comorbidities in case of the older age, higher disease comorbidities, impaired renal function, definitely diabetes, kidney, these are the considerations, and it needs a lesser hydrations like cisplatin. So it is more or less in case of the, it is good for the cardiac also, and hepatic and renal function should be considered. The emphasis should be important that we should monitor properly the system recognitions. Effective adverse effect must be reduced, and whenever you are giving this, in the zeal of giving costly medicine, you should also consider that immunotherapy also can cause various kind of the complications. So then you should be answerable, counsel properly, because your patient sometimes feels so much of the distress because of the investing so much of the money and not getting that kind of the result. So you have to be very much competent on that. Adverse effect of the special interest, skin reactions in case of the EV, and definitely adverse effect of the special interest pembrolizumab, we are having the various thyroid related alterations, hyperlipidemia, this should be considered, and definitely immune mediated or ALI, ARDS should also be considered in case of the adverse effects. Onset of the selected adverse effect, definitely we are not going in the details, more or less when you are combining enfortumab along with the pembrolizumab, you should consider three things. Hyperglycemia, because most of the patient in the age is higher, is having the male patients mostly having the diabetes. Second, you should consider the pneumonitis, skin reactions, these should be considered, and peripheral neuropathy. These all are more or less individualized. Then if the patient is having peripheral neuropathy of the grade 2, grade 3, having the severe tingling sensation, most commonly sensory, does not affect the motor to some extent, so then we must be cautious of the things. These are the current guidelines. It's not possible for say, most commonly if the patient is treatment, in the case of the treated for the naive advanced patients, we can start with the enfortumab vedotin. Along with that, disease progression if there, we can consider of the chemotherapeutic agents. Now the chemotherapeutic agents and the newer drugs is also coming. That is the fibroside growth factor inhibitor. The lots of the other drugs are also coming. On the time with the greater applications to the community, we can understand the result. Thank you. These are the their abbreviated versions of that. Thanks to the organizers and thank you all for providing this opportunity and Astellas also. Thank you.
Thank you, Dr. Kundu, for such a wonderful presentation. But as a nephrologist, I always concern about renal drug toxicity. So do you have any change in approach regarding treatment of bladder cancer in kidney patients, CKD patients? And how do you counsel these patients regarding drug toxicity, if unavoidable?
The main problem is that, sir, the if the kidney patients, bladder patients most commonly comes with urinary tract obstructions. Kidney patient commonly does not comes with a kidney malignancy, does not come with that. Bladder cancer comes with that. If the patient is already emaciated, everything is being, most commonly patient comes with a very in a poor nutrition state. In that case, we must consider only one thing, that kidney function should be preserved. So first is that outlet obstruction should be relieved, first and foremost. We can put for the digest stenting, we can go for the PCN placement, and creatinine when subside with the improvement of the function, creatinine clearance is being improved, then only we can think of giving anything first. And it is not the only medicine we can give. Dr. Aftab will admit with me, for the long we are giving the various other medicine also, which is a cheap, and also cisplatin is the most nephrotoxic drug along the things. But other medicine can also be given if the patient is doing good. So these are the approach, sir, individualized approach we should do. And most important is that ureteric orifice should be open. Because urethra is closed, because we can remove that, but ureteric orifice should be open, and PCN, digest stenting, everything should be done first. Then only we can consider this. It is not that creatinine is 6 and we are starting it. It is not possible.
And what about CKD patients? Suppose a patient with bladder cancer has creatinine level 2. So what how you will counsel him regarding toxicity?
So regarding the CKD patients, we definitely, if the patient is having the more than 2, or like that patient is already having the symptoms, we don't give anything. We try to give only single agent gemcitabine sometimes, or like that. Because of the hydration, you should give with the various kind of the platinum chemotherapeutic agents. So we cannot give the hydration that much. On regarding this, we don't have the data when the creatinine clearance is not that good, we are giving that. They are also saying that creatinine clearance is more than 60, you go for that. But creatinine is more than less than 30, they are not included even. They have not even included this, those patients. So that's why we should consider first is that the patient having the good metabolic functions. After that, we will do anything. Definitely, one thing I just like to say, in case when there is a kind of the obstructions we are thinking, and it is locally advanced, in case of the urinary bladder, we sometimes in our professor also did it like that, we do the kind of the bypass of the urine. so that for the few days at least patient will having a kind of the palliative approach on that. Then we can, at least the urine should be excreted. So that is the approach on that. Thank you.
So thank you, Dr. Kundu, for finishing on time.
Thank you.
And since we are running behind the schedule, so we won't take any further question. So we are, sure. Thank you. So we will be moving to next sponsored session on renal cell carcinoma. For this, I would like to invite Dr. Abhishek Anand, Director and HOD, Medical Oncology, Paras HMRI, Patna. Dr. Abhishek.
Chairperson, for chairing the session. Moving forward, I would like to invite the chairpersons, Dr. Satish Midha from Ranchi, Dr. Anand Sinha from Ranchi, Dr. V.K. Jain from Ranchi, Dr. Akansha Sinha from Ranchi, Dr. Rajiv Bhandari from Ranchi, and Dr. Sweta Sinha Verma from Ranchi to chair the sessions.
Good afternoon, everybody. We have a slight change in program. Dr. Shailesh is yet to arrive, so we'll go on to the next one, Dr. Prashant Kumar Agarwal. He is a PhD from Max Planck Institute, Chief Scientific Officer, Data Center, Genetics, and Director of Scientific Affairs and Partnerships. Can we invite him on stage, please? Hello, and the topic is what's the buzz, the new biomarkers in MNSCLC.
Hi, good afternoon, everyone. First of all, thanks to Dr. Satish for organizing. I think it's the second version of the meeting at Ranchi. And I would say that the ecosystem has been created where I could see a lot of interactions and a lot of good topics have been discussed. A very interesting area is where he asked me to speak, what's the buzz, new biomarker in metastatic non-small cell lung cancer. So lung cancer management, and I think this is historically, if you see the lung cancer, we are very lucky to deal because there are multiple driver mutations you identify in lung cancer. And especially in adenocarcinoma compared to squamous cell carcinoma. So 1912, you imagine that lung cancer, first case was reported. And moving forward, 1933, where the lung cancer was treated with pneumoctomy successfully. 1948, lung cancer was treated based on the chemotherapy. And 1950, where you see that the lung cancer was associated with the cigarette smoking. So before that, we had no idea that the cigarette or the smoking caused lung cancer. Moving forward, 1965, lung cancer was treated with radiotherapy. 1970s, lung cancer was detected by CT screening or scans. 1991, the role of adjuvant chemotherapy in treating non-small cell lung cancer. 1996, platinum doublet therapy. 2003, TKI targeting EGFR. And I think that is where the paradigm shift when we understood that the TKI is something which could treat many of those lung cancer where non-small cell lung cancer and precision medicine also got introduced during this era. 2006, where the monoclonal antibody targeting angiogenesis, 2050 ICI and PD-L1 blockage, 2016 artificial intelligence we started discussing. But if you see that the lung cancer, and we are in the era of next generation sequencing and multi-omics, there are three different bigger domains. One, which is radiomics, where you see all the automated detection, tumor segmentation, and you would see the thousands and thousands of scans. And we try to understand that how does this scan make sense. Pathomics we call, and pathomics name, it's coming from pathology. So you have again the whole pathology of the slides, and based on that you can do automated detection, tumor classification, grading, and cellular and tissue structure analysis. When we talk about the biolomics, and I made it very big term, biolomics means multi-omics, where all the biology of the tumor would understand. And this would include the genomics, epigenome, transcriptomics, proteomics, metabolomics. All these three different broader domain leads to make us understand the biology of the disease much deeper, much better. And liquid biopsy, we are in the era of liquid biopsy. And each of these segments actually giving us and empowering us to understand the liquid biopsy and how liquid biopsy is making the changes in the clinical practice. So now, if you see the common site of metastasis in the non-small cell lung cancer, bone, which is coming much more compared to any other, but 22.3%, bone, then move to lung, which is 20%, brain 15, liver 6, and multiple different organ. Aggregately, it will be 36.1%. So patient with the EGFR metastatic non-small cell lung cancer have approx twice the risk of CNS metastasis compared to the patient with EGFR wild type. Now, clinical burden and molecular profile, if you see, 5-year relative survival, if you see, it's a 67% localized, 40% regional, and 12% distant metastasis. What is very interesting that the metastatic non-small cell lung cancer, non-squamous, what we could identify almost more than 60% of the patient have oncogenic driver mutation. And this is a very good number that we could identify more than 60% of the patient. And this is also giving us an idea that out of 2 patients, you would identify a oncogenic mutation or targetable mutation, regardless of PD-L1 expression. Now, multiple approved drug in the advanced non-small cell lung cancer. I think this is the only cancer where you would see multiple targets have been identified, starting from MET, KRAS, RET, NTERK, BRAF, ROS, ALK. And again, if you see the journey, when we started learning in the year 2005-6, it was erlotinib, gefitinib, and then we understood the resistance mechanism, we entered to osimertinib. But EGFR, this is all targeting EGFR mutation. Moving forward, we understood, or we learned novel mutation, new mutation in lung cancer, EGFR ALK, ROS, BRAF, and NTERK, and multiple, at least 9 to 10 different mutations by 2023, which we learned, we identified, which could be targetable, and multiple drugs have been approved. So the clinical mandate is very, very clear. The test, no, and you first test it, and then you go for the treatment. And this is what the NCCN recommendation is, that you first do the testing, you confirm the testing, and based on the confirmation, you go for the treatment. Now, EGFR, I'm talking, and most of the clinicians who are treating with the lung cancer, they know EGFR is a panacea. But coming about not the common mutation, the classical mutation, there are many non-classical or rare mutations, and which you could see 10 to 15% uncommon mutation, other than exon 19 deletion, exon 20 insertion, and L85R insertion. So there are mutations, and these mutations you could see that other mutation which almost 28.22%, and these are L861X, and there are multiple S7681, G719X, and compound mutations also. So this was one of the case study which we published with Dr. Kumar Pravas, and this was the rare compound mutation identified, which was EGFR L858R, and the very, very rare mutation identified both from the tissue and the blood, which is E709A. And this is just, you could see the tumor, and in the arrow you could see that the tumor has progressed over the time, and this is the 42-year-old female with aggressive thoracic therapy, and the baseline was presenting no treatment administered. The patient had been given, so a scan was given, and then they found, based on the NGS, we identified these compound mutations, and again the patient had been given pemetrexed, carboplatin, and gefitinib. And on the follow-up, patient is surviving currently. And this is just showing you that the mutation, and this mutation you could see both from the solid and liquid, and we identified both this compound mutation from the tissue as well as liquid from the blood. And also we did the Sanger sequencing, which verified that these mutations were present, and C-Bioporter data revealed only 8 patients with EGFR E709A mutation, with none showing co-occurrence of EGFR L85R. So response rate, now this is a very interesting slide, that when we talk about the response rate of common and uncommon EGFR mutations, you would see that the first generation TKIs, there are some of those mutations, those are the rare mutations I'm talking, where the response rate were very good. Just pick E719X, where the response rate was 39%. When TKI second generation came, the response rate increased from 39 to 56%. But in the third generation, the response rate decreased from 39 to 56% to 33%. Another mutation, I will just pick an example, E709X, where first generation TKI, there was no response. Second generation TKI, there was better response. But the third generation TKI had much better response than the first generation. So this is the journey where when we develop any TKI, it's a drug developed, depending on the systematic of the compound where it fits, depending on where the pockets these compounds go and fit, the response to those drug varies. So this is one of the trial, FLORA-2. You would see that it has been given a newly diagnosed patient with the locally advanced metastatic EGFR, metastatic where exon 19 deletion or L85R. And you could see that the randomized trial where N was 1:1 ratio, and patient have been treated, and the disease progression or unacceptable toxicity was considered. And you could see that the median overall survival, which was 47.5%, has actually improved, and later when we compare from 37.6%. So these are the trials which have been done, and where it shows that the overall survival and have the patient where the poor prognostic factor treated with the osimertinib, which is the targeted therapy, plus the chemotherapy, which is platinum-based pemetrexed. Now I'm going to touch base on the newer biomarker, because we are trying to touch base that what are the novel biomarkers which have been studied recently. And NRG fusions, which was known and which are known maybe 1% or less than 1%, it has emerged as a predictive biomarker in non-small cell lung cancer. So what you see that NRG, which actually goes and bind to the HER3. So HER3 domain, this NRG goes and binds. After it binds to the domain, you can receptors, what it does, it dimerizes HER2 and HER3. And because of this dimerization, there is activation of further downstream PIK3-AKT pathway. And PIK3-AKT pathway will lead to the cell proliferation. So there is a drug now which actually block, and this is, you can see the dimeric antibody which binds one arm, which is binding to HER2, and other one which is binding to HER3. And this binding which leads to the complete abrogation of the signal transduction pathway. And what you would see to the right side, that this has been already, the trial has been done, and overall survival has improved. Across the tumor type, it is 30%. Median survival is 6.8 months. Non-small cell lung cancer, 29%, and pancreatic cancer, 42%. Again, if you see the other NRG fusions in different solid tumors, there are multiple clinical trials and trials status you could see, which is against anti-HER3, and another one is pan-ERBB2 inhibitor. This is another, so again, NRG trial, we call it, and this is where the trial where NRG fusion positive non-small cell lung cancer, what you would see that the FDA actually granted, this was the accelerated FDA approval for this drug for non-small cell lung cancer and pancreatic adenocarcinoma. And the results very beautifully, it shows that some of the patient, it responded very, very well. And the other where you could see to the right side, when we compared to the treatment naive patient versus the previously treated patient, again the response rates varies, and you would see that the overall survival, which was quite high compared to the previously treated ones. So the clinical benefit rate reached almost 65%, defined as complete response, partial response, or a stable disease lasting for at least 24 weeks. Now, when we talk about the emerging biomarkers associated with the primary resistance to targeted therapy, we understood that many times we look for coexisting mutation. Why and how does it make sense? Whenever PIK3 mutation come with the EGFR mutation, we know that they are negative prognostic value for the response to EGFR TKI. Again, KIP mutation with the KRAS mutation coming together, negative predictive value, again with the KRAS inhibitor treatment. CDKN1 mutation with the KRAS mutation, negative predictive value for response to KRAS.
And there are multiple RB1 mutation again with the T53 mutation. This has a better prognostic value for later neuroendocrine transdifferentiation of the tumor. There are another set of biomarkers which are associated with the primary resistance to non-targeted therapy. And these are non-targeted, the bottom ones. Something like STK11 mutation. When you find a patient with the STK11, it means it's a negative predictive value to the response to immunotherapy. KIP mutation coming, just one mutation of KIP1 coming in the patient, NGS, it again shows the negative predictive value for response to immunotherapy. EGFR driver mutation, all of us know that it has a negative predictive value to the immunotherapy. So there are multiple such studies which give us eventually a very clear picture that why the dual mutation versus a single mutation and which of the drug is going to respond for those mutations which may not work. I will just touch base to ADCs. I think we are in the era of ADCs, and ADCs are working very comparatively very good in breast cancer and now in lung cancer also. So what are the ADCs? The structure you could see is an antibody. So antibody has FAB, which is called fragment antibody binding, where it binds to the antigen. So which is called FAB. FC is the lower domain or lower where the antibodies have interacted and binding to the many of those I think the molecule neutrophils or macrophages. So FAB and FC, these are the domain. So now ADCs have been developed which are targeted. So antibodies, FAB can go and bind to any such protein which are overexpressed on the cancer cells. What we do that we put this cytotoxic drug with the linker here. And this is where it has much more dose. The dose of the drugs are much higher compared to any chemotherapeutic drug we administer. So this antibody drug conjugate you could see with the linker, and there are multiple FAB antibody drug conjugate have been developed for HER2, EGFR, for PSMA, VEGFR2, collagen 4, and multiple such tissue factors have been developed. The way it works, the overview you could see, this internalize, when it internalize, it actually get dissociated, all the drug molecule, and this drug molecule is targeting directly to the tumor cells. It not only directly talking and killing to the tumor cells, but also tumor microenvironment. Many times it kills to the VEGF and the angiogenesis process. So there are multiple ADCs in lung cancer which are in trial. For HER2 targeting ADCs, there are TROP2 targeting ADCs, HER3 targeting ADCs, and MET targeting ADCs. And what you could see in different sections, these are the trials which are mentioned. So I'll give you some of the extraordinary example where we got a very progressive results using the ADCs. HER2 targeted ADCs, which is trastuzumab, deruxtecan. So this is a humanized anti-HER2 IgG1 monoclonal antibody with same amino acid sequence as trastuzumab. It's the same amino acid sequence is same, and what you could see that there is a linker where the drug had been attached, and this is well called tetrapeptide based cleavable linker. So it could be cleaved. These linkers can cleave once it reaches to the tumor molecule, the tumor site, it is getting cleaved, and then the drug is very effective to killing the tumor. And again, you could see the dose is antibody ratio 8 and a stable linker and tumor selectable cleavable linker depending on what tumor you are going to target, and it has a high potency, membrane permeable. So these ADCs are developed that it can enter in the membrane very easily. And again, the payload, what the term you have heard, payload. You can keep hearing this term payload. Payload means a linker where the drug has been bound, which is we call payload. Now this is the trial, what you could see, HER2 mutant non-small cell lung cancer, 91 patient, adult with metastatic HER2 mutant non-small cell lung cancer refractory to the standard treatment. So those patients were refractory, and here you could see to the right side trastuzumab linker TROP1 inhibitor has been added, and you could see the confirmed objective response was 55%, duration of response was 9.3 months, progression-free survival 8.2 months, and overall survival 17.8 months. So another antibody drug conjugate targeting TROP2, and TROP2 is a membrane protein which is overexpressed. You could see TROP2 to the right side, and again there is a drug which has been developed. These are the again the payload. Multiple payload has been added to the linkers with the different site of the antibodies. What it does, it binds to the top 2 membrane protein and then it internalizes. Once it internalizes, it gets acidification on the endosomal cleavage linker, and then there is the payload which goes to the tumor. But what it does is it actually stops the topoisomerase activity. And topoisomerase activity is very important because it is not allowing for the DNA to repair. So it damages the DNA. There is apoptosis. And this is where such ADCs, you could see this result from EVOKE-02 first line SC and pembrolizumab by the PD-L1. And again, this is showing that PD-L1 TPS more than or equal to 50% compared to PD-L1 TPS less than 50%. Of course, where the TPS is higher, more than 50%, have far better response than those patients where the TPS was less than 50%. FDA again granted this accelerated approval of telisotuzumab for non-small cell lung cancer with high c-Met protein overexpression. And again, I am talking about any such protein which are overexpressed on the tumor cells, we target those. And this is when the liquid cancer, you keep hearing about the CAR T cells, where the CD19, which are prevalently present on the B cells, those are the cells which you target. So we are looking for many such expressed molecule which could be targeted, and c-Met is one such example where you could see the ADCs produced. Again, there is a linker, there is a cleavable valine linker is there, and this is how it internalizes. What it does here is it is not going and interfering with the topoisomerase, but it is interfering with the microtubule disruption. And where there is a microtubule disruption, it will block the cell cycle. So cell will not divide. So these are some of the very novel concept, and you would see that this particular drug, which is monotherapy in patient and with previously treated c-Met protein overexpressed, non-squamous, EGFR wild type, advanced non-small cell lung cancer. This is a trial called Luminosity and a phase 2 multi-center non-randomized patient 168, non-squamous, and outcome you could see that they have to the right side down, you could see that c-Met overexpression, there is a high overall response and intermediate, and total there is 29%, 29.2% compared to the prior studies, or the median duration of the response 7.2 months. So this data highly supports the use of teliso monotherapy as a second line and beyond treatment in patients with c-Met overexpression, non-squamous EGFR wild type. I'll quickly touch base, 2 more minutes. PD-L1 status, we're talking about the PD-L1 status, and it is a golden standard for us to pick those patients who can be given the immunotherapy. And you would see this graph that by year 2015, 2016, suddenly there's a high peak of the PD-L1 because we were not testing PD-L1 earlier 2015, 2016, and suddenly we understood the importance of PD-L1 expression, and the growth of the curve suddenly from 2017, 2018 moved much forward. However, there are complications with the intratumor heterogeneity, difference in the PD-L1 staining, import of the treatment, and intratumor heterogeneity too. However, beyond PD-L1 marker, there are another markers, which is TMB, tumor mutation burden, and MSI high. And you could see that once you consider not only the PD-L1, when you also consider the TMB and MSI high, you could see the right side, the patient's survival. So this is PFS has increased from those patients where only we are going ahead with the PD-L1. So STK11, I was mentioning that some of the rare mutations, some of those mutations which are only predicting that the patient may not respond to the immunotherapy. This is another good example, STK11 mutation in PD-L1 inhibitor, which are resistant to KRAS mutation in lung adenocarcinoma. KEAP1 co-mutation, negative predictor. This is another good example when STK11, KEAP1 are adverse predictors for ICI therapy. So some of those mutations we can know that, okay, these patients are going to respond to immunotherapy. KEAP1 STK11 alteration enhanced the vulnerability of ATR inhibition. This was published in Nature Medicine, and this again shows that how the biomarker directed targeted therapy plus durvalumab in advanced non-small cell lung cancer, a phase 2 umbrella trial. So just
touch base the blood-based immune biomarker, because we talk liquid biopsy and lung cancer. We are practicing liquid biopsy very often. So advanced non-small cell lung cancer, baseline peripheral blood, and integrated blood omics. And immunomics, I think we are in the era of immunomics when we talk about the immune program associated with the benefit, where you could identify T-cell activation, non-classical immunocyte. You can see the CXCR3 and TIM3 expression. The dawn, you could see that immune progress associated with the with the resistance. And where there is a CTL4 expression, this is very important, that we should not only look for the PDL1, we should look for other immune cells also. So this is beautiful example where CTLA4 expression also checked for those patients only where PDL1 expression was checked. And this gives us an idea about the circulating biomarker. It could be ctDNA, it could be exosome, it could be circulating tumor cells, and each of these biomarkers would give you different kind of answer, starting from the mutation, methylation, or microRNA, or also about the cell chemoresistance, especially with the circulating tumor cells. This was the paper we recently published. This is liquid biopsy, a pivotal test to help navigate clinical decisions at the precision center in India, and ctDNA clearance would help us to understand escalation and de-escalation of the treatment. So the future is very comprehensive when we talk about that. So many biomarkers evolved. Last 5 years, if you see recently, we identify many of the novel mutations, novel fusions. But if you see the current biomarker, we know ALK, BRAF, EGFR, MET, ROS, KRAS, ERBB2. But there are another set of biomarkers, what I mentioned you are the emerging biomarker, which could be STK3, KIP, TMB, MAP, PIK3, NRG. And all these, actually all this combination of biomarker bringing us to a clear point that testing approach is important. Single gene test may not, a small gene panel may not. This is the time that we should talk about the comprehensive genome profiling or large panel gene. So thank you very much for your attention.
Thank you, Dr. Prashant, for such a wonderful presentation. The subject is very complex, and these new biomarkers in non-small cell cancer, lung cancer, which is the most common and very dreaded disease, you have tried to make the subject as understandable as possible. I am thanking you again.
Thank you, sir.
And invite the audience for question, if any. Please.
Hello. Yeah. Thank you so much, Dr. Prashant. That was an insightful session.
She will ask one question.
Yeah, you wanted to ask a question.
Hi, Dr. Prashant. I know we are going to break for lunch. It's a very quick question, because your last slide, you had actually spoken about smaller panels might not be sufficing, but you need to go to comprehensive genomic profiling. So there is one interesting study which in ASCO, which especially for lung cancer, they had done a comparison between a smaller 50 gene panel and a comprehensive gene panel. And it was a study between, I think, 104 molecular markers. They were able to see 100% concordance with the smaller gene panel and the comprehensive gene panel, because the treatment direction is also very clear for NSLC. And they had also projected it as something which is a rapid test, which could return, which would be a smaller gene panel. So I want to know what is your opinion on that.
So it's very clear, if those 50 genes are present also in the CGP, then there will be complete overlap. So there will be concordance. So I'm not surprised that there's 100% concordance. Anytime when we talk about the CGP, you get complete full information, where you ask about the TMB, you ask about the BRCA, depending on what cancer we are talking. You talk about those mutations I was mentioning about the rare ones. You are going to miss out. And now so many novel drugs came, and they are in the trials also. So you may miss out. I truly believe lung cancer is historically at least known for the driver mutation. You can identify out of 3. If you take 1 patient, you can definitely find, or 2 patients, you can find driver mutation. So this 52 gene panel, and I always remember Dr. Kumar Prabhas, he always tells that this gene panel works because the patient can afford. And for these
affordability is something.
And these patient, those mutations, there is a drug available. So if the drug is available, then why I would go for the unseen territory where we may not
able to afford, the patient may not able to afford, or drug may be not available. But imagine for those patients where you are going to miss out those driver mutations, or the patient stop resistant to the drug when you are giving based on the primarily doing the small gene panel. So you want to go much deeper to understand this, what are the signaling pathway, what could be the mechanism where the disease got resistance. So I think there are multiple avenues where we actually go for the comprehensive gene panel.
Thank you, sir.
Thank you
so
so
much.
much. Thank you, sir. Thank you.
Thank you again, Dr. Prashant.
Thank you so much for that session. It was wonderful to listen to you all. Thank you, chairpersons. Now, we have now reached the scheduled time for lunch. May I now request everyone to reassemble in the hall in half an hour for the next session, please. Thank you.
Check. Hello. 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 Check. Hello. Check. Hello. 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 Check. Check. Hello. Hello. Check. Hello. Check. Hello. 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 Check. Hello.
आवाज नहीं आ रही. Hello. Yeah, welcome back post lunch. So let's begin with the session on lung cancer. For this, I would like to invite the chairperson, Dr. Rajiv Bharadwaj, and Dr. Rakesh Thakur to chair the sessions. I hope they are not available, so they will be joining shortly. So to begin with, I would like to invite Dr. Imran Nisar Sheikh, Consultant Medical Oncology, Kokila Ben Dhirubhai Ambani Hospital, Mumbai, for his talk on ESCO 2026 Outlook. Chair Rajiv Bharadwaj.
Okay, so शुरू करें. Good afternoon. So yeah, Dr. Satish, with your permission, should we start? So good afternoon, everyone. At the outset, I would like to thank Dr. Satish and team for giving me this opportunity to visit this wonderful place. My brief today is to present 4 articles which were published in ESCO 2026 this year. I'll start with the first presentation, or the first slide rather. Now this is a study involving or looking at the overall survival of first-line amivantamab plus lazertinib in atypical EGFR mutated advanced NSCLC. This was presented by Dr. Joel W. Neal, and it's an updated analysis of the Chrysalis 2 study. We all know that the EGFR mutations make up a large number of mutation-driven NSCLCs, but there are certain atypical mutations which are also seen in the EGFR realm, which do not have any good therapy against them. Most of the times, these are G719X, S768I, and L861Q. They are responsible for around 5 to 10% of all these mutations. Now, what we typically use in this case is the drug called afatinib. It gives you a median OS of 19.4 months, and most of the patients stop treatment by 2 years. Osimertinib was also tried. It gives you a median PFS of around 9.4 months, with most of the patients not able to take it beyond 1 year. Other EGFR TKIs are in development. So here is a study which looked at amivantamab, usually used for exon 20 insertion, plus lazertinib combination in NSCLC. So its mechanism of action would typically include dual EGFR inhibition, MET inhibition, and immune cell directed activity. In the Mariposa study, intravenous amivantamab and lazertinib have already significantly prolonged OS versus osimertinib. Now this trial looked at its role in atypical EGFR mutated cancers. So this was the typical schedule. Lazertinib was 240 mg orally plus IV amivantamab 1050 mg, and they looked at this cohort C, that is the atypical EGFR mutations treatment naive or post EGFR directed therapy. They looked at the overall response rate by RECIST, and the secondary endpoints were as enumerated. And typical mutations like exon 19 and L858R were omitted. Also, the exon 20 insertions were omitted. So this is the radiographic response with first-line amivantamab and lazertinib. So in this cohort C, total 49 patients were there, 45% female, 57% Asians, and as we enumerated, these were the types of atypical ones. Some were compound mutations. Look at the ORR, 57%, and at a median follow-up of 16.1 months. The clinical benefit rate was 84%. Median duration of response was 20.7 months, and the median PFS was 19.5 months. Now here, we are looking at the OS. So this was the disposition of the patient. So out of the 49 patients, 39 discontinued all, and ongoing were 10, so 20% of the patients.
And 7 participants continued on both amivantamab and lazertinib, 2 on amivantamab and 1 on lazertinib only. This is the overall survival, 41 months, 3.5 years. Excellent. Subsequent therapy, most of the patients who progressed would go on to receive chemotherapy or some other target therapy. This was the swimmer's plot, which showed the time on treatment with baseline characteristics. You can see 39% of the patients remained on treatment for 2 years. This is with atypical EGFR mutation type. Again, more than 30% patients remained on treatment after 2 years. This is the most difficult to treat type, the TP53 type. Again, more than 30% of the patients could make it up to 2 years. Now, this is one comparison between real life data and the results of Chrysalis 2 cohort C. What you can see here is that there is a significant improvement of 41 months versus 15.2 months in the median OS. Safety-wise, it was well tolerated. However, the skin-related reactions were more with EGFR inhibition, and hypoalbuminemia and peripheral edema were more with the MET inhibition. So to conclude, the single-arm study of amivantamab plus lazertinib in first-line atypical EGFR mutated NSCLC demonstrates a meaningful OS of 3.5 years, and hence it has shown its effect now in both the common EGFR mutations as well as the atypical EGFR mutations with no new safety signals identified. The second study is ivonescimab plus chemotherapy versus tislelizumab plus chemotherapy in previously untreated advanced squamous non-small cell lung cancer. So we are looking at the Harmony 6 overall survival trial. It's a Chinese trial. The background is most of the patients of NSCLC, PD-1 inhibitor plus chemotherapy is an established first-line regimen who have an advanced disease, but few were powered for OS and reported significant improvement. So this study is a randomized double-blind phase 3 study of ivonescimab plus chemotherapy versus tislelizumab plus chemotherapy in patients with advanced squamous NSCLC. And here they wanted to see whether this bispecific antibody, that is ivonescimab, did it improve the overall survival. So these are the results. There were in all 532 patients. They were pathologically confirmed squamous NSCLC, stage 3B or 4, no prior systemic therapy, no EGFR or ALK mutations, and good ECOG performance status. They were randomized to receive ivonescimab 20 mg per kg plus paclitaxel, and then continued ivonescimab for 2 years versus tislelizumab plus chemotherapy, and then continued on tislelizumab. So here it is a comparison between the immunotherapy and a bispecific antibody. These were the statistical considerations, patient disposition. So basically equally distributed patients, 266 in each arm. These were the baseline characteristics. Most of the patients, as you can see, were stage 4, had bad tumor characteristics, central type, major blood vessel encasement with cavitation, with hemoptysis, and you can see a large number of patients had a low PD-L1 status in both the arms. This is the overall survival. You can see it significantly improved the overall survival, 27.89 versus 23.69 months. This is the subgroup analysis. So all subgroups benefited from it irrespective of their PD-L1 status, brain metastasis or visceral metastasis. This was according to the PD-L1 expression. So whether it is less than 1 or more than 1, they benefited. This is between PD-L1 1 to 49% and above 50%. Again, the OS favors the bispecific antibody arm. Subsequent anti-tumor therapy, most of them received some sort of chemo followed by immuno and some other targeted therapy. Few patients received surgery or radiotherapy. Safety summary, mostly very well tolerated, but grade 3 side effects were around 69% in ivonescimab chemo versus 58% in tislelizumab chemo. However, very few related to death. This is the side effect profile. As you can see, with the bispecific antibody, the myelosuppression was a little bit more as compared to the tislelizumab plus chemo, but not greatly different. However, proteinuria was much more pronounced. Rest of the side effects, even including grade 3 and more, were similar between the two arms. So this is a breakup of the possibly VEGF-related side effect of the bispecific antibody. So more of proteinuria, edema, hemorrhage, and hypertension with the ivonescimab and pembrolizumab arm. So to conclude, it significantly improved the OS in this squamous advanced NSCLC. It showed a comparable safety profile, and a global phase 3 study is underway since this study was restricted only to the population in China. So this is the molecule, and this is now indicated in 2 indications in China for use. The third study, this is the event-free survival with adjuvant sulpercatinib in stage 1B3A RET fusion positive NSCLC Libretto 432 trial. So what's the background? We all know that the role of osimertinib, alectinib is well established in the adjuvant setting, but none such exist in the RET fusion positive patients, and no adjuvant therapy with regards to the target therapy is approved in this category of patients. So this is the phase 3 study which investigated sulpercatinib as adjuvant therapy in early stage RET fusion positive NSCLC. This is the design, stage 1B, 2, 3A NSCLC, but RET fusion positive. They should have received definitive therapy, surgery or chemoradiation, and no evidence of disease progression, means good response after the definitive therapy. 150 patients overall, randomized to receive either sulpercatinib or placebo, and the treatment continued for 3 years or disease progression. The primary endpoint they looked at was the event-free survival. Secondary endpoints were EFS by BICR, in the EFS in the overall population, safety and overall survival. Now this is the distribution. It involved 65 countries, total 151 patients. Baseline characteristics, most of them were around 60 years age, most of them were East Asian, most of them had a good or never smoker status, and RET fusion, as you can see, KIFB and RET was the most common one. PDL1 and other things are noted here. Now this is the event-free survival. Look at the difference in the Kaplan-Meier curve. They separate quite early. So it has met its primary endpoint and demonstrated a statistically significant improvement in overall survival in favor of sulpercatinib. This is the overall population where sulpercatinib does much better than the placebo. This is the primary analysis population on the left side and the overall population. So even by blinded independent committee review, the sulpercatinib arm does better than the placebo arm. This is the forest plot showing all subgroup of the patients, irrespective of their smoking status, geographical status, disease status, show benefit for sulpercatinib. Fewer patients progressed on sulpercatinib and very few, or rather one patient only for brain metastasis, whereas the opposite was true for the placebo. No deaths occurred in the sulpercatinib arm, very few discontinued, basically because of the side effects. So grade 3 or more treatment-related adverse events were manageable, and they usually were due to the usual side effects of sulpercatinib. So what are the usual side effects? Liver enzyme elevation, ascites, diarrhea, QTC prolongation. These are the ones which one should look for when the patient is on therapy with sulpercatinib, and at each baseline and subsequent visits, these should be checked. So to conclude this trial, sulpercatinib demonstrated improvement in the event-free survival for RET fusion positive NSCLC versus placebo, hazard ratio 0.17. It was with tolerable safety profile. And therefore, one should now be checking for RET mutations in early stage lung cancer also, other than the metastatic setting. So the last trial now, just 5 minutes if I may have. So this trial is the OptiTrop Lung 05 study. So it's a randomized phase 3 trial where there's sacituzumab tirumotecan plus pembrolizumab versus pembrolizumab as first-line treatment for PDL1 positive advanced NSCLC. So what's the background? We all know for advanced NSCLC, chemo plus PDL1 is the standard therapy. And what do we get? Median PFS of 5 to 8 months, OS of 16 to 20 months. So there is something which can be further improved. Now TROP-T is a target which is expressed by most of the NSCLC, and by inhibiting this, it may complement the effect of PD-1 or PDL1 blockade, thus causing more cell death. So prior phase 2 studies have confirmed this. So this is the design of the drug, sacituzumab tirumotecan, where you have an antibody drug conjugate, typically the monoclonal antibody sacituzumab for anti-TROP2, and the cytotoxic payload is belotecan with a drug antibody ratio of 7.4. And there is a linker which is stable in the plasma, releases the drug only in the cells, and causes cell toxicity and less of side effects. So this is the study design. Locally advanced 3B3C metastatic NSCLC with no prior systemic anti-tumor therapy, no sensitizing EGFR or alterations, and PDL1 status at least greater than or equal to 1%, and a good performance status. They were randomized to receive only pembrolizumab versus pembrolizumab plus the sacituzumab tirumotecan, and then the thing was continued till disease progression or for at least 2 years. They looked at the PFS and secondary endpoints was OS, PFS, ORR, DCR, DOR, etc. So this was the statistical analysis. These are the baseline characteristics. You can see well matched both groups. More of current or former smokers, most of them good ECOG performance status, more of adenocarcinoma, more of stage 4 disease, more of PDL1 between 1 to 49%, and there were more of distant metastasis including brain and liver. So this is the progression-free survival by the BICR. The sacituzumab TMT plus pembro significantly improved the PFS. You can see 65% reduction in the risk of progression in favor of sacituzumab pembro versus pembro alone. This is by investigator analysis. Again, 62% improvement with the investigator analysis in favor of SAC TMT and pembro. This is according to the PDL1 expression. Now, interesting to see, those who had a PDL1 between 1 to 49% have a wider separation of the curves as compared to those who have a PDL1 TPS of greater than 50%. But again, in favor of SAC TMT versus SAC TMT and pembro versus pembro. This is by histology. So both non-squamous and squamous benefited by SAC TMT and pembro. This is the forest plot. Again, underlining the same thing, that all subgroups are equally benefited. Now this is the descriptive OS at PFS interim analysis. So there is a trend towards improvement in OS, though the OS data is not yet mature. These three row columns show you the overall response rate, the deep response rate, and the duration of response. So in all three categories, the SAC TMT plus pembro scores over single agent pembro. Safety summary. So median duration of exposure to SAC TMT and pembro 9 months, pembro 8.3 months, and pembro alone was 5.1 months. So a slightly higher incidence of grade 3 or more adverse event with SAC TMT pembro versus pembro, primarily driven by the hematologic adverse events of SAC TMT. And the treatment discontinuation rate were the same in both the treatment arms. No treatment related deaths due to SAC TMT and pembro. These were the adverse effect profile as expected. Bone marrow suppression because of the sacituzumab deruxtecan, and pembro caused more of hypothyroidism, hyperthyroidism, and its usual autoimmune side effects. So to conclude, SAC TMT and pembro demonstrated a statistically significant and meaningful PFS benefit versus pembro alone in first line positive PDL1 positive NSCLC, and it was in all the subgroups, including the low PDL1 TPS types. It achieved more response, deeper response, and durable responses than the pembro alone, including in patients with PDL1 greater than or equal to 50. OS data is still immature, but there is a trend towards improvement, and the safety profile was manageable. No new signals were observed. So this study suggested that the SAC TMT plus pembro could be a potential new treatment option for PDL1 positive advanced NSCLC without EGFR or ALK alterations, because you can improve upon that PFS of 5 to 8 months and OS of 16 to 20 months by the addition of this bispecific antibody. So that's my last slide. Thank you for the patient hearing.
Thank you so much, dear speaker. That was an insightful session.
Thank you.
I may now request the chairpersons to kindly conclude the session. We will proceed to the next topic. I now invite our next speakers, Dr. D.K. Singh sir, Dr. Supravo Chakravarti, Ranchi, Dr. Souvik Sarkar, he's a pulmonologist based in Ranchi, Dr. Shreyanshu Sahai from Ranchi. Yeah. So this will be a panel, so I would request our speakers to kindly be seated. Respected chairpersons, if you can be seated in the next front row so that the panelists can take the seat. And kindly please introduce our next moderator for the session, for the panel.
Good afternoon to all my dear colleagues and my seniors. So I would invite my panelists, Dr. Amit Kumar, Dr. Avinash Upadhyay, Dr. Joydeep Ghosh, Dr. Ghanshyam Biswas, Dr. Prashant Kumar, Dr. Richa Chauhan, Dr. Rukmini, Dr. Sushma Padmaja. So we will be basically discussing the recent developments which have happened for management of lung cancer in ASCO 2026. As we know that lung cancer, the precision oncology era has come up. Initially it used to be a one disease, but we know that it has, based upon the histopathological diagnosis, we divide lung cancer into small cell as well as non-small cell lung carcinoma. And further, non-small cell lung carcinoma is divided into subtypes of squamous and adeno. And we routinely now do the molecular pathology analysis in NSCLC to look out for those driver mutations and based the driver mutations which are now targetable, and that has changed the paradigm of management of lung carcinoma. So approximately, I would say 50% of these targetable mutations, driver mutations are targetable. The most common being EGFR followed by AL-cross. So commonly we do a NGS comprehensive panel to look out for these driver mutations. So I would like to ask the pathologist here, Dr. Rukmini. So what challenges do you face, specifically where we need the tissue for further testing? What challenges do you routinely see where the tissue is the issue in lung cancer?
So you asked me about the challenges we face.
As a pathologist, because
Okay.
we need these samples for further testing as well. So
Yeah.
what do you do in your practice, whether you consider for a routine, limited IHC panel or a comprehensive IHC panel, what challenges as pathologists do you face when we are seeing NSCLC in our practice?
Basically, in case of lung cancer, the quantity is like really scarce. So we get very little tissue. So the idea is to preserve as much tissue as possible so that we can go for molecular testing. So depending upon on the histological type, like if I can see that it doesn't require any IHC, suppose if it is a clear-cut case of squamous cell carcinoma, then I'll not put IHC.
Okay.
But if I am not being able to diagnose whether it is an SCC or is it an adenocarcinoma, in that case I will just use TTF1 P40 and suppose both turns out to be negative, then I'll give it as non-small cell carcinoma NOS and then I will put the rest of the tissue for molecular testing. So that is how I preserve.
Okay. So Dr. Prashant Kumar, regarding the NGS testing, so I would like to know where does IHC and FISH stand in the era of NGS? So,
so see, the FISH has limitation, which all of us know, and we're still struggling because the probe is an issue. I remember that 5 years back when we were working on breast cancer, only 4 or 5 probes were there. So again, I am very propeller of the using the NGS because NGS is far more sensitive. And in a one go you'll get much more information depending on what you ask, that what you do. If the tissue is an issue, I can also comment that liquid biopsy is something we should be heading towards, And there are data which clearly suggesting that many of those mutation you may not even identify tissue, you can identify liquid. A lot of concordance data, the concordance data between tissue and liquid showing more than 77%, 80% concordance. So according to me, that when tissue is issue, of course, you can go with the liquid biopsy, but the tumor content is also very important, that whatever tissue you are taking, it should be minimum 18 to 20%. It's very important. And your second question is that, what you asked, I forgot.
Where does FISH and IHC stand now in the era of NGS?
I think the NGS, depending on what gene panel you can do, what is the cost, how much wallet is fat or heavy, you can pick. But lung cancer is very straightforward. There are a lot of drivers we know. So most of the drivers you could identify, and the data suggests that out of 3 patients, if you pick lung cancer, you will find at least 1 patient having the driver mutation or 2 patients. So we are in a pretty good shape.
So Dr.
Actually, IHC, can I tell one thing? But as you asked about IHC, whether it can be replaced, but for PDL1 testing you need
We have
IHC,
to do
so
IHC.
you cannot go for NGS in that.
Yes,
so
yes.
It will still be there.
I have a small point. So there is still a complementary factor to doing IHC. For example, the classic example I would say is ERBB2 amplification.
Yes.
So ERBB2 amplification is something which you see only in the molecular level. And IHC, you see a HER2, overexpression. Sometimes there are places where you don't correlate both. Not all ERBB2 amplifications have HER2 overexpression, but we need biomarkers. So the biomarkers testing methodology can be, n number when you can treat a patient with a particular biomarker. Yeah.
So you're doing you're routinely doing IHC for HER2 amplification, or you're just doing NGS testing?
I think for this one you need both, because
need both.
we want a treatment schedule, and you have it as ERBB2 amplification or HER2. There are studies which compare both, and it also says gene copy number doesn't directly correlate with the expression, protein expression biomarkers.
So, Dr. Amit, I would like to ask regarding the NGS, you are doing on solid and liquid sequentially, or whether you are doing it concurrently, finance is no cost. What is your take on this?
So initially in practice, solid first. If patient is affordable, definitely I counsel them for both solid and liquid. But if a cost is a constraint, solid first. And if tissue is not available, then only going for a liquid.
Dr. Vinash, what is your practice?
So I also believe
concurrent.
Liquid and solid biopsy, yes.
Dr. Joydeep?
Mostly solid first,
Solid
followed by
first.
liquid only if the tissue is not available in the first line.
And NGS DNA based or RNA based?
Both.
Both. Okay. So very important that both DNA and RNA based should be considered because there are false negative with DNA based NGS. So Dr. Prashant, you would like to highlight regarding the DNA and RNA based NGS, a word regarding the DNA?
Very quickly, the fusions actually. The whole idea is that when we talk about the RNA-based NGS, we would like to identify those fusions. Even DNA-based fusion you can identify, but RNA is always preferable. And the other thing is that RNA, I can go much deeper, the transcriptomics, when we talk about the expression. Now, with the advent of data, suggests that we should also do the expression of the genes at the transcriptomics level. So I truly believe that we should be explorative mode, where we should do both DNA and RNA.
RNA-based. So the Crown data was presented in the ASCO 2026, and now we have 7-year data for lorlatinib. And what was impressive, that patient who have brain metastasis, there is 7-year survival of 53%. So I think this is a practice-changing trial. So I would like to ask my medical oncologist, Dr. Ghanshyam. So what strategy do you employ when the patient is diagnosed with ALK-positive CA lung, whether you go for sequential alectinib followed by lorlatinib or lorlatinib upfront?
So all the ALK positives are not the same. So there are high risk features. So like brain metastasis, the variant ALK, and P53. So if these three are there, then your choices will be the 3rd generation lorlatinib, or probably the brigatinib, which is rather between second and third generation. So that choices, because many of these patients may not be affording. Otherwise, lorlatinib with the crown dart at 7 years, with all the three features, high-risk features, so lorlatinib will be the choice.
Yes. So, Dr. Richa, ALK positive CA lung brain metastasis, symptomatic. So, as we know that the survival is more than 7 years now, and quality of life is a major factor which plays now. So, it has become more of a chronic disease. So, what radiation techniques would you consider in ALK positive CA lung with limited brain metastasis?
So the technique will depend upon the number of lesions we have in brain and where the location of the disease. If it's 1 to 4 lesion, we now go for stereotactic radiotherapy. So that preserves the quality of life.
Yes. So since ALK positive CA lung has become a chronic disease, it is important to focus on the quality of life as well. Even with brain metastasis, we have a 7-year survival, which was recently presented in ASCO 2026. Now, we'll be briefly discussing the trials which were presented by Dr. Imran. So this is regarding the EGFR mutated advanced NSCLC, where first line amivantamab with lazertinib was given in atypical EGFR mutated NSCLC. So, Dr. Amit, what is your routine practice whenever you see EGFR atypical mutations? What drug do you consider? Or you consider these patients for chemotherapy along with some TKI? What is your practice?
So it all depends on what is the mutation. So every have a different connotations. So if it's a EGFR exon 20, definitely amivantamab with chemotherapy is the first line. For other atypical mutations, we have to see whether they are sensitive to osimertinib or afatinib, and if nothing, then basically chemotherapy.
So suppose the patient has G719X, what would you consider in this patient?
For G719X, it is afatinib or osimertinib also works good for these patients, so we start with that.
Dr. Avinash?
My practice also was afatinib.
Yes. So, Dr. Joyadi, do you feel this is a practice-changing trial since it was a single-arm study?
Yeah, academically practice-changing, but I don't know how many of us would be able to give this drug to Indians.
Yes. And Dr. Ghanshyam, regarding the side effect profile of amivantamab and lazertinib, have you considered in any of your patients?
So
and what?
Hugely toxic drug, not only from the pocket, but even after the applying of cocoon and other mechanisms, so still it is a toxic drug. So, and very difficult to maintain this patient for a longer duration. If at all this patient continues for 3.5 years, so it is a hell lot of supportive management.
Yes. So it was compared with the real world cohort as well, although it was a single arm study, but we can see as per the historical controls, it has achieved a median overall survival of 40 months. So I feel it is a practice changing trial, but financial toxicity is one thing most of the patients won't be able to consider in our clinical OPD. So this was again ivonescimab plus chemotherapy versus tislelizumab plus chemotherapy. So this is a new drug which targets both VEGF as well as PD-L1. So this was a China only study, and it included patients with the squamous cell carcinoma NSCLC stage 3B, stage 4 with no EGFR ALK mutations, and we can see that giving ivonescimab was, it improved the overall survival significantly as compared to tislelizumab. So again, my question to Dr. Amit, do you feel again is this practice changing, or we need more data, or this was only a China only study, so we need whether global data as well before considering this into our practice?
So basically this molecule has a double effect, not only PD-L1 but VEGFR inhibitor too, and this mechanism of action is showing clearly a benefit. So once the molecule is available, I'll say it's the first choice.
So the traditional teaching was when patient is having squamous, we generally don't consider for anti-VEGF based therapy since there is a risk of bleed and hemopsis. So wouldn't you be worried about the risk of hemopsis and bleed?
Yeah, so definitely that's a concept in the squamous cell, but also in the squamous cell, if the tumor is not centrally located and not near to the blood vessels, in that case also bevacizumab or VEGFR inhibitor can be given. But definitely the exact cause has not been mentioned in this trial why there is less bleeding despite adding VEGFR in a squamous cell, but it is clearly showing bleeding risk is less. So might be more real world data when comes, we will have more answer.
Dr. Avinash, what do you feel regarding this trial? Practice changing, or we need more data?
I think this is a new.
Dr. Joydeep, your opinion regarding this trial, dual blockage of VEGF and PDL1? China only
is that
study.
you won't have any Western data with this drug. So it will only be Chinese data. So if you have to believe it, you have to believe the Chinese data. Since we are already using Chinese IOs, so if this becomes available, there is no harm using it because we have a randomized trial.
So in fact, so what Jaideep said was Chinese, but I have a similar study profile. It's from Pfizer. Similar mechanism of action, but that is in Western. And we have randomized the first patient in India. So it is anti-PD-1 and anti-VEGF. Similar trial is there, but that is including both adeno and squamous.
So the benefit was seen in all subgroup of patients, and the benefit was seen irrespective of PDL1 expression. Most importantly, the risk of bleed was only 3% with ivosymumab. So hemorrhage was grade 3 was less than 3%. So regarding the Libretto 432 trial, so this was for RET mutation positive patients, early stage, stage 1B to stage 3A, who have received definitive therapy, surgery, radiation and adjuvant chemo, and patients were randomized to selpercatinib versus placebo, and treatment was given for a span of 3 years, and there was significant improvement in event-free survival with hazard ratio of 0.172. So again, to Dr. Ghanshyam, what do you feel? Is this practice changing or?
So there should be a patient for the practice, no? So rate. So this trial was actually stopped because they could not recruit patients. So now Lilly has come in metastatic setting, and suddenly they have come with the adjuvant setting, and we have seen osimertinib in adjuvant setting, ALK in adjuvant setting, and so far it is expected that these drugs have come up the ladder in a curative setting.
Yes, so important is we should consider for comprehensive NGS in adjuvant setting as well. We should look out for these driver mutations, and at present there are 3 mutations which can be targeted, EGFR, ALK and now RET as well. So no OS data as such. Still you would be considering MET testing. Dr. Joydeep?
See, in the curative setting, EFS is a good surrogate marker of OS. And looking at the Kaplan-Meier, it's definitely going to have OS benefit. Hazard ratio is 0.1. You rarely see a hazard ratio of 0.1 in anything.
So the last trial, anti-TROP2 sacituzumab deruxtecan versus pembrolizumab, OptiTROP Lung 05. So this had around 60% had PDL1 of 1 to 50%, and in those subgroup we know that chemo IO is the standard of care. So do you feel there is some shortcoming in this trial where the control arm is just IO only? So Dr. Amit?
Yeah, definitely. So they haven't used chemotherapy in the control arm, and even with PDL1 more than 1%, more than 50%, it could be like that. We all know that ADC with IO will be now with the next thing which will be coming up, but definite comparison with chemo IO is needed for making a practice changing.
So more data is needed where we need to compare it with chemo IO rather than IO alone.
So even with the recent meta-analysis 2 months back, even with the cohort of more than 50, they were benefited with chemo and pembro combinations.
Yes.
And here 40% patients were 1 to 49 where a standard of care was not given.
So for more than 50%, maybe this can be considered, and 1 to 49 we need more data because it was not compared with the chemo IO, which is the standard of care. So I think I would conclude and thank you all for. Thank you.
Good afternoon, everybody. May I request Dr. Mubarak Ponce, who is Senior Consultant Medical Oncologist, Dr. L.H. Hiranandani Hospital, Mumbai. He will be talking on colorectal cancer in focus critical outcomes and learnings from the Checkmate 8 HW study. May I request Dr. Mubarak Thank you.
Yes, ma'am.
Good afternoon, everyone. I thank Dr. Satish Sharma.
would request our chairpersons to kindly introduce the next keynote speaker along with the topic.
Hello. So it is my privilege to introduce Dr. Shailesh V. Srikhande sir. And in fact, in the original chairperson's name, it was not there. And when I was asked to do so, I am really pleased to introduce you, sir. So, sir is the Chief Executive at Tata Cancer Care Foundations, Mumbai. And the Ranchi Cancer Hospital and Research Center at Ranchi as well as Tirupati are under him. But that is a very small introduction for him. He is a world-renowned hepatopancreatico-biliary surgeon, as well as I want to tell you that he is a director of GI and hepatobiliary cancer surgery at Gleneagles Hospital, Parel, Mumbai, and a consultant surgeon at Breach Candy Hospital and Srikhande Clinic, Mumbai, India. That's a very small introduction, sir, but I won't waste much time. But I like to tell you what he is going to discuss with us. That is about the pancreatic cancer in 2026, from therapeutic nihilism to precision multidisciplinary care. So I have heard sir speaking before also. There is a group of international surgeons that is called SFS. So Dr. Parul Sukla, sir himself, and few other surgeons from all over the world, they are the members. And I'll advise, in fact, the surgeons who have not joined that SFS forum, please do it. It's a very, very insightful and teaching also for young surgeons as well as for, other surgeons like sir. So I won't waste much time, sir. Please go ahead with your presentations.
Thank you, Colonel Pandey sir. Thank you, Dr. Satish Sharma. Thank you to Ranchi Cancer Summit for giving me the pleasure and privilege of the podium to be here. All of a sudden, in the last 6 months, Ranchi has become very dear to me. The reason is not only because of Dr. Satish Sharma, who is also working part-time with our hospital at the Ranchi Cancer Hospital and Research Center. He is a very capable medical oncologist, and you know that with the Tata philosophy, we want to help as many patients as we can, and I don't need to say more in the presence of Dr. Advani, who has been an icon for us even before I joined Tata Memorial more than 25 years ago. So the philosophy is to reach to more and more people, and through that perspective, our Ranchi Cancer Hospital and Research Center is going to be doing more and more work, and you will see this in the period ahead. Now, the brief given to me is to speak about a difficult disease. Before I start, I want to know how many people are surgeons in this audience. How many? 1, 2, 3, 4. Are there reluctant surgeons? No, there are no surgeons. Okay.
I'll tell you, surgeons are bold, so raise your hands and don't hide.
Yeah, okay. So 4 or 5. And how many medical oncologists are there in this audience? Only 3 or 4. So who are the other doctors here then? All radiation oncologists? Oncopathologists. Okay. So the problem we have here is that I don't have to teach anyone, but localized solid tumors are best treated by radical surgery. I don't say this because I'm a surgical oncologist, but because even now, if you have localized disease, I'm sure that my medical oncology and radiation oncology colleagues will agree that surgery is the best way to try and cure a patient with pancreatic cancer. But there is a problem that we don't get a large number of pancreatic cancers that are truly localized. So let me try to share with you, they have given me the title of a keynote lecture for 25 minutes. But in 20 minutes, I'll try to show you a little bit of the journey in pancreatic cancer surgery and how we can blend it with medical oncology and sometimes with radiation oncology to try and see how we can improve the prognosis of a disease as we move towards making cancer more and more of a chronic disease rather than immediately finding a cure, which is what all of us, of course, want. So this is the story of pancreatic cancer surgery. This is a slide of 1995. That's a slide of 2006. Even in 2006, when Johns Hopkins published a series of 1,000 Whipple resections, you have only 64 patients in that 1,000 resections with N0 disease. That means the disease has not gone to the lymph nodes, and then you will have 40 people out of 100 who are alive at the end of 5 years or more than that. That means surgery is doing something, but surgery is not enough. So I think it's important in surgical oncology, even in 2026, in the era of liquid biopsy and NGS, that we need to know how to do good surgery to try and solve a problem. I'm talking about an operation which was started more than 100 years ago in 1909, but got popularized in 1934. And what do you see from the first 3 patients who were published in the Annals of Surgery? First lady died in a little over a day due to fistula. Second patient died on the 8th post-operative day due to liver failure, fistula, liver abscess. Third patient got a re-exploration, got a fistula, stayed in the hospital for 2 months, but finally did survive for 2.5 years, thus providing the first evidence that maybe you should do surgery, and good surgery, for a very complex organ with a very complicated way of doing an operation. My own journey, I first, as a young surgeon, I've tried to see what can I do to reduce the chance of a fistula. Why do I tell this to the few surgeons and those who may be wanting to do surgery? Is look at what was said in New York in 1986 when I was in my 10th standard, that the United States Congress should pass a law making it illegal to do a Whipple operation. This is United States of America, is what I want everyone to understand here in Ranchi today afternoon. Now, if you get a fistula, you have a 40% chance of mortality. So every surgeon must try to do what I tell every surgeon. Amitesh Anand, our lead surgeon, is very much here. I'm proud to say that once upon a time my student, but now a dear colleague, and he knows one of my sentences, attention to detail of everything you do, whether it's research, whether it's chemotherapy, whether it's immunotherapy, or whether it's a simple surgery, or whether it's a high quality surgery. Attention to detail will help you to save lives. I used to do this technique in a particular way with my mentor, Dr. Jagannath, when I was a fellow at Tata Memorial, when I used to also work with Advani sir when he was still there. And at that time, we used to do a pancreaticogastrostomy. I learned something from this man in Germany, Markus Buchler, a mentor to me, and he told me 3 things. Whatever you do, please standardize. Secondly, whatever you do, you must document. And thirdly, you must publish. Because if you have not published, sorry to say, it means you have not done. The simple philosophy is we all talk, but if we don't publish, it is not done. So our generation needs to understand that we standardize, we document, and we publish. I started doing that, and our results of joining the pancreas to the intestine improved, the mortality reduced. What did I learn? This was not original. This is William Halsted. William Halsted is known to be the father of American programs in surgery. He created 17 chairs of surgery. And what did he teach when you want to join two organs together? We ask everybody in an MS exam that you must bring two organs together with perfect anatomical approximation, have good blood supply, there should be no tension, there should be no distal obstruction, and if you can do this very gently, you trust and respect God, and the patient will respect you back. And that's what exactly works even today in the era of robotic surgery. So the surgeon remains the most important factor. Remember this for my entire cancer oncology colleagues. I grew in Tata Hospital in 25 years. Initially, we started doing operations where we tried to save patients when there were complications. In 2007, we standardized a technique of pancreas anastomosis, which is done till date, even now, by my future generation of surgeons. We started looking at what is happening across the whole of India in terms of improving the outcomes of a difficult operation. Then as we grew, we started getting more confident. In our joint clinic, this kind of a tumor, which is involving a blood vessel, was considered to be inoperable, and we would say palliative care, palliative chemotherapy, pain management, please go home. Then I got a good radiologist. They taught us how to look at the blood vessels, how to look at the tumor with the blood vessels and the interface. And now every resident of ours evaluates a pancreatic cancer very critically, whether it is resectable, borderline resectable, or locally advanced. And I will tell you why. If you don't have good radiology and if you don't have the mind, the eyes do not see what the mind does not know, is what we should remember when we work with our patients every day. So the next thing was that if you want to do difficult operations with blood vessels, you must start doing more and more complex techniques. And the enemy for any surgeon is bleeding. Pancreatic surgery is vascular surgery. Pancreatic surgery is not rectal surgery, it's not stomach surgery, it is vascular surgery. If you can handle superior mesenteric vein, superior mesenteric artery, and other critical structures, almost anything and everything that is localized can be operated and removed, but wait, should not be removed, and I will tell you why. This was one of the first cases, not in 2001 when I joined in Tata, but 10 years after I joined in Tata. A patient of 66 years of age, his children were working with Novartis in Basel, fit man, took chemotherapy, locally advanced, inoperable cancer, kept coming to us. We gave all sorts of chemotherapy. We gave radiotherapy. The patient came back walking and said, I know that the problem is still localized. Can you please take it out? I know that this is the only chance to live. A patient knew this. We did not know this in terms of evidence. We said, this is advanced, pancreatic cancer is a bad disease, don't do this. He said, I know there is a risk to my life. I trust you, please do this. What have we done? We have removed the portal vein and joined it back. We have completely gone to the root of the celiac axis, exposed the superior mesenteric vein, cleared the entire retroperitoneal tissue. We have done an extended pancreatectomy in a patient whom we previously considered as locally advanced inoperable cancer. The patient lived for 3 more years and died. Lesson learned, you must know radiology. You must know every patient is different. You must know how is the biomarker, and you must know how good is the response to chemotherapy plus minus radiotherapy. Something which was difficult for me, handling blood vessels, is a routine now in terms of vascular resection for pancreatic cancer. But now my oncopathology colleagues come in. We do such a nice operation. We show nice pictures in conferences. And then the pathologist phones me after 8 days and says, Dr. Srikhande, this is R1 resection. What are you doing? You are wasting your time in the operation theater. No, I'm joking. I'm not saying that. But it is R1 resection. Then you start realizing that only technique and high skills and lot of learning, or the Malcolm Gladwell 10,000 hour story doesn't work. You need to work in an environment where you all come together to try and see how we can improve our patients. So that's what I mean. Anatomy with radiology and surgery, biomarkers, and more research to see what you can do with CA19-9 and newer markers, which will come now. And I'm looking at my molecular pathologists and researchers. And then, of course, no two patients are the same. I may do a very difficult operation on an old, fit patient, and I may not do the same operation on a younger, less fit patient. So don't confuse skill with patient selection. Choose your patients, choose your battles when you treat pancreatic cancer. My pathologist told me that your R1 resection rate for pancreatic head cancer is 57%. Periampullary cancer, bile duct, 20%. Ampullary so-called small tumors, 7%. So that means we need to do something more before we touch this patient. Plus, here is a surgeon talking to medical oncology colleagues that unless I can give 6 cycles of chemotherapy post-operatively, giving up to 5 cycles of chemotherapy is not making patients live long after such a complex operation. So the onus is on the surgeons. I know there are few surgeons here, that if we do good surgery, they must recover well so that they can go back to chemotherapy within 8 weeks or at the most 12 weeks after a complicated operation, so that they can get 6 cycles of chemotherapy to get a chance to live long. Giving 1 cycle post-operatively, 2 cycles post-operatively, 3 cycles post-operatively is not good enough. Satish Sharma will say that Dr. Srikhande has done a poor operation. I can give only 2 cycles of chemotherapy. It doesn't work. So I do my best to do good surgery and then I send them to you. So that brings us to the thought process that perhaps it's good to give some chemotherapy before, especially when the chance of R1 resection is high. And that has been shown again by data. The red bar is the upfront surgery rate. But if you give chemotherapy first, your R0 resection rate is much better. The R1 rate is coming down. So chemotherapy is also working in a difficult cancer. Again, go back to documenting what we do. So this is our own work where we have looked at 201 borderline resectable disease, 148 with chemotherapy first, plus minus radiotherapy, and a small number directly with surgery. You see the R0 resection rate, 75% versus 42%. I know overall survival is not improving, but it's an ongoing journey and we continue to get better. Since you want to talk about nihilism to optimism, I remain the eternal optimist. Moving on, in 8 years at the Tata Memorial, during this period with a team which was developing, we did 620 standard Whipple operations, but 63 more extended, more difficult Whipple operations. Here I have resected the splenic, resected the common hepatic artery and joined the splenic artery to the liver so that we could resect the hepatic artery and do a complete resection. And you still get about 40 patients who are alive at the end of 3 years, provided they get adequate chemotherapy. That has changed from 63 operations when it was initially 9% over 8 years. Afterwards, it has become 16%. So do we do more radical operations in the era of multidisciplinary care? Yes, we do. You can see this from our objective documented data that we have looked at 197 of these from a baseline of 1,227 Whipple resections. So the journey has been an escalating complexity and stable outcomes over a period of time at the Tata Memorial. We can keep on doing vein resections, we can remove the tumor with the vein. I'm not going to go into details. This is a case of celiac axis resection. Look at this lady who has been treated for a celiac axis. Inoperable tumor, see the CT scan in between, the flying bird sign, hepatic artery, splenic artery gone, and then we have treated with total neoadjuvant chemoradiotherapy, then resected, reconstructed the common hepatic artery. See, the liver is looking like a liver treated with FOLFIRINOX 12 cycles almost, and then we have resected, and patient is doing fine even 2 years later after surgery. Are these surgeries worth it? Yes. If you look at a senior colleague of mine, an ophthalmologist, celiac axis block, doing fine and running marathons today. If you look at this gentleman, and there are many of these are not anecdotes. So yes, I do speak to you from a position of confidence in terms of a large number of pancreatic resections. We now also know that chemotherapy works even better than before. So sometimes I plan a difficult operation like a celiac axis, but at the end I'm able to safeguard all vessels because the disease has responded well to chemotherapy, predominantly, uncommonly radiotherapy. We will evolve robotic technologies over a period of time. I don't have the time to discuss with you, but what have 24 years in pancreatic surgery and at Tata taught me? Pillars are not parallel, they are coupled. Service will generate questions, research will answer them, education will multiply the answer. Standardization will beat novelty. If everybody starts to think tangentially, unfortunately nobody is thinking straight. We need to be thinking straight and doing the standard jobs well every day. Advani sir can correct me if I am saying something wrong. The basic foundations cannot change. Definitions will become infrastructure. Otherwise, we are talking apples and oranges and we are not talking about the same patient when we should be talking about the same patient in a language we understand. So at the end of it, please understand this is a bad cancer. Gene mutations and core signaling pathways, there are 12 pathways and 63 of these are gene mutations. It is too many. There is the stroma, there is the cancer cell, and it's not easy to tackle this cancer and cure it quickly. But it's possible because you are getting precision medicine more and more, as you know very well. And what you see is what I am talking today because you heard a standing ovation in ASCO recently. And that's about KRAS, which is actually a very old story. I've done this work in the lab in Bern more than 25 years ago on rats. And what you see here is, I've deliberately cited the publication starting from Nick Limion, 1992 onwards, when I was still doing my MBBS. It takes a long time from bench to the bedside for some research to really yield the necessary results. This is what I talked to you about the lab. You have a control and you have the KRAS and then you delete and then you will see what happens, that physiological levels of KRAS GD12 induced full spectrum of human pannin and invasive pancreatic cancer. So the minute you delete that, oncogenic KRAS is required for both initiation and maintenance of pancreatic cancer in mice. So if you can inactivate KRAS, you are reversing the pannin formation, the precancerous stage of pancreatic ductal adenocarcinoma, shown a long time ago, but this is what we got in ASCO today. But again, for the younger members, and even to my medical oncology colleagues, yes, we see that it is doing better than conventional chemotherapy in stage 4 pancreatic cancer. So something to look forward to, but also look at the control group very critically. Also look at the fact that what percentage of patients get the kind of rash they get, and also look at the fact that the NHS is perhaps not going to accept it because the drug today costs 10,000 pounds in the in the United Kingdom, so it will not come into the United Kingdom easily. So as scientists working in a country like India, we should constantly be aware about availability, accessibility, and affordability. But we are going to get there more and more, and I think at this point in time it's best that I stop my lecture because I have exceeded the time. Improving access to care is my goal while working at the Tata Memorial, and this continues even now, not just as a surgeon across India, but most importantly, this was 25 years in Tata. Now this is Breach Candy Hospital and the Glen Eagles Hospital, where I'm the chairman of oncology to continue GI cancer services. But more importantly, Ranchi and Tirupati is now even more dear to me. So you will start seeing me more and more often. Even if you don't like me, I will periodically come to spend some time with my surgical colleague and my friends in Ranchi. Thank you very much. I'm sorry I've exceeded the time. My apologies for taking 5 minutes more. Thank you.
Sir, for keynote address, this is not exceeding any time, sir. And we are really overwhelmed by the journey which you have described to us from the beginning till now. So really, sir needs a standing ovation from all of us. And this is from our core of hearts, sir. And I'd like to tell you the audience was pin drop silence. It was not with other presentations. This is my...
I think Satish Sharma came in, there was pin drop silence after that.
So, though keynote address, I'm not supposed to be asked any questions, but...
I'm very happy to answer them if you have the time. Very happy.
If somebody want to have any questions, query, or any comments, please.
Just first, at the outset, I would like to just congratulate you for a wonderful presentation.
Thank you.
I know Shailesh from a long time, since he used to come with his father in ASI conferences. And we have invited his father also to give one lecture in Ranchi in Academic Medical Forum.
Yes.
In one of the orations.
Yes.
So we had a great bondage. I always used to visit Tata during the time of Dr. Jagannath.
Yes.
And used to visit OT, your fellow there, and then Parul Shukla and all. I learnt some of the surgeries there also. I know pancreatic surgery has really evolved the organ which earlier no one used to touch. In the beginning of my career, I did few Whipples also. Now I have stopped doing all these complex surgeries because there are better persons in Ranchi to do. I had done one Whipples in my small setup long back, and at that time Dr. B. Krishna Rao, you know, he came to Ranchi.
Bhim Kunte, yes.
And he was seeing my patient there. So he just said, how dare you do these surgeries here? I said, we have to learn these things and slowly these will evolve. I think now the cancer care has improved a lot, and it's going to go further also.
That's the mission.
And we need it because the incidence, detection and all these things are increasing.
And our nation needs it.
Yeah.
We need to become a better nation. We should stop going abroad. We should do it here.
Your dedication and quality which you are giving, and you have brought India's name to the world.
Thank you, sir.
Because the work which you have done, you are trained in Germany.
Thank you.
Thank you very much.
Thank
and
you.
coincidentally, now my son has been trained under you. So it will again another relationship which we have.
I want everyone to come to RCHRC.
Thank you very much.
Sir, one thing I like to tell you about Amitesh. Amitesh, are you listening? He has learnt all the good qualities from you, sir. He is very patient, and really the way of dealing with patients, they like him. And though he has a flexible time of working, but he devotes very, very long time sometimes in the hospitals. And I have seen him doing Whipples, quite few of them. One was in fact cardiologist's father himself, and he lived for quite some time.
Very good.
Anupam's father.
So whenever he is not working, you phone and tell me.
Hello. Sir,
I think this question from all radiation oncologists in this forum. But once we have started our studies, this has like a short notes question to us, CA pancreas and the role of radiation. So I just want to know the intraoperative, have you ever had exposure of it, or how was it?
So, we have done, when I was in Germany, there was intraoperative IORT, which was being attempted a lot at one point in time. But our previous director, Dr. Dinshaw herself, we used to have an IORT in Tata Memorial as well. But over a period of time, the evidence in terms of IORT for locally advanced pancreatic cancer has gone down. But what I feel is still an open question is, despite your alliance trial, published by my friend Matt Katz from the MD Anderson, there were certain shortcomings in the alliance trial. So though it was a randomized controlled trial and it failed to show a benefit, on the other hand, it showed a disadvantage of radiotherapy versus chemotherapy. I think the jury is still out. We don't know. My own colleague at the Tata Memorial for many years, a RENA engineer, we have tried to see those uncinate process tumors which are closer to the artery, not just to the vein, more beyond the vein to the artery, the extreme end of borderline resectable or locally advanced, where we have given about 6 to 8 cycles of neoadjuvant FOLFIRINOX or gem-nab-paclitaxel, and then given SBRT, and I've ended up operating on patients even after 10 or as per the Mayo Clinic protocol of Mark Truty, total neoadjuvant, TNT, up to 12 cycles. That number is smaller. More numbers get operated in 6 or 8 with chemo. There is more evidence for chemo, less evidence for radio, but I think in an individual case there is still a role for radio, because the R0 resection rates in those who respond to radiotherapy and chemotherapy is perhaps even better, and patients tend to even live longer. But that's still retrospective data. We don't have head-to-head high-quality randomized trials. So I think we will keep evaluating it.
Very true, sir. It was very clear answer from that. But sometimes what we see, like post-operatively, some lymph node which has been very close to the vessels, and I have seen lots of cases in my practice. So those cases, how is the exposure like of radiation? Like usually you see the post-operation.
You mean recurrence which happens after surgery?
No, sir. Sometimes it happens once they are going to resect the surgery, some leftover near the vessels nodes,
so
which we get.
Normally a large number of these patients, whether it's a lymph node, it is normally associated with a PNI and lymphovascular emboli. And then I'm sure my medical oncology colleagues will agree more that this is predominantly a systemic disease. So the American philosophy is to sometimes give local radiotherapy.
Yes.
But the vast majority of people would give systemic chemo. Now, if you have an isolated margin positive, but node negative, PNI negative, LVE negative, then giving localized radiotherapy is what we would do in a small percentage of patients.
Yes, a very small percentage, but we have done it most of the time. Thank you, sir.
So one question is that regarding this neoadjuvant, we have to need the biopsy first, because we have lots of the options here nowadays. Regarding the biopsy, what do you prefer commonly? Because it's a retroperitoneal structure, we have to go for the...
So ideally, again, this is an operator-dependent thing. Vast majority of our tumors, if you can get an EUS with a biopsy, it is the best. And your EUS, despite the intense desmoplasia and the stroma, which is a problem in pancreatic cancer, but maybe it also prevents the cancer from spreading.
Yes.
It's difficult to get into the tissue.
Yes.
But an experienced endosonographer will always do. So I always say that when you have a good endosonographer in a first attempt, 90% of the times I get a diagnosis. 10% of the times we have to do a second biopsy, etc. And then the procedure is more expensive. It is operator dependent. Those needles are more expensive. But if you don't have that facility for any reason, then the second best option is to do a percutaneous CT guided, but not the best advice if your surgeon is still feeling that there is a good chance of offering a good resection.
So once upon a time when the MPD dilatations was the indications of the going for the surgery, is that still exists?
Yeah, if it is resectable disease,
we go for this.
So yeah, you should not keep on waiting for a tissue diagnosis to the point that it is too late. So if you have a double duct sign, if you have ruled out gallstone disease, if you are reasonably sure that it can be either pancreatic head cancer or localized chronic pancreatitis, both of them are justified to offer a Whipple resection. But rule out autoimmune pancreatitis with an IgG4 level. I'm looking at Satish because I'm discussing a case with him presently, which we are doing together, where after 2 attempts at tissue diagnosis, they still don't have a diagnosis. Patient has come with obstructive jaundice, etc. But I just told him that before you do anything, just rule out IgG4 autoimmune pancreatitis. Because if it's autoimmune pancreatitis, course of steroids, and then none of us are required. Only the gastroenterologists are happy.
Thank you, sir. Thank you. Any more questions?
Thank you so much, sir. The questions will keep going, but we have time restraints as well. Thank you so much, Dr. Shailesh Trikhande, sir, for that insightful session. It was really engaging. Please applause for sir. I may please request our chairpersons to be on the stage because we have a special talk now. Dr. Satish will soon join us on the stage as well. So I may request our chairperson to kindly introduce the next speaker.
I have to stand up for this. He is the sir of all the sirs. So that's why I am requesting and proud to announce that Dr. Padma Shri Award holder, Dr. S.H. Advani sir, big round of applause for him. The director and the Department of the Medical Oncology. No mention to say anything about sir. Is the director of the Jeshlok Hospital and Research Center, Mumbai now. Is a renowned most and is the mentor of all of the faculties. Thank you. And pranam.
Check. Hello. Hello. Yeah, good evening. After the wonderful presentation by Dr. Srikhande, it's very difficult to match with him because his presentation was so clear-cut, which shows tremendous confidence and the learning from the hand-on learning for last 25 years. So I think that is where you can really realize the importance of the speakers. There are always the speakers, but some present only the data, which is more of the data from various collections. But here was the solid data and interpretation of actual work. Anyway, I will mention about what is happening in the oncology. As all of you know, oncology has a tremendous turning, I call it turning points. And we have learned in last 50 years. I'm in the practice of oncology for 50 years. And I have seen at least 4 or 5 turning points, or what we also call landmark changes, a landmark paradigm shift in the treatment. First time I noticed this was when we got the drug like cisplatin. Before that we had all the drugs, 5-FU, methotrexate, but they were never good. But cisplatin turned the tables, and that gave us a confidence. It produced a cure. Like there was it produced a cure, particularly in germ cell tumor, which was non-seminomatous germ cell tumor, was totally fatal. But with the introduction of single agent, cisplatin, it turned the point. It became curable. And of course, the cisplatin ultimately got used in many conditions. Even today, we use cisplatin in various diseases, including lung cancer, pancreatic cancer, everywhere. The second change which we noticed was when the drug came, we call it anthracycline, adriamycin. That also made a tremendous impact. And again, you can see that even today it is used in almost all the conditions. Then for 20 years there was very little. But then suddenly what came was another branch of oncology. So apart from the cancer treatment, we had surgery, we had radiotherapy, we have chemotherapy, but now we had what we call it targeted therapy. That made a big impact, and I'm sure since morning you have heard how in the lung cancer domain has totally changed, in the sense that previously lung cancer we never thought that we'll be treating with the tablets, and today we are treating lung cancer with a tablet, particularly ALK positive lung cancer, and there you will find 5 years and 6 years median survival. So I could not imagine that how I was thinking of treating lung cancer with the tablets and producing the long-term benefit. And I think that made a major impact. But lastly, one thing more which turned the tables. Everybody knows immunotherapy. I knew also about immunotherapy 50 years ago. But what was the immunotherapy those days? Was we used to give BCG, melanoma, we used to inject intralesional BCG, and then sometime it will disappear, sometime it will increase. That was the situation. We used to use BCG in many other conditions. Then we used to use polyvalent antigens, multiple antigens from different bacteria, put and give to the patients. But nobody got the real response. The table was turned for the immunotherapy with basic understanding of the immunology. As all of us think that immunotherapy is that you stimulate the immune system and you get the answer. That's absolutely wrong in terms of modern immunotherapy. I'll just, it's not moving. So the whole immunotherapy today, what we are talking about is the center around the T cells. If you understand T cells, you will understand everything about the immunotherapy. While in contrast to the active immunotherapy, it is a B cell. It supposed to produce antibodies, but not in the cancer. Cancer, we need the T cells, which can really make the immunotherapy better. What does it do? The immunotherapy or the immune system gets fortified, and its action is that it detects the tumor cells selectively and then kill it. So that's the difference. This immunotherapy is a selective killing of the tumor cell. How does it do that? All the cancer cells, as you have been told by Dr. Prashant also before, that all the tumor cells have some gene defect, which may be driver, mutation, or any other changes. All of them have the tumor gene defect. Now when the defect in the DNA is there, that defective gene gets transcripted into RNA. So that is also abnormal. And then it produces by translation, it produces the abnormal protein. And where does this protein is living there? On the cell surface. So in other words, all the cancer cells have this tumor antigen, so-called tumor antigen. And this is basically because of the abnormal DNA. Once you have realized that, then the understanding the immune system becomes very easy. Now, since the tumor antigen is there, it is picked up by the dendritic cells and they assimilate it, and it produces the HLA along with the HLA complex. It produces a very strong stimulus, and this then affects the these are the T cells. So you can see over the dendritic cells take the antigen and then stimulate the naive T cells. So T cells are stimulated. They are further activated and ultimately produce the killer T cells. And those killer T cells go and destroy the tumor cells and the tumor dies. So it's so simple that if you have a T cells, they will go and kill the tumor cells selectively. However, in the body, there is never one-way traffic. Everything is regulated. So there is a stimulus, there is an inhibition. So you can see over there at the end that how the T cells which are activated can also be inhibited, because those T cells, activated T cells, produce the inhibitor, and that it inhibits the T cells. So it's a very auto-regulation. So that's what we call it, the death protein 1 that inhibits the T cells. Similarly, at the initial level, where the naive T cells are being stimulated, they also get activated and produce another protein. We call it cytotoxic T lymphocyte antigen 4. What does it do? It auto-regulates the T cells, so the T cells get inhibited. So that's once you understand this basic mechanism. For this basic mechanism, the Dr. Lawrence, he received the Nobel Prize because he understood this mechanism, that how the T cells are stimulated and they are inhibited. So the modern immunotherapy is based on this. There's no auto-stimulation by the antigen and all. Here, what we give in immunotherapy, if you look at it, how the T cells are getting activated and they are getting inhibited. Suppose you want to increase the T cell function. What you can do, you can stimulate the T cells more. They are already stimulated, so you can't increase that. But you can stop the deactivation, inhibition. So if you stop or put the brake on the inhibition, it's a very peculiar, some people don't understand. For me also, it took almost 6 months when people used to show the different figures. It used to be confusing. What are they talking? Break the activation and all. But now you can understand much better that what you have to do is, what is the PD1, a death protein 1 doing? It is inhibiting the T cells. Remove the PD1. How do you remove it? You have antibody and you neutralize the PD1. So PD1 is not there, and therefore the T cells will go on stimulating. The T cells will go on killing the tumor cells. Similarly, the CTL4, that is also the inhibitor, and if you have an antibody against the CTLA4, again you will stop the inhibition and have the better activation of the T cells. So this is a basic. There's no immunotherapy here. It's just the antibodies which you are giving, and it turns, it stimulates the T cells. So I think this is what made the bigger impact. So the first one, the CTLA4, is called the priming phase. There's the first phase of T cell activation. And the later on, the inhibition which occurs, that's the effector phase, which is the PD1. So if we have to stop the activation of the T cells, then we have to, the T cell activation is inhibited by these factors, PD1 and the CTLA4. So what we do? In the case of priming phase, we have antibodies, and that is called the ipilimumab, and that counteracts the CTLA4. So CTLA4 is inhibited, and that's how it works. I'll show you some examples later on. And similarly, when you have got the other monoclonal antibodies against PD1, which are plenty of, whether it's Pembro or nowadays a lot of Indian drugs have come. They are all equally effective and they can be really used in this way. Of course, apart from this immunotherapy, there are other things which have come up, and they are really coming up very nicely. We know that acute lymphoblastic leukemia and lymphoma, they are being treated by what we call it CAR T cell therapy. So when you use the word CAR T cell therapy, again it is a very connotation which does not easily understandable. What it does is CAR T, these are normally the T cells don't have the receptors. They don't have the receptors. But if you inject the gene into the T cells for the receptor, it will develop the receptor. So what people have done is they have developed the receptors for CD20 or CD19. These are the CD19 and CD20 is present on the leukemia and lymphoma. So for that, there's no, on the T cells, there's no receptor for that. But if you inject the T cells with the gene, and that gene produces the receptors, and if the receptor is there, it will go and bind to the CD20 and CD19 and kill the cells. So it is a selective killing of the T cells. That is what has happened with the CAR T cell therapy. So I think understanding of the basic really have allowed us to develop all these new modalities of immunotherapy. I'll just show you some examples. And particularly in the lung cancer. Lung cancer, there are two main therapies. One is targeted therapy, and if you don't have targeted therapy, then you have to use the immunotherapy along with the chemotherapy. And the results have remarkably improved by using these monoclonal antibodies against the immune checkpoint inhibitor. And you can see here that how the survival has improved. Previously, we never used to have the survival of more than even 5% at the end of 2 years or so. And here now we can see that about 10 to 20% of the patients are surviving. In fact, this has allowed us to even think about cure in lung cancer. We have quite a few number of patients who are gone beyond 5 years, and we think that they are cured after the immunotherapy. So I think just look at this, the big tumor and how it has regressed slowly over a period of time. So I think because of the lack of time, I just wanted you to understand the basic of immunotherapy. Once you understood the basic of immunotherapy, it will be so easily integrated. One thing more which you heard in a lecture before, that they were using double immunotherapy. And these double immunotherapy are not selected by the heck of it. You cannot combine Pembro with the other drug like nivolumab. That will not work because both of them, the action is at PD1. So when you are combining the immunotherapy, you have to combine the immunotherapy which works on PD1 and the drug immunotherapy which works on the CTLA4. And then you can get the additive effect. So I think this is a basic understanding of the immunotherapy. And with this, I think the results have remarkably improved. Thank you very much.
Thanks, sir, for sparing valuable time for us. And it is your enthusiasm and zeal for teaching to all of us youngsters and whoever wants to learn. It is really remarkable. So really, sir deserves a standing ovation. So we'll have standing ovation for him. And as per tradition, though it is not questions to be asked, but if somebody have, because this will be one of the lifetime moments for all of us. So if you want to ask anything, please go ahead.
Now it is working. Hello, sir. It was a great talk as usual. I am Amitesh. I am a surgical oncologist. And I was just wondering what your thought process is regarding, for example, endpoints of evidences changing nowadays. Like the golden holy grail is overall survival. But what is your thought process on evidences which are going on surrogate markers like DFS and IDFS, and we are probably forced to change our practice on those evidences. So what is your thought process on that? Shall we go ahead with that endpoints?
Yeah, I think we have to progress, as Srikande said, that we have to learn more, apply and see the results, collect the data and show that it's really effective. That has to be done. So similarly, probably the CAR T-cell therapy will go away with the development of the new ADC, where they are called the T-cell engager. They engage the T-cells directly with the tumor cells. So I think it's a rapidly changing world. The scientific knowledge is coming in tons to us, and that's why people are focusing more and more on a smaller area, because the science is growing so well.
Right, sir. Sir, I have a question. Randomized from 162 sites of 16 countries and 4 geographical regions like Asia, Europe, Oceania, and Northern America. So almost globally they have taken patients, and around 650 patients were randomized for this trial. This trial was global, randomized, double-blind, parallel arm, placebo-controlled and phase 3 study. In first line, they have randomized, they have taken unresectable, locally advanced or metastatic squamous cell carcinoma esophagus, and those who have not received any systemic therapy, PS0 to 1. Randomized to tislelizumab along with chemotherapy versus placebo plus chemotherapy, and chemotherapy could be platinum plus 5-FU or platinum plus paclitaxel. And based on the PD-L1 status, they have stratified to less than 10% or TAP score more than or equal to 10%. The primary endpoint of this study was overall survival in all randomized patients, and secondary endpoint was PFS, overall response rate and duration of response. So this is the primary endpoint, OS in all randomized patients, and they have shown that there was significant improvement in OS, and improved from 10.6 months to 17.2 months, and with a magnitude of 6.6 month improvement is seen in overall survival. So again, the primary endpoint was met, and there was significant improvement in median OS in all randomized patients. Coming to other secondary endpoints like PFS, overall response rate and duration of response, again there was improvement, and a statistically significant benefit was seen in PFS, as well as overall response rate with tislelizumab was around 63.5% versus 42.4% in placebo group, and duration of response was also on the higher side, 7 months versus 5.7 months in placebo group. So again, this drug is improved PFS and overall response rate and duration of response. Coming to safety and tolerability, you can see the bars that this drug doesn't add any extra adverse event to the combination, and that's why the treatment related adverse event was similar in both the arms. So that rationale was 303 var for the first line setting. Now rationale 302, tislelizumab role in the second line setting. That means the patient has progressed on the first line chemotherapy arm. So that's why they took those patients who have progressed after first line of chemotherapy, systemic treatment with performance score well preserved 0 to 1. They randomized 1:1 to tislelizumab, 200 mg, IV 3 weekly versus chemotherapy. That was physician choice of protocol was given, maybe taxane, paclitaxel or docetaxel or irinotecan. So depending upon physician choice of chemotherapy was given, and treatment was continued to disease progression or intolerable side effect. Again, they have stratified depending upon the PD-L1 status, TAP score more than 10 or less than 10%. Again, in that case also, primary endpoint was overall survival in all randomized patients. Secondary endpoint was OS in CPS score or TAP score of more than 10%. And another secondary endpoints were PFS, overall response rate, duration of response, quality of life, and safety. So coming to OS overall, as well as in TAP more than 10%, you can see the improvement of around magnitude of 2.3%, 2.3 months in overall patient, and again magnitude increased from 2.3 to 3.5 months if PD-L1 score is more than 10%. So this drug improved OS versus chemotherapy in all randomized patients as well in patient with TAP score of more than 10%. Another secondary endpoints have shown that PFS, overall response rate, duration of response was also better with tislelizumab. Coming to safety and tolerability, again this drug is well tolerable drug and generally tolerable. There is no safety issues, new safety issues when we compare with chemotherapy, and with lower rates of grade 3 and more side effects was seen with this drug. So in second line, if those patients who have progressed on chemotherapy, in second line tislelizumab can be given with a better safety and tolerable profile. So when we indirectly compare the other immunotherapy drugs like pembrolizumab with chemotherapy, nivolumab with chemotherapy, toripalimab with chemotherapy we have. So there are 4 basic immunotherapy drugs along with tislelizumab are approved in first line setting of esophageal squamous cell carcinoma. You can easily see in this table that this drug, tislelizumab, works very well and almost comparable in terms of median OS, median PFS, overall response rate, and duration of response. So definitely, if possible, we should give this drug to our patient, and as per recommendation, this drug is also approved in first line setting. When we compare in the second line setting, the rationale 302 showed that there was improvement in median OS and median PFS, and the magnitude of benefit was much better than other immunotherapy drug like pembrolizumab and nivolumab. So in second line esophageal squamous cell carcinoma, this drug appears to be better as compared to pembro and nivo in terms of OS and PFS. So coming to network meta-analysis of all these things, the first line setting, the tislelizumab and chemotherapy, when we compare it with pembro, nivo, and placebo with chemotherapy. So tisle with chemo was associated with highest probability of being the most effective treatment and highest likelihood of being the top ranked therapy when we see the Sucra score or P-based score. So this drug is much better than other immunotherapy drug. As well as in PFS also, the tislelizumab was significantly more favorable to nivolumab plus chemotherapy. And tislelizumab chemotherapy was associated with highest Sucra score of 90% and P-based score of 71% for PFS. Again, in objective response rate, although nivolumab was having better Sucra score and P-based score, and tislelizumab is the second in this network meta-analysis. While we see the side effect, definitely placebo have the lesser side effect, but when we compare with other immunotherapy drug, tislelizumab was having better scoring and better tolerable drug. It is a better tolerable drug when we compare with pembrolizumab and nivolumab. This is a forest plot and it's showing that the subgroup analysis of all those subgroups that the benefit of OS was definitely seen in almost all subgroups. Similarly, subgroup analysis of PFS, the tislelizumab with chemotherapy maintained the highest likelihood of being top-ranked treatment in PD-L1 positive tumors. And same is for overall response rate. So to conclude, in this analysis, the tislelizumab with chemotherapy was the highest ranked anti-PD-1 agent for OS, PFS, and grade 3 treatment-related adverse events, and significantly more favorable to nivolumab with chemotherapy for PFS. And collectively, these results highest favorable risk-benefit profile of tislelizumab with chemotherapy and provided a potential rationale to adaptation of use of tislelizumab in esophageal squamous cell carcinoma. So in first-line setting, tislelizumab with chemotherapy have the better tumor response rate and survival outcome, and as well as in the second line also, this drug did very well and significantly showed to improvement in survival and response rate. So thank you so much. This was my last slide, and over to my chairpersons.
Is there any question from the audience? Sir, you wanted to ask?
No, I do not want to ask a very specific question. Nice presentation, Dr. Gunjes. One of my acquaintances is having this kind of esophageal squamous cell CA that I know of. So I want to know what is the cost of this drug compared to others.
So cost is very much affordable, boss, because these drugs, the pharma companies are giving patient assistance program. So all these drugs are now available in patient assistance program. That patient has to buy one cycle, then another cycle of this drug will be given free. And after few cycles, the whole year treatment will be free of cost. So if we compare these drugs like tislelizumab and other toripalimab, we have serplulimab, we have nivolumab, we have generic brand. So yearly cost is around 5 to 6 lakhs.
Okay.
So it is quite affordable, and because of those PAPs and generic brands are now available, many of our patients are now taking immunotherapy in clinics.
Okay. Thank you.
So if you'll allow me, Gunjes, to ask a question.
Sir.
How confident are you in extrapolating the data of this trial or the trials that you have discussed in adenocarcinoma of the esophagus or esophagogastric junction?
Extrapolation in clinics?
Clinics.
So definitely, sir, because of all those available immunotherapies, we are giving in first-line setting and patients are doing well. So in long-term setting, if you see around 15 to 20% of our patients are having a durable response and they are doing good also. In adenocarcinoma also. So in adenocarcinoma, we have drugs like pembrolizumab, nivolumab. The treatment depends on the PD-L1 scoring. If CPS is more than 5, then we can use nivolumab. If CPS is more than 10, we can use pembrolizumab. But these drugs, the newer drugs, tislelizumab or toripalimab, these drugs are coming despite of any PD-L1 positivity. We can give upfront also, and they are doing good in PD-L1 negative patients also, sir.
In your one of the PD-1 binding data with affinity, you showed SPR data of kinetics. Like that, you have data for all other drugs as well, the binding data, how affinity-wise they are?
Affinity-wise what, sir?
You showed one affinity data.
Correct, sir.
Right,
correct.
PD-1, and you showed a strong affinity with that.
Correct, sir.
And then you showed a big table of many drugs possible.
Correct.
Do we have that kind of affinity data for all of these drugs?
Yes, sir. Because in the phase 1 or phase 2 trial, basically we do pharmacokinetics and pharmacodynamic data. And when we see the pharmacodynamic and kinetic data of this drug, it is having the better profile of PK and PD data in comparison to Nivo and pembrolizumab.
Thank you, Dr. Gunjes, for the wonderful presentation. And the next in line is Dr. Animesh Agrawal, who is a consultant in medical oncology at Apollo Hospital, Lucknow, and his topic is raising the bar for ALK NSCLC panel perspective on Crown at 7.
Thank you, Chairperson, sir. Thank you, organizers, for asking me to be here. So, my slides are not visible. So, I
I will be talking about the data for lorlatinib, that is the CROWN trial for ALK-positive NSCLC advanced disease. This first slide is essentially setting the stage why the drug is so hyped up, why we are so happy with it. It is essentially that up to a third of patients, but maybe let us say around 1/4 of all patients who are on an ALK TKI are unable to move on to a second line TKI or chemo or whichever systemic therapy that we would like to use. And the second issue with ALK positive disease is the propensity for brain mets. Indeed, a lot of patients will present with brain metastasis but no other visceral mets. So these are the two core issues that we struggle with when we are dealing with, or let me say used to struggle with, when we are dealing with patients with ALK positive NSCLC. Lorlatinib is a third gen TKI, and it has an excellent blood-brain barrier penetration. Its efficacy there is quite good, as we will see in the future slides. So the phase 3 trial CROWN is a simple enough trial design. First line metastatic disease, NSCLC, ALK positive by local or central testing, and patients randomized 1:1 to receive either lorlatinib at 100 mg OD or crizotinib at 250 mg BD. Crizotinib was the standard of care at that point of time. I mean, that's quite a long time back by now. The patients were stratified by the presence or absence of brain metastasis and their ethnicity. PFS was the primary endpoint. Other oncological endpoints, safety, quality of life were secondary endpoints. The baseline characteristics were well balanced in both arms. As one would expect, there was a preponderance of females. Almost half of the patients were Asian, and most patients were never smokers, over half of them. 25% of these patients did have brain metastasis at presentation as well. This, of course, is the headline number. PFS at 7 years, 55% for patients with brain metastasis, with visceral disease, with stage 4 disease, for patients who were on lorlatinib, versus 3% on crizotinib. These, frankly, are stupid numbers. For all metastatic disease in solid cancer, maybe even for curative intent solid cancer, 7-year PFS of 55% is not a number that we are accustomed to in most malignancies, maybe breast cancer, maybe head and neck sometimes. I mean, these are not numbers that we are used to seeing. When we split these numbers into those patients who had brain metastasis versus those who did not. So for patients who do not have brain metastasis, 56%. For patients who had brain metastasis, 53%. So essentially, the presence or absence of brain metastasis has been rendered irrelevant by this drug. The drug is extremely effective regardless of where we are. And before we start saying that maybe this was just a population where we got good results, look at the data for crizotinib, right? So on the right, we have the patients with brain metastasis on crizotinib. None of them made it past 2 years. So none of the patients were able to stay progression-free on crizotinib after 2 years. So this is it is the biology of the drug that we are seeing here. Another thing that we can see is patients who are event-free at 2 years. So the PFS at 2 years is approximately 70%, and at 7 years it is 56%. So 70, 56. So 80% of the patients, yani 4 out of 5 patients who make it to 2 years are going to stay disease progression free for the next 5 years straight. So that is a very, very impressive statistic again. And okay, so basically the next 2-3 slides are basically chest thumping by the manufacturers. They are really drilling it home that whether the patient has brain metastasis or not, their patients are going to do well. So only 9 patients had an intracranial event progression when they were on lorlatinib. I mean, you should really, really let that sink in. 150 patients took a drug for 7 years in a disease that is known to have a propensity for the CNS, and only 9 of them had intracranial progression over 7 years. That is a staggering statistic. And again, I mean, frankly, this is just the same way of showing, I mean, essentially almost straight line progression-free survival curves. So that is what we are looking at. The cumulative intent, again, I mean, one slide that we should remember, we should always be looking at the depth of response that has been achieved. So the greater the depth of response, the longer the progression-free survival. So we can see that the curve on top, the greenest line, we can see that the 75% PFS at 5 years. These are the patients who had a depth of response of 75% or greater. Okay, so essentially, yes, it's an effective drug. Even if dose reductions are there, the drug continues to be effective. And as far as safety is concerned, that will unfortunately have to not be addressed because I am informed that the chief guest is here. So we will curtail this and move on with the sessions. Thank you for your time.
Thank you, Animesh. It was going very smoothly and we missed it, the complete presentation. All the best. Thank you. Shall we close this session then? Yes. Okay. So with this, I am told to close this session. All the very best for the rest of the program. Thank you.
Hello. Hello, hello. Bada, bada. Hello, hello. Hello, hello, mic check. Hello, hello, mic check. 1, 2, 3, 4. Hello. Hello, hello. Hello, hello, mic check. Hello.
Hello, 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 check. Hello, hello. Hello.
Hello, hello, mic check. 1, 2, 3, 4. Hello. Very warm welcome at Ranchi Cancer Summit 2.0. We have with us as the guest of honor, Honorable Additional Chief Secretary, Government of Jharkhand, Shri Ajoy Kumar Singh sir. आपका बहुत बहुत स्वागत है, अभिनंदन है, जोहार है आज के इस रांची कैंसर समिट 2.0 में. And a very warm welcome to all our distinguished guests present here, eminent doctors, healthcare professionals, researchers, policymakers, and every participant present here. आज हम सभी रांची कैंसर समिट 2.0 के इस महत्वपूर्ण मंच पर एकत्रित हुए हैं और एक ऐसा मंच जहां चिकित्सा, अनुसंधान, जागरूकता और मानवीय संवेदनाओं के साथ मिलकर कैंसर के विरुद्ध संघर्ष को एक नई दिशा देने के लिए हम सभी प्रतिबद्ध हैं. थोड़ी ही देर में हमारे आज के इस समिट के उद्घाटन समारोह के मुख्य अतिथि के रूप में आवर ऑनरेबल चीफ गेस्ट ऑनरेबल मिस्टर जस्टिस श्री महेश शरद चंद्र सोनक, चीफ जस्टिस ऑफ झारखंड हाई कोर्ट, विल बी विद अस. आप सभी से अनुरोध है, कृपया अपनी अपनी जगह पर बैठ जाएंगे। आज के समिट के उद्घाटन समारोह के मुख्य अतिथि महोदय का आगमन हमारे बीच इस परिसर में हो चुका है और बस अब से कुछ ही पलों में हमारे बीच मंचासीन होंगे। Honorable Mr. Justice Shri Mahesh Sarad Chandra Sonak, Chief Justice of Jharkhand High Court, is the chief guest of today's Ranchi Cancer Summit inauguration ceremony. As the guest of honor, we have with us Honorable Additional Chief Secretary, Government of Jharkhand, Shri Ajoy Kumar Singh sir. साथ ही यहाँ पर उपस्थित हमारे सभी आदरणीय सम्माननीय हमारे डॉक्टर्स और जितने भी यहाँ पे डिस्टिंग्विश्ड गेस्ट्स हैं, इस मंच से हम आप सभी का पुनः एक बार स्वागत करते हैं, अभिनंदन करते हैं। अंसारी साहब भी हमारे बीच आए हुए हैं, मंच के नीचे विराजमान हैं। सर, आपका भी हम इस मंच से स्वागत और अभिनंदन कर रहे हैं। मंच पर मैं आमंत्रित करना चाहूंगी मंच पर मैं आमंत्रित करती हूँ सत्सम्मान हमारे गेस्ट ऑफ ऑनर श्री अजय कुमार सिंह सर, एडिशनल चीफ सेक्रेटरी गवर्नमेंट ऑफ झारखंड। सर प्लीज मंच पर आए और स्थान ग्रहण करें सर। साथ ही मैं मंच पर आमंत्रित करती हूँ डायरेक्टर डिपार्टमेंट ऑफ मेडिकल ऑन्कोलॉजी जसलोक हॉस्पिटल एंड रिसर्च सेंटर मुंबई, डॉक्टर एस आडवाणी सर। सर का मंच पर बहुत बहुत स्वागत है, अभिनंदन है। मंच पर मैं आमंत्रित करती हूँ डॉक्टर विजय कुमार मिश्रा, ऑनरेबल चेयरमैन क्रिटिकल केयर एंड एचओडी एनेस्थीसिया मणिपाल हॉस्पिटल रांची। सर प्लीज कम फॉरवर्ड एंड प्लीज बी सीटेड ऑन द डायस। May I invite Dr. Shailesh V. Srikhande, Chief Executive Tata Cancer Care Foundation, मंच पर आएं और स्थान ग्रहण करें। डॉक्टर शैलेश वी श्रीखंडे, डॉक्टर सोनल दीक्षित, रीजनल हेड ऑफ मेडिकल सर्विसेज मणिपाल हॉस्पिटल। मंच पर आप सभी का, हमारे गेस्ट ऑफ ऑनर इन सभी डिस्टिंग्विश्ड गेस्ट का मंच पर बहुत स्वागत और अभिनंदन करते हैं। बहुत बहुत स्वागत और अभिनंदन। हमारे बीच ऑनरेबल चीफ गेस्ट ऑफ दिस रांची कैंसर समिट 2.0 ऑनरेबल मिस्टर जस्टिस श्री महेश शरद चंद्र सोनक, बहुत बहुत स्वागत और अभिनंदन। सभी से अनुरोध है, कृपया राष्ट्रगान के लिए अपनी अपनी जगह पर खड़े हो जाएंगे। राष्ट्रगान के लिए हम सभी खड़े हो जाएंगे।
जन गण मन अधिनायक जय हे भारत भाग्य विधाता, पंजाब सिंध गुजरात मराठा द्राविड़ उत्कल बंगा, विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा, तव शुभ नामे जागे, तव शुभ आशीष मांगे, गाहे तव जय गाथा। जन गण मंगलदायक जय हे भारत भाग्य विधाता, जय हे जय हे जय हे जय 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 हे।
कृपया आसन ग्रहण करें। बहुत बहुत धन्यवाद। आज के इस रांची कैंसर समिट 2.0 में जब हमारे बीच गरिमामय उपस्थिति हो चुकी है माननीय मुख्य अतिथि महोदय की, सर्वप्रथम हम अपने सम्मान की भावनाएं आप तक संप्रेषित कर रहे हैं। वी आर शोइंग आवर happiness to you by presenting shawl and memento. May I request Dr. Satish Sharma, Consultant Medical Oncologist at Manipal Hospital, Ranchi, and convener of this summit, to present shawl to our Honorable Chief Guest and memento also. तालियां भी आप सबकी तरफ से जरूर हों। Honorable Mr. Justice Shri Mahesh Sarad Chandra Sonak, चीफ जस्टिस ऑफ झारखंड हाई कोर्ट। साथ ही ये पेंटिंग स्मृति चिन्ह स्वरूप हम आपको प्रदान कर रहे हैं सर। थैंक यू वेरी मच सर। Again, I would like to request Dr. Satish Sharma, so please welcome our guest of honor, Shri Ajoy Kumar Singh sir, Additional Chief Secretary Government of Jharkhand. सर का हम स्वागत अभिनंदन करते हैं अंगवस्त्र के साथ और स्मृति चिन्ह स्वरूप एक यादगार पेंटिंग हम आपको प्रदान कर रहे हैं। तालियों की गूंज भी स्मृतियों में रहनी चाहिए। थैंक यू सर। पुनः एक बार डॉक्टर सतीश शर्मा से आग्रह होगा, हमारे बीच डॉक्टर S.H. आडवाणी सर हैं, डायरेक्टर डिपार्टमेंट ऑफ मेडिकल ऑन्कोलॉजी, जसलोक हॉस्पिटल एंड रिसर्च सेंटर मुंबई। सर का हम स्वागत अभिनंदन करते हैं। तालियां जोरदार हों। धन्यवाद सर। सर से ही पुनः आग्रह होगा, हमारे बीच डॉक्टर शैलेश वी श्रीखंडे सर हैं, चीफ एग्जीक्यूटिव टाटा केयर सेंटर फाउंडेशन, टाटा कैंसर केयर फाउंडेशन, आपका सर हम स्वागत अभिनंदन करते हैं डॉक्टर शैलेश वी श्रीखंडे सर का शॉल और ये मोमेंटो के साथ। Thank you very much, sir. Once again, I would request Dr. Satish Sharma, sir, to present shawl. Dr. Vijay Kumar Mishra, Chairman, Critical Care and HOD Anesthesia, Manipal Hospital, Ranchi. ये शॉल और स्मृति चिन्ह स्वरूप पेंटिंग हम प्रदान कर रहे हैं। Thank you very much, sir. Once again, I would request Dr. Satish Sharma, Dr. Sonal Dikshit हैं मंच पर, Regional Head of Medical Sciences, Manipal Hospital. आपका हम अभिनंदन करते हैं, स्वागत करते हैं ये अंगवस्त्र के साथ और स्मृति चिन्ह स्वरूप ये पेंटिंग हम आपको प्रदान कर रहे हैं। बहुत बहुत धन्यवाद सर। आज हम सभी यहाँ पर बहुत ही महत्वपूर्ण समिट रांची कैंसर समिट 2.0 में एकत्रित हुए हैं। एंड वी ऑल नो कैंसर इज नॉट merely a medical challenge, it's a social, emotional and economic concern. Summits like these inspire collaboration, innovation and hope. कैंसर से लड़ाई केवल दवाइयों से नहीं बल्कि जन जागरूकता समय पर लाने, जांच और सामूहिक प्रयासों से जीती जा सकती है। तो आइए इसी आशा और उम्मीद के साथ कि हमारे इस उद्देश्य में ईश्वर हमें हर समय सहायता प्रदान करे, हम एक ऐसा दीप प्रज्वलित करें जो हमारे मार्ग को प्रशस्त करे। मैं सादर निवेदन करती हूँ हमारे लॉर्डशिप से कृपया दीप प्रज्वलित कर आज के इस समिट के उद्घाटन सत्र का विधिवत शुभारंभ करें। तमसो मां ज्योतिर्गम्य। और आप सभी से गेस्ट ऑफ ऑनर और हमारे सभी मंचासीन अतिथिगणों से आग्रह होगा कृपया दीप प्रज्वलन में आप सहयोग करें। तमसो मां ज्योतिर्गमया। Thank you very much, Lordship. Thank you very much, our guest of honor and all the respective guests. May the light continue to inspire new hope in light direction. Every meaningful initiative begins with a vision, and every successful summit is driven by dedicated leadership. So now it's time to invite, it's our privilege to invite the convener of Ranchi Cancer Summit 2.0, Dr. Satish Sharma, Consultant Medical Oncologist, Manipal Hospital, Ranchi, to deliver the welcome address. Sir.
गुड इवनिंग, आप सभी को मेरा नमस्कार। लास्ट टाइम मैंने जब स्पीच दिया था तो इट वाज अ मेड अप स्पीच जो आपको एक कागज़ में दिया जाता है, एंड बिकॉज डिग्नेटरीज थे एंड उसके हिसाब से वो स्पीच बोला था। इस बार मुझे आई थिंक हमारे स्टेट के सिस्टम से आई वॉज सो कम्फर्टेबल, आई थॉट कि मैं अपने लोगों के लिए बोल सकता हूँ. सो मेरा जर्नी चालू हुआ कि मैं 12th क्लास यहाँ से किया, उसके बाद एज यूजल आई वेंट आउटसाइड, 15 साल बाहर था. देन सडनली माई पेरेंट्स टोल्ड कि आई बिकेम ऑनकोलॉजिस्ट, आई वॉज अबाउट टू जॉइन. मैं कोकिलाबेन में था, मैं हिंदी में रखूँगा, बहुत सारे हमारे पेशेंट्स हैं जो सुन रहे हैं. सो मेरे पेरेंट्स से बोला कि आई वॉज अबाउट टू ज्वाइन कोकिलाबेन में पढ़ा था, वहीं वापस ज्वाइन था, बुला रहे थे, जाना था, नेचुरल है, मुंबई से अच्छा क्या जगह होगा. एंड माई पेरेंट्स टोल्ड नहीं, यहाँ पे आना ज़रूरी है और वी आर देयर, एवरी वन इज़ देयर, वाई डोंट यू कम. एंड अंसारी अंकल नीचे बैठे हुए हैं, मेरा डीएम ख़त्म हुआ उसके पहले ही स्टार्टेड कॉलिंग मी 3 months बिफोर, आपका ख़त्म होने वाला है, मुझे पता है, आप आइए. एंड he is the person who has brought cancer care to Jharkhand. So I think a big applause to him. मंच पे बैठे हुए चीफ जस्टिस साहब, मैं उनसे पहली बार मिला. एंड द फर्स्ट टाइम वी मेट वी डिस्कस नथिंग एल्स, और मैं 3-4 बार उनको मिल चुका हूँ और हमने कुछ और डिस्कस नहीं किया हेल्थ के अलावा. इट वॉज हेल्थ, इट वॉज कैंसर. सो नेचुरली मैंने बोला कि सर नेक्स्ट टाइम मैं भी जब भी कुछ करता हूँ, मन में सोचा कि आपको ही बुलाना है मुझे. हमारे ACS साहब हैं अजय सर, तो यू विल नॉट फाइंड, मैं बहुत सारे स्टेट में रहा, मॉर्निंग भी सर से बात हो रही थी, उसके पहले भी बात हो रही थी. मैं बाहर बहुत स्टेट्स में रहा हूँ, बहुत जगह ऐसे जगह रहा हूँ जहाँ पे मुझे लोग मिलते हैं, तो आपको इनसे ज़्यादा अप्रोचेबल हेल्थ सेक्रेटरी या वो आपको नहीं मिलना है. एंड दिस इज़ नॉट ऑन द बिकॉज मैं डायस पे हूँ, सर आए हैं. मैं इनको पहली बार मिला एंड दैट टाइम तो मैं जस्ट आया ही था. एंड ही फर्स्ट थिंग टोल्ड कि आप मेडिकल ऑनकोलॉजिस्ट हैं, तो बोले हाँ. तो बोले कि देखिए हम सदर में प्लान कर रहे हैं, मेडिकल कॉलेज में प्लान कर रहे हैं. मैं आई वॉज अमेज्ड बाई हिज क्लियरिटी कि ही नोज कि हेल्थ कैंसर इज गोइंग टू बिकम अ प्रॉब्लम एंड वी नीड टू रीच टू डिस्ट्रिक्ट्स. एंड सर के एफर्ट से हमने रामगढ़ में डे केयर सेंटर चालू किया, विच इज़ अगेन नॉट अ कैपिटल सिटी. इट इज़, बहुत सारे ऑनकोलॉजिस्ट है, यू विल बी अमेज्ड टू नो दैट झारखंड बीइंग बहुत सारे वर्गों में पिछड़ा हुआ है, बट कैंसर में इट इज़ वन ऑफ द स्टेट्स विच इज़ गिविंग इम्यूनोथेरेपी इन आयुष्मान भारत. द नीड ऑफ इम्यूनोथेरेपी. तो सर हैज़ बीन पाइनियर. मैं जब कॉलेज में था उस समय एक टाइम्स ऑफ इंडिया का एक आर्टिकल था या किसी न्यूज़पेपर का था, द स्टेट विच हैज़ नॉट ओपनड अ मेडिकल कॉलेज पोस्ट इंडिपेंडेंस, इट वॉज झारखंड. पोस्ट इंडिपेंडेंस, ये मैं 2010 की बात बता रहा हूँ, देयर वॉज नो मेडिकल कॉलेज विच इज ओपन पोस्ट इंडिपेंडेंस, ना सरकारी ना प्राइवेट. नाउ वी हैव मणिपाल टाटा मेडिकल कॉलेज इन जमशेदपुर, जहाँ से हमारे 2-3 RMOs हैं वहाँ से. एंड द क्वालिटी ऑफ एजुकेशन इज़ क्वाइट गुड एंड वी आर नॉन वर्ज कि मैं सर से डिस्कस कर रहा था 2-3 साल में विल सी मेनी मोर प्राइवेट मेडिकल कॉलेज टू बी ओपन. तो सर इज़ लाइक अ poster for healthcare, both for private and health sector for us in Jharkhand. So I wanted him to come. सर बोले इतने बड़े लोग डॉक्टर्स आएंगे, उसमें मैं क्या बोलूँगा. बोले सर आपका विजन ही इम्पॉर्टेंट है, द कैप्टन इज मोस्ट इम्पॉर्टेंट. एंड वी आर ब्लेस्ड टू हैव ACS हेल्थ सेक्रेटरी साहब अजय सर जैसे. देन आडवाणी सर, ही हैज़ बिन मेंटर. हमने अगर किसी को मेडिकल ऑनकोलॉजिस्ट बनना है तो इट इज़ ही फर्स्ट नेम ही लेयर इज डॉक्टर आडवाणी. एंड हम तो सर विल नॉट रिमेंबर, आई वॉज अ पोस्ट MD resident and I was in breach candy for 3 months. And I was on 4th floor. 4th floor is supposed to be the most VIPs floor. And I got a call in night 10 o'clock कि आडवाणी सर is coming, तो आपको 4 बजे आना होगा मॉर्निंग में. तो जनरली ऐसा नहीं होता, बट मैं बोले कि इट्स नॉट कंपल्सरी, इवन द नाइट ड्यूटी डॉक्टर कैन कवर फॉर यू, बट इट इज़ जस्ट वी आर टेलिंग यू. एंड देन बोला नहीं सर को मिलना है मैं एक बार. मैं तो फिर आई वेंट टू 4 o'clock. सर केम टू सी पेशेंट एट 4 o'clock in the morning. एंड दैट वॉज द फर्स्ट टाइम आई मेट हिम एंड दैट इंस्पायर्ड मी कि मुझे मेडिकल ऑनकोलॉजिस्ट ही बनना है. Then we have more inspiring. Dr. Salish sir is there, and
I think after I finished my MD, the first subject which I chose was MS General Surgery in Mysore Medical College. मैंने लिया, सर बहुत खुश नहीं होंगे, मैं 2 दिन में वो छोड़ दिया मैंने. मुझे लगा surgery is not cup of my tea, but then yes, sir has been an inspiration. Vijay sir has been a pillar for our hospital at Manipal, Ranchi, and finally Sonal Dikshit ma'am, who is there and who is guiding us. So I will, from organizing team and for my core committee, I'll like to have you all in such a huge numbers, and thank you for everything. And I was discussing with Ajay sir, this is like we had 700 registration for today. Until tomorrow we will have crossed 1,000. This is probably one of the biggest cancer summit in Eastern India. And this is different because we are not calling on your doctors. We have patients, we have NGOs. We want everyone to interact and the fear of cancer should go. That's the motto. Thank you.
Thank you very much, sir, for your welcome address. And now may I invite Dr. Vijay Kumar Mishra, Honorable Chairman, Critical Care and HOD Anesthesia, Manipal Hospital, Ranchi, for your address, sir. Welcome with a big hand.
Good evening. Honorable Chief Justice Sunak sir, Honorable Additional Chief Secretary Ajay Singh sir, Dr. Advani sir, Dr. Srikhande, Dr. Sonal Dikshit madam, and my younger colleague Satish, and all the distinguished guests here present in this auditorium, and the people from media. It's a matter of privilege and honor for me to be standing here and addressing this august audience, and to welcome you all to this inauguration ceremony of Ranchi Cancer Summit 2.0. The reason why such summits are essential is something that I would want to highlight on. Cancer is not something that is unknown or has not, it's probably touched everybody in this hall in one way or other, through their family, through their extended families. So none of us are untouched by cancer. And there's a lot of treatment, there's a lot of innovation, there's a lot of expertise that has come in the market. But still, the crucial challenge that is remaining with the cancer treatment and management is, I think, the awareness. The awareness has been the biggest bottleneck in the treatment and management of cancer. Sorry about the quality of my voice, just running a bad throat. So yeah, so the awareness has been a real challenge, and this is where summits like this will ensure that when we have the experts, the healthcare people, the policymakers, the people who have a voice in the society coming together to talk and deliberate upon matters which will go far into the population to increase and deliver awareness to the people in the remotest of corner about the possibilities that cancer treatment has with it. It's not a one man's job, it's neither a one hospital's job, it's neither a one institution's job to beat cancer. It's impossible. It's the collaborative effort of everybody, and everybody like us sitting in this hall together, sharing expertise, knowledge, that together we can beat the cancer. At Manipal, I take pride in, I take pride in sharing a few things. That at Manipal, we believe in this motto that cancer is not only about treatment. It's more than that. Treatment is a part of it, but prevention, education, emotional support, long-term care. These are all integral parts of cancer care. And that's where we at Manipal are strongly working on it. Recently, we have invested heavily, both financially and in terms of manpower at different units of Manipal Hospital in the care of, improving the care of cancer delivery by means of investing in advanced equipments, developing building infrastructures. At Manipal Ranchi, for those of you who are familiar with the hospital, we have set up a dedicated floor for oncology services, a separate ICU for oncology. We have set up MRI. We are in the process of setting up PET scan and the radiation unit. So we are actively into the care of the cancer. And as I said, not just the treatment part, but everything around it. And again, this forum has given me the opportunity to come and stand in front of you to just express the things that we at Manipal are doing. But I would be more happy if this message goes out in the society that a collaboration between all of us is what will take it to the last person in the population. I think I'll stop there. Thank you very much.
Thank you very much, sir, for your address. And now I would like to invite Dr. Sonal Dikshit, Regional Head of Medical Services, Manipal Hospital, for your vision address, ma'am. Please welcome with a big hand.
A very good evening, ladies and gentlemen. Honorable Chief Justice of Jharkhand High Court, Mr. Ajay Kumar Singh, Chief Secretary, all the dignitaries on the dais, off the dais, and my colleagues. It's an honor for me to represent Manipal Hospitals at such a prestigious gathering. And I'll take 2 minutes of yours to tell you about the vision of Manipal as far as cancer care and oncology is concerned. You might be aware that Manipal Hospitals is the largest chain of hospitals in India when it comes to the number of beds. So we are 49 hospital chain in various states of India. As far as the state of Jharkhand is concerned, the two anchors for us here are a very strong institution, the name of Bhagwan Mahavir Manipal Hospital, Ranchi, and our sister organization, Tata Manipal Medical College and Hospitals in Jamshedpur. So between these two hospitals, we are taking care of comprehensive cancer care. And I think, rightly mentioned by my predecessors, cancer care is the need of hour. The number of cancer cases are increasing all around, not only in Jharkhand, but everywhere in India. And there is a need for us to step up and improve the facilities available. So as far as Manipal is concerned, our core values of patient centricity, ethical practice, and clinical excellence, these guide us in whatever we do. So far, we have an excellent clinical expertise in the field of medical oncology, surgical oncology, and we try to provide not only, good clinical talent and good world-class infrastructure, but what is more important is care with compassion. So that is what we want to differentiate us. We should be known by that we provide compassionate care. And as rightly mentioned by Dr. Mishra, we are trying to include radiation oncology as well. So we are going in for a linear accelerator so that all kinds of cancer and every stage of cancer can be treated in nearer home, and patients don't have to travel to bigger metro cities for treatment of cancer. So every, successful surgery, every chemotherapy, every life touched is what we are aspiring to do, should be available nearer home, in Jharkhand itself, in Ranchi itself. That is the aspiration. With this, I would like to congratulate the organizers of this conference for organizing such a wonderful conference, very, very pertinent topic, and for giving me an opportunity to speak. So thank you very much. Have a nice evening ahead. Thank you.
Thank you very much, ma'am, for your vision address. And now, I would like to invite Dr. Shailesh V. Srikhande, Honorable Chief Executive, Tata Cancer Care Foundation, for your address, sir.
Good evening to all of you, Honorable Chief Justice Sonak sir, Ajay Kumar Singh ji, Dr. Advani, Satish, and the other dignitaries on the dais. We have heard something which is very similar by the previous speakers. Having spent 25 years at the Tata Memorial Hospital from 2000 till December 2025, the one thing I did notice was that the highest incidence of cancers predominantly is in the north and the northeastern states of India, which made us into the kind of referral center that we are today. If Tata Memorial is taking care with its other hospitals across the country, only a little over 1.3 lakh patients as a footfall of new registrations of cancer. We would see about 75,000 new patients of cancer every year, just right alone in the heart of Mumbai, where I'm spearheading the development of a brand new Tata Memorial in the form of the Platinum Jubilee Block. But having said that, Tata Memorial caters to 10% of India's cancer burden. We are in the midst of a cancer epidemic, not in the coming future, but now. And in a few years, we are also going to be having 30% of our population, which is going to be a geriatric population as well. The purpose of telling you this is that the kind of figures that are staring at us is frightening. Dr. Satish needs to be congratulated for trying to not just organize a medical oncology conference, but for trying to create the cancer ecosystem. So my congratulations to you in the sense that you've got all stakeholders involved in this venture. But since Tata Memorial treats only 10% of cancers, that's where it was only a natural transition for me after being the head of cancer surgery for 15 years and serving as the deputy director of Tata Memorial to take over as the chief executive of the Tata Cancer Care Foundation. Certainly, we have identified areas which need more attention. And therefore, we have the Ranchi Cancer Hospital and Research Center, a beautiful facility. When I came here, I've already been here 4 or 5 times this year. But when I came here first, I said that I wish I was 20 years younger. I'm still young now, but I wish I was 20 years younger, that I would work in such a beautiful hospital, because it's already more or less a comprehensive cancer center. Fantastic daycare chemotherapy facilities, 2 state-of-the-art radiation oncology machines, taking on a lot of workload thanks to our director, Dr. Sharan, and his very capable team members. What I'm trying to say is that centers like Manipal and Tata Research Cancer Centers are all coming up in Ranchi. So we will certainly be able to try and achieve the ultimate goal in a low and a middle income country, that affordability, accessibility, and availability of care, facilities, infrastructure, and the necessary manpower is going to evolve and develop as we move ahead. So through that perspective, whether it comes to training of nurses, whether it comes to training of medical physicists, whether it comes to supporting personnel in the world of oncology, beyond us surgeons and medical oncologists and radiation oncologists, There is too much of work to be done in terms of research, epidemiological studies to really know what is the ground reality. So the number of districts that we are going to be getting into across Jharkhand is something which would not be possible without the kind of fantastic support from Jha sir and so many of you, for which we are grateful, because the thing that I told you was about affordable healthcare. When we speak about affordable healthcare, India continues to live in different centuries at the same time. So though we become a low and a middle income country, what we see in the West, the United States, Western Europe, Japan, and now China, is only 6% of what the world gets. We belong to the remaining 94%, where our ground reality is different. And that's where the ability to reach out to 60 to 70% of our patients who would need subsidized, high-quality, evidence-based care is rightly going to be available. It's already available, and it would be our mission to enhance this care and continue to contribute to future meetings like this Ranchi Cancer Summit, not just by coming, attending, and giving a lecture and having a nice evening, but presenting our own data. I think I gave a lecture some time ago that giving a lecture is one, documenting your data is another, publishing your data is what is the work that is really done. So I think this is where the quality of these summits will also keep on increasing as we go ahead. And I'm very excited and look forward to future Ranchi Cancer Summits. And thank you for involving me and for inviting me for this important event. Thank you so much.
Thank you very much, sir, for your very inspirational address. And now I would like to request Dr. S.H. Advani, sir, Director, Department of Medical Oncology, Jaslok Hospital and Research Center, Mumbai, for your address, sir. तालियों के साथ स्वागत करें.
Respected Chief Guest and Mr. Ajay Kumar, the Health Secretary, and all the dignitaries on the dais and off the dais. I always wonder, what is this meeting for? We call it CME, Continued Medical Education Program. What is the purpose of that? The purpose is single. It's a single purpose for which these meetings are made. The purpose is that in future, not only oncology, but every field is going to expand. Science is expanding too fast. That's where AI is really coming and supporting us, because our brain alone is not enough. We need another brain to imbibe all the knowledge which is coming up. And one of the way to imbibe more knowledge is all these meetings. And I must say that 50% of my knowledge, which I acquired over a period of time, has come from these meetings, where you meet the individual, you meet the people who are doing the good work and enhance your capabilities and capacity. Particularly, I feel in the field of oncology, the numbers are increasing. As Dr. Srikhande mentioned, it is an epidemic of the cancer. Cancer is number 2 today after the cardiac diseases. And soon it may become number 1 as well. And what does that mean? This epidemiology tells us that we have to be prepared for that. The number of physicians, surgeons, radiotherapists, and all other paramedicals is not enough today to deal with the cancer which is existing. As he said, 70 or 80% of the people are still far off, living at the distant place. They can't reach to the main hospital. Forget the Tata Memorial Hospital, but they can't even go to the nearby hospitals as such. So we have to move. We have to move to the periphery. And I'm so happy that today at Ranchi, where I remember 35 years ago when I visited here, there was no medical oncologist here. And today you have a medical oncology department, you have a separate radiation oncology department, and the surgical oncology as well, and the pure cancer hospital along with the Manipal hospital taking care of the cancer patient. So I think that's a really positive progress which we are seeing. An important thing is all of us, today I realized that almost maybe more than 50% of the audience here is not oncologists, they are non-oncologists, which is very important because ultimately it is the people at the periphery who makes the difference. They have to be aware about the disease. So the cancer awareness is the most important factor. So it's only when the physicians, surgeons, general practitioners are aware about the cancer that they will diagnose the disease at the right time, they will suspect the disease at the right time. And I think what we have to develop is the sense of high index of suspicion at the level of general practitioner, so that they should not miss the case, diagnose at the least suspicion, and make sure that that cancer is either confirmed or excluded. That's a very important factor in overall improvement. So I'm again very thankful to the organization, particularly Dr. Satish, who have made this big indent in terms of making all of us together to discuss various facts about the cancer, how we can diagnose the disease early, how we can treat accurately these patients, and how we are going to learn more and more for the future application of the new technology. Few words. Again, I would like to thank each one of you for the patience hearing. Thank you.
Thank you very much, sir, for your address. And today, we have with us a visionary administrator whose leadership has played a significant role in strengthening the healthcare system of Jharkhand. It's my privilege to invite our guest of honor, Additional Chief Secretary, Government of Jharkhand, Shri Ajoy Kumar Singh, sir, for your address, sir. तालियों के साथ स्वागत करें.
Thank you very much. Honorable Chief Justice Jharkhand, Dr. S.H. Advani, Dr. Sunal Dikshit, Dr. Sailesh Khande, Dr. Vijay Mishra, Dr. Satish Sharma, और इस सभागार कक्ष में उपस्थित सभी चिकित्सकगण, रिम्स के डायरेक्टर, देवियों सज्जनों, प्रेस और मीडिया के प्रतिनिधिगण, सबसे पहले तो मैं ऑर्गेनाइजिंग कमेटी और ख़ास करके डॉक्टर सतीश शर्मा जी का बहुत बहुत शुक्रिया अदा करना चाहता हूं कि आपने इनवाइट किया और मुझे अपनी बात रखने का मौका दिया. पिछले वर्ष भी कैंसर समिट रांची में हुआ था और उस समय भी मैं प्रेजेंट था, और दूसरे समिट का भी मैं साक्षी हूँ, आज भी प्रेजेंट हूँ यहाँ पर. और ये सब्जेक्ट हमारे लिए, आपके लिए, सभी के लिए बहुत ही महत्वपूर्ण है, और डॉक्टर के दृष्टिकोण से ही नहीं, एक मानव होने के नाते भी उसी दृष्टिकोण से भी बहुत ही महत्वपूर्ण है. जैसे कि हमारे पहले डॉक्टर विजय मिश्रा बता रहे थे कि यह बीमारी ऐसी है जिससे कोई भी अछूता नहीं है, कोई भी परिवार अछूता नहीं है, या एक्सटेंडेड फैमिली हो, फैमिलीज़ हो. जिस सोसाइटी में हम रहते हैं उस सोसाइटी में कहीं ना कहीं कोई ना कोई इस बीमारी से पीड़ित है. यदि हम ग्लोबल स्टैंडर्ड देखें, कुछ डेटा पे यदि हम प्रकाश डालें, तो WHO के अनुसार जो एस्टिमेट है कि ग्लोबल कैंसर बर्डन जो है वो 20 मिलियन यानी 2 करोड़ नए केसेस हम लोग के सामने आए हैं. 2 करोड़ पूरे विश्व में केसेस आए हैं, और उसमें से 9.7 मिलियन जो है वो डेथ्स हैं, जो 2022 का आंकड़ा है. 90 लाख के करीब लोगों की मृत्यु हुई है इस बीमारी से. और आने वाले समय में 2050 तक का जो एस्टिमेट है उसमें 77% इसमें इन्हांसमेंट होगा, यानी कि ये करीब करीब 20 मिलियन से 35 मिलियन 3.5 करोड़ डिजीज बर्डन जो है वो वर्ल्ड वाइड हो सकता है। और यदि इंडिविजुअल रिस्क फैक्टर्स यदि हम देखते हैं तो 75 इयर्स तक पहुंचते पहुंचते लगभग ग्लोबली देखा गया है कि 20% लोगों को कैंसर हो ही जाता है 75 इयर्स तक पहुंचते पहुंचते, और जबकि नेशनल स्टैंडर्ड हमारे देश में यह 10% का ही आंकड़ा है, यानी विश्व के दृष्टिकोण से देखें तो हम बेटर प्लेस्ड हैं। हो सकता है कि ये एक्चुअली सब लोगों का जो है वो स्टैटिस्टिक्स नहीं होगा, डेटा भी हमारा हो सकता है एक्यूरेट नहीं होगा, लेकिन अभी तक जो भी डेटा, जितना भी एक्यूरेट डेटा है उसमें हमारे पास है कि ग्लोबल स्टैंडर्ड से हम बेटर हैं इसमें, जो नेशनली हैं उसमें। कैंसर का इंसिडेंस यदि हम देखते हैं तो उसमें जो हमारे देश का हम लोग देखते हैं इंडिया का, तो अभी 529 2022 में था पर लाख पॉपुलेशन जो इंसिडेंस ऑफ डिजीज है, जो कि आने वाले समय में 549 हो सकता है पर लाख ऑफ पॉपुलेशन। यानी यदि स्क्रीनिंग करेंगे हम 1 लाख की जनसंख्या को तो 540 के करीब, 529 के करीब मरीज मिलेंगे जो कि कैंसर से पीड़ित हो सकते हैं। झारखंड के दृष्टिकोण से यदि हम देखते हैं तो झारखंड का कोई हमारे पास बहुत एक्यूरेट डेटा नहीं है, क्योंकि हम लोगों ने अभी तक कैंसर रजिस्ट्री जो होती है बनती है उसको अप टू डेट नहीं किया है। दो हम लोगों ने इस बीमारी को नोटिफाई भी किया है, लेकिन नोटिफिकेशन के बाद भी जो डेटा कंपाइलेशन होना चाहिए था वो प्रोटोकॉल अभी हम लोग सेटअप कर रहे हैं ताकि आने वाले समय में बेटर हमारे पास आंकड़ा हो सकता है। लेकिन जो डेटा हमारे पास है, जो ICMR का डेटा है और जो टाटा कैंसर केयर फाउंडेशन ने जो डेटा स्टैटिस्टिक्स हमारे सामने रखा है, उसमें ये रखा है कि हमारे जो स्टेट में जो इंसिडेंस है डिजीज का वो 70 पर 1 लाख पॉपुलेशन है। 71 लाख पॉपुलेशन बहुत कम है, क्योंकि नेशनल आंकड़ा 529 है, तो हम भी उसी के आसपास ही होंगे, लेकिन हमारा डेटा एक्यूरेट नहीं है आज के डेट में। और सबसे ज़्यादा जो अलार्मिंग सिचुएशन हमारे सामने ये है कि जो सबसे ज़्यादा केसेज हैं, जो ब्रेस्ट कैंसर के केसेज हैं, वो हमारा यहाँ पे डिटेक्शन जो हो रहा है वो 3rd स्टेज में होता है, और 45% केसेज स्टैटिस्टिकली देखेंगे तो 48% जो है वो इसका डिटेक्शन 3rd स्टेज में होता है। उसके बाद ट्रीटमेंट बहुत ही मुश्किल हो जाता है। इसलिए जो इम्पॉर्टेंट स्टेप्स हम लोग को लेना चाहिए और हम लोग ले भी रहे हैं, उसमें नंबर 1 जो स्टेप है उसमें अवेयरनेस क्रिएशन एंड लार्ज स्केल, मास स्केल की स्क्रीनिंग की आवश्यकता है। अवेयरनेस के लिए मुझे बहुत खुशी है कि इस तरह के वर्कशॉप्स यहाँ पे हो रहे हैं, लेकिन हमें यहाँ तक ही सीमित नहीं रखना होगा, इसको हर एक डिस्ट्रिक्ट स्तर पे ले जाना होगा और हर एक पंचायत स्तर पे ले जाना होगा, तभी हम लोग मास स्क्रीनिंग कर पाएंगे। लेकिन फिर भी हम लोगों ने जो मास स्क्रीनिंग किया है, जो आयुष्मान आरोग्य मंदिर है, जो हमारे हर एक पंचायत में है, लगभग 4000 आयुष्मान आरोग्य मंदिर हैं, और वहाँ पे जो हम लोगों ने स्क्रीनिंग किया है अब तक 1.28 करोड़ पॉपुलेशन का स्क्रीनिंग कर चुके हैं हम लोग, जो कि ऑलमोस्ट मोर देन जो हम लोग एवरेज पॉपुलेशन जो 30+ ईयर्स का जो स्क्रीनिंग करते हैं देखेंगे तो उसमें लगभग 50% के आसपास स्क्रीनिंग हम लोगों ने किया है 1.28 करोड़ पॉपुलेशन का। और ये स्क्रीनिंग सिर्फ 3 कैंसर जो हैं, जिसमें कि सबसे ज़्यादा होता है, जिसमें ओरल कैंसर हैं, सर्वाइकल कैंसर हैं, ब्रेस्ट कैंसर, इसकी स्क्रीनिंग हम लोग लार्ज स्केल पे आयुष्मान आरोग्य मंदिर में हम लोग कर रहे हैं। और जून 2026 तक का हमने बताया कि 1.28 करोड़ जो हम लोगों ने पॉपुलेशन का स्क्रीनिंग किया है, उसमें से 2.13 लाख करीब करीब देखेंगे तो लगभग 2% लैक्स केस ऐसे मिले हैं जिनमें कि फर्दर एग्जामिनेशन की ज़रूरत थी। 98% बिल्कुल क्लीन है, लेकिन 2% ऐसे पॉपुलेशन है जिनको फर्दर इन्वेस्टिगेशन, फर्दर टेस्टिंग की ज़रूरत पड़ी, और वो हम लोग कर रहे हैं। और उसमें से 670 लोग थे जिनको कि डायग्नोज किया गया इस डिजीज़ से। तो ये लार्ज स्क्रीन जो हम लोग कह रहे हैं कि अवेयरनेस होना चाहिए, तो सबसे पहला स्टेप जो है अवेयरनेस हमारा पूरे गांव के स्तर पे, हर एक स्तर पे होना चाहिए। और उसके बाद स्क्रीनिंग बहुत ज़रूरी होती है, तो स्क्रीनिंग हम लोग कर रहे हैं। दूसरा, जो स्टैटिस्टिक्स कंप्लीटली डेटा एक्यूरेट होना चाहिए, उसके लिए हम लोगों ने राज्य स्तर पे कैंसर को नोटिफाइबल डिजीज़ बना दिया है, उसको नोटिफाई कर दिया है। लेकिन डेटा जो प्रोटोकॉल है वो हम लोग डिसाइड कर रहे हैं, और जल्दी ही प्रोटोकॉल डिसाइड करेंगे तो हमारे पास स्टैटिस्टिक्स जो है वो कंप्लीट एक्यूरेट स्टैटिस्टिक्स हो जाएगा। जहाँ तक ट्रीटमेंट की बात है, तो ट्रीटमेंट में जो डे केयर सेंटर्स हैं वो पूरे स्टेट में हम लोग 8 डे केयर सेंटर्स चला रहे हैं, और ये अभी भारत सरकार का भी बहुत ज़्यादा फोकस है। और बजट 2026 में भी और 26-27 में भी आया है कि हर एक डिस्ट्रिक्ट में डे केयर सेंटर्स होना चाहिए। वहाँ पे जो केमोथेरेपी है, इम्यूनोथेरेपी है या रेडिएशन है, वहाँ पे ये जो सुविधाएं उपलब्ध कराई जाएं। और इस साल के अंत तक हम लोग भी 24 ज़िलों में डे केयर सेंटर स्थापित करने के लिए हम लोग प्रयास कर रहे हैं। फोर्थ, जो टर्शियरी हेल्थ केयर, जो टर्शियरी केयर के सेंटर्स में है, तो आपको जैसे बताया कि रांची कैंसर हॉस्पिटल एंड रिसर्च सेंटर यहाँ पे इस्टेब्लिश होके काम कर रहा है। और इसके साथ ही साथ जो रिम्स में भी हमारा 3 ऑन्कोलॉजी डिपार्टमेंट है, ऑन्को सर्जरी भी है, रेडिएशन ऑन्कोलॉजी भी है, तीनों डिपार्टमेंट्स हैं जो काम कर रहे हैं। और हम लोगों ने लास्ट ईयर जो हमारे 5 मेडिकल कॉलेजेस हैं स्टेट के, वहाँ पे भी हम लोगों ने ऑन्कोलॉजी डिपार्टमेंट सैंक्शन किया है, और रिक्रूटमेंट्स भी अंडर प्रोसेस है। तो राज्य सरकार का ये मकसद है कि सिर्फ इसका ट्रीटमेंट स्टेट कैपिटल में ही नहीं सिर्फ रहे, बल्कि इसको हम लोग को हर एक मेडिकल कॉलेजेस तक ले जाना है। जो टर्शियरी हेल्थ केयर सेंटर्स है वहाँ पे भी फैसिलिटीज़ उपलब्ध कराई जानी है, और डे केयर सेंटर्स जो हैं वो डिस्ट्रिक्ट हॉस्पिटल्स में वहाँ पे उपलब्ध कराई जाए। हमारे पास जो कमी है, जो हम लोग देखते हैं सबसे बड़ी जो कमी रही है हमारे पास, हमारे राज्य में खास करके, कि हम लोग सुपर स्पेशलिटी की पढ़ाई नहीं शुरू कर पाए। और रिम्स में अभी आज के डेट में मात्र जो 11 सीट है सुपर स्पेशलिटी की, और यही कारण है कि हमारे स्टेट में सुपर स्पेशलिटी हॉस्पिटल्स बहुत डेवलप नहीं कर पाए, क्योंकि बाहर जो डॉक्टर्स जाते हैं पढ़ करके वापस झारखंड नहीं आना चाहते हैं। ये भी एक मेजर कारण रहा है। और इसलिए हम लोग का, राज्य सरकार का ये है कि आगे आने वाले 3 वर्षों में हम लोग सुपर स्पेशलिस्ट की सीट्स 11 से बढ़ा करके 100 करें, और ये हम लोग कर भी रहे हैं इसके लिए। और जब हम 100 करेंगे तो इस तीनों डिपार्टमेंट में जो मेडिकल ऑन्कोलॉजी है, ऑन्कोलॉजी सर्जरी है, और फिर तीसरा जो रेडिएशन वाली है, ये तीनों डिपार्टमेंट्स में हम रिम्स के डायरेक्टर यहाँ हैं उनसे भी रिक्वेस्ट किए है कि तीनों डिपार्टमेंट में आप सुपर स्पेशलिटी की पढ़ाई शुरू करिए, ताकि यहीं पे हम लोगों को पढ़ा करके यहीं पे लोगों से काम हम लोग ले सकेंगे, जो बहुत ही हमारे लिए आवश्यक होगी। राज्य सरकार द्वारा राजकीय हॉस्पिटल्स, जो गवर्नमेंट हॉस्पिटल्स हैं, उसमें तो सुविधाएं दे ही रहे हैं, लेकिन एक सबसे बड़ी बात यह है कि जिनको भी प्राइवेट सेक्टर्स में भी इलाज कराना है, वो प्राइवेट सेक्टर्स में इलाज कराने के लिए राज्य सरकार ने अव्वल स्वास्थ्य सुरक्षा योजना चालू किया है। मुख्यमंत्री अव्वल स्वास्थ्य सुरक्षा योजना और आयुष्मान भारत मुख्यमंत्री आरोग्य योजना चालू है। और ये दोनों योजनाओं में इस राज्य में हम लोग देखेंगे तो 15 लाख रुपए का फैमिली कवरेज हम लोग दे रहे हैं पर ईयर। और आसपास के राज्यों से यदि तुलना करेंगे, जो दूसरे राज्य हैं वहाँ पे मात्र 5 लाख का कवरेज है, जबकि हमारे राज्य में 15 लाख रुपए का कवरेज हम प्रोवाइड कर रहे हैं। और ये कवरेज जो हम प्रोवाइड कर रहे हैं, इस बार से हम लोगों ने ये किया है कि जितने भी कैंसर के ट्रीटमेंट्स हैं, वो सारे ट्रीटमेंट्स को हम लोगों ने इन पैकेज के तहत, इस स्कीम के तहत ला पाए हैं। तो अब कोई भी आदमी कैंसर का ट्रीटमेंट कराना चाहता है, बिल्कुल कैशलेस इलाज करा सकता है। उसे सिर्फ राज्य सरकार द्वारा जो निर्गत कार्ड है, अव्वल स्वास्थ्य सुरक्षा योजना का कार्ड या आयुष्मान भारत का कार्ड शो करना होगा, और बिल्कुल किसी भी प्राइवेट या गवर्नमेंट हॉस्पिटल्स में वो इलाज करा सकता है। यदि हम स्टैटिस्टिक्स देखते हैं तो हमारे स्टेट में करीब 30,382 कैंसर का ट्रीटमेंट्स इस कार्ड से हुआ है, दोनों कार्ड से, अव्वल स्वास्थ्य सुरक्षा योजना और आयुष्मान भारत से। और यदि साइकिल देखते हैं, पूरी जो कीमोथेरेपी की साइकिल है, रेडिएशन की साइकिल, तो 1.72 लाख के साइकिल हम लोगों ने ये फैसिलिटी प्रोवाइड किया है और कुल मिलाकर के 416 करोड़ रुपया का इस दोनों योजनाओं से हम लोगों ने डिस्बर्समेंट लास्ट ईयर्स में किया है। यही नहीं बल्कि कार्ड के अलावा भी हम लोग मुख्यमंत्री गंभीर बीमारी योजना है जिसके इसके ऊपर का खर्च की यदि आवश्यकता है तो हम लोग मुख्यमंत्री गंभीर बीमारी योजना में भी ये लाभ हम लोग देते हैं। एक हम लोग जो नया काम कर रहे हैं उसमें एक मैं काम का यहाँ पे बताना चाहता हूँ कि आने वाले समय में हम लोगों ने पीपीपी मोड पे डिस्ट्रिक्ट हॉस्पिटल्स को मेडिकल कॉलेज में अपग्रेड करने के लिए कहा है और चार डिस्ट्रिक्ट्स में ये काम शुरू हो गया है। मणिपाल से मैंने पहले भी रिक्वेस्ट किया था, आज भी मणिपाल के हैं, रीजनल डायरेक्टर हैं, डॉक्टर हैं यहाँ पे। मैं आपसे रिक्वेस्ट करूँगा, हम लोगों ने ऑलरेडी एक्सप्रेशन ऑफ इंटरेस्ट इनवाइट किया है 4 डिस्ट्रिक्ट्स के लिए। इफ़ मणिपाल इज इंटरेस्टेड तो आप यहाँ दूसरा कॉलेज भी खोल सकते हैं। आपका भी टाटा में हॉस्पिटल है, यदि धनबाद में, गिरिडीह में, खूंटी में कहीं पे इंटरेस्टेड है हॉस्पिटल खोलने के लिए तो आप सामने आइए, राज्य सरकार आपको पूरा का पूरा सपोर्ट करेगी इसमें। इसी के साथ मैं आपको पुनः इस वर्कशॉप के लिए, कॉन्फ्रेंस के लिए बहुत बहुत बधाई, शुभकामनाएं देता हूं और मैं ये उम्मीद करता हूं कि जो पूरे राज्य से यहाँ पर लोग आए हुए हैं, आप भी इसी तरह के वर्कशॉप अपने यहाँ जहाँ काम करते हैं, जिस ज़िले में आप हैं उस ज़िले में भी ये वर्कशॉप ऑर्गेनाइज करिए और इस वर्कशॉप को ऑर्गेनाइज करने के लिए राज्य सरकार से जो भी सहायता की आवश्यकता होगी वो राज्य सरकार आपको सहायता ज़रूर करेगी। धन्यवाद।
बहुत बहुत धन्यवाद सर, आपकी प्रेरणादायी विचारों के लिए आपका हम बहुत बहुत धन्यवाद करते हैं। बुलवाना तो नहीं होगा। एमडी एनएचएम सर हमारे बीच आ गए हैं। सर आप मंच पर आएं और स्थान ग्रहण करें। कुछ अपरिहार्य कारणों के कारण आपको लेट हुई है सर, प्लीज़ बैठ जाएंगे सर। आपका हम बहुत बहुत स्वागत अभिनंदन करते हैं। शॉल और पेंटिंग के साथ हम स्वागत अभिनंदन करेंगे सर का। डॉक्टर सतीश शर्मा सर से आग्रह होगा। तालियां आप सबकी तरफ से हो। मिशन डायरेक्टर नेशनल हेल्थ मिशन श्री शशि प्रकाश झा सर का हम स्वागत करते हैं रांची कैंसर समिट 2.0 में। बहुत बहुत धन्यवाद सर। थैंक यू सर। एंड नाउ दिस इज द टाइम टू प्रेजेंट द एक्सेलेंस ऑफ हेल्थ केयर अवार्ड्स, सेलिब्रेटिंग द रिमार्केबल डेडिकेशन, innovation and excellence of our healthcare heroes. A warm welcome, a warm round of applause, ladies and gentlemen. उनके लिए जोरदार तालियां बजाइए, जिनका आज हम सम्मान करने जा रहे हैं, जिन्होंने बहुत ही मीनिंगफुल डिफरेंस हमारे समक्ष प्रस्तुत किया है। और इसके लिए मैं हमारे आज के माननीय मुख्य अतिथि महोदय से सादर आग्रह करती हूँ। मे आई रिक्वेस्ट और ऑनरेबल चीफ गेस्ट, ऑनरेबल Chief Justice of Jharkhand High Court to kindly present the Excellence of Healthcare Awards. और आपकी तालियों के बीच मैं सबसे पहले आमंत्रित करती हूँ मंच पर डॉक्टर अनवार निज़ाम फ्रॉम डाल्टनगंज। मुख्य अतिथि महोदय के करकमलों द्वारा आपको सम्मान प्रदान किया जा रहा है, एक्सेलेंस ऑफ हेल्थ केयर अवार्ड्स। साथ में हमारे गेस्ट ऑफ ऑनर और हमारे सम्मानित अतिथिगण। तालियां आप सबकी तरफ से हो। इनके बाद आएंगे डॉक्टर सुशील कुमार पांडे फ्रॉम डाल्टनगंज। डॉक्टर सुशील कुमार पांडे फ्रॉम डाल्टनगंज मंच पर आ रहे हैं। एक्सेलेंस ऑफ हेल्थ केयर अवार्ड से आपको सम्मानित कर रहे हैं हमारे अतिथिगण, गेस्ट ऑफ ऑनर के करकमलों द्वारा। डॉक्टर शरद जैन फ्रॉम डाल्टनगंज। डॉक्टर शरद जैन, डॉक्टर शरद जैन फ्रॉम रामगढ़। Dr. Rajiv Kumar Gupta from Ramgarh. तालियां लगातार होती रहें. आपकी तालियां सबसे बड़ा सम्मान है. ये एक्सेलेंस ऑफ हेल्थ केयर अवार्ड से आप सभी को डॉक्टर राजीव कुमार गुप्ता, रामगढ़. इनके बाद आ जाएंगे डॉक्टर आर आजम फ्रॉम रामगढ़. हमारे सभी गणमान्य के अगर कमलों द्वारा इन्हें डॉक्टर आर आजम फ्रॉम रामगढ़, डॉक्टर आर आजम फ्रॉम रामगढ़ इस समय मंच पर आ रहे हैं. एक्सेलेंस ऑफ हेल्थ केयर अवार्ड 2026. साथ ही डॉक्टर विद्यापति फ्रॉम रामगढ़. आप सभी को एक्सेलेंस ऑफ हेल्थ केयर अवार्ड प्रदान किया जा रहा है. Who are making a meaningful difference in healthcare system. बहुत बहुत धन्यवाद इन सभी को ये अवार्ड प्रदान करने के लिए. थैंक यू वेरी मच लॉर्डशिप एंड ऑल आवर. थैंक यू वेरी मच टू प्रेजेंट दीज अवार्ड सर. बहुत बहुत धन्यवाद. कृपया स्थान ग्रहण करें. बहुत बहुत धन्यवाद. और एक बार जोरदार तालियां इन सबके लिए बजा दीजिए, क्योंकि तालियां ही सबसे बड़ा सम्मान है. बहुत बहुत बधाई. और आप निश्चित रूप से हम सबके लिए इंस्पिरेशन हैं इसी तरह से आगे बढ़ने के लिए और अपनी सेवाएं देते रहने के लिए. And now it's my proud privilege to invite our chief guest, Honorable Chief Justice, High Court of Jharkhand, to address his august gathering. Sir.
Respected Dr. S.H. Advani ji, Dr. Shailesh Srikhande ji, Ajay Kumar Singh ji, Shashi Prakash Jha ji, Dr. Vijay Mishra ji, Dr. Sonal Dikshit ji, and of course the main organizer, Shri Satish Sharma ji, distinguished oncologists and researchers who have traveled from across the country to be with us, survivors and patients in this gathering who carry within your own bodies the knowledge of this disease that perhaps no textbook can teach us, members of the organizing committee of Cancer Summit 2, dear friends, ladies and gentlemen. At the outset, I wish to express my sincere gratitude and deepest regards to Dr. Satish Sharma ji and all of you for this kind invite and the privilege of sharing some thoughts with such an august gathering. Of late, it is not very often that members of the medical and legal profession meet in such benign circumstances. I initially tried to decline the invitation. My first reaction stemmed from my abundant ignorance about the ever-expanding field of medicine and particularly oncology. What, I wondered, could a person trained in law could possibly say to a room full of domain experts and eminent healers? But on reflection, I do not think that the answer lies in any comparison between our two professions. I think the answer is simpler than that. It lies in the fact that before anything else, I am a husband to my dear wife Sangeeta and a father to my dear son Ishan. Sangeeta courageously battled cancer of the thyroid in 2012, and is battling the cancer of her right lung since 2025. My son and I have painfully experienced the intense anxiety, the wait in the hospital corridors or outside the operating theatres for a prognosis and how Sangeeta was coping. We have painfully experienced Sangeeta's efforts to make light of this serious situation, her physical and mental trauma, only to comfort us. Believe me, dear friends, that perhaps there is no pain greater than to be helpless in the face of a loved one's suffering. Our hearts went out to several others who shared the hospital corridors with us during our trying times. At least by God's grace, we had the material wherewithal for the treatment, which several others did not. I too have seen and experienced firsthand the almost superhuman efforts that the doctors almost routinely and with a smile put in, true to their demands and responsibilities of their profession and to the Hippocratic oath that they subscribe to. I believe I know what it means to watch someone somehow draw strength that they did not know that they possessed. From doctors who refuse to let a difficult prognosis become an excuse for indifference. That is not a small thing. It is, I have come to believe, one of the finer forms of courage that our society produces. And it is practiced every day, quietly, by people and professionals, very like those who have gathered in this hall today. I therefore come to you, surely not as an expert, but as a humble witness to these unfortunate scenes and tragic experiences. I also come as a proud witness to the resilience of men and women who have lived through cancer and to the doctors who stood beside them in those trying times. They are all owed the place of honor in this hall and surely not me. I come here only to publicly acknowledge our collective debt and to express our gratitude to the medical profession, which is perhaps the minimum that they richly deserve. I regard it as my great fortune to be able to share the days with greats and legends like Dr. Advani and Dr. Srikhande, whom I met for the first time today, but who have touched the lives of so many we know and so many more that we do not. So I decided to accept this invite with a deep sense of humility and for an opportunity to thank you all personally and profoundly. Friends, Dr. Paul Kalanathi, a neurosurgeon who faced his own terminal diagnosis with extreme or extraordinary lucidity, wrote something that I have not been able to forget. He wrote that even if I am dying, until I actually die, I am living. That sentence, though simple, speaks volumes. It reminds us that medicine is not merely about treating disease, but about caring for life itself as long as it endures. Every doctor in this hall who has refused to abandon a patient to despair has, in their own way, been faithful to this noble insight. Today, though I will try to resist the temptation to draw out elaborate parallels between the law and medicine at every turn, I do believe that both legal and medical professions exist because the world that we live in is far from perfect. It is neither just nor is it healthy. In fact, the statistics of which a glimpse was given to us by Dr. Srikhande and Dr. Ajay Kumar is extremely scary. The doctor stands beside the body in distress and asks what still can be done. The judge stands beside the wrong that has been done and asks the same question. Neither of us would have a profession in a perfect world. That we do something about this is itself a kind of an honest humility worth holding on to. Beyond that, I will let medicine be medicine and law be the law. But cognizant of the immense good that you do, I would urge you at this summit to devote a part of your time to deliberating on the lives cancer touches. The distances it forces people to travel, and the question of who gets the benefit from science that you practice, and most crucially, who do not. There is a story I think of often, not because it is dramatic, but because it is so ordinary that it could belong to hundreds of families across Jharkhand. In fact, it could belong to hundreds of thousands of families across our great nation and the globe itself. A patient notices that something is wrong. There is no facility nearby to confirm it. A long journey must be undertaken. Lack of resources must somehow be overcome. By the time the diagnosis is finally made, if at all, precious months have passed, during which the treatable cancer may have metastasized and consequently far more difficult to treat. This is not a failure of medicine or the medical profession. The science and scholarship represented in this hall itself are remarkable. This is a collective failure of the rest. This is a consequence of distance and limited access, perhaps due to lack of resources or, as Dr. Advani pointed out, awareness, resulting in delayed diagnosis and appropriate treatment. These challenges require not only medical excellence, but stronger institutions, better infrastructure, and a wider access to health care. For instance, Jharkhand is a state of considerable mineral wealth, rich forests, and considerable human resilience. It is also a state where the distance between the village and a functioning oncology center can be measured not merely in kilometers, but sometimes in several days. I am really impressed with the work which Dr. Sri Ajay ji explained to us, and I'm extremely proud and happy about that. But we all do agree that much needs to be done. I urge you to deliberate on this issue, not to burden a medical summit with matters properly belonging to policy and administration, but because I do believe that the medical experts and oncologists in this hall are amongst the most credible voices in this country today on what early detection actually requires on the ground. When you speak about this gap and speak collectively at a summit like this, the policymakers listen in a way they do not always listen to perhaps a court or to the press or to the suppressed wail of a patient's loved one when told that you have come too late. Article 21 of our Constitution provides that no person shall be deprived of his life or personal liberty except according to the procedure established by law. Over decades, our Honorable Supreme Court has read the expression life to include right to health and even right to a clean environment. Without good health or clean environment, the right to life would be reduced to a mere right to exist, which amounts to little. But these lofty ideas and interpretations must not remain merely phrases in a judgment. If we are to live up to the promise of Article 21, these ideas and phrases must become a lived reality for a poor tribal family in Khunti, the daily wage laborer in Dumka, and the rural household in Pakur. Each of us, or each of them, are entitled to an early diagnosis, timely treatment, as any more fortunate resident of our metropolitan cities. Today we have Ajay Kumar ji, we have Jha ji representing the administration. The Dean of RIMS is also present with us. You have kindly invited me as the representative of the state's judiciary. More than the medical fraternity, we from the administration and judiciary have to ask ourselves whether the promise of the hallowed Article 21 is true, or is it, for too many of this country, still a long-cherished dream, recited in judgments and medical policy statements, but not yet lived in the villages of our great country. I will not pretend that the answer is fully in our favor today, but that is no reason to despair. If our hopes have been liars, then perhaps our fears may turn out to be dupes. say not, the struggle not availeth. So I do not wish to sound a pessimistic note by saying that the gap, though significant it may be, between the constitutional promise and the dream is static and not shrinking. This gap narrows every time a mobile screening van reaches a village that it did not reach last year. This gap narrows every time a young oncologist like Dr. Satish Sharma chooses to build a practice in this state that needs it more than in a city that can manage with a little less. This gap narrows every time the tools of this new technological age are deliberately directed at the patients least able to afford the old ones. On the medical front, where I confess I am least qualified to speak, let me quote William Osler, who helped found one of the world's great medical institutions. He said that a good physician treats the disease, but a great physician treats the patient who has the disease. That distinction goes beyond words. It reflects the difference between a system concerned only with the outcomes and one that remains attentive to the individual. The same is true of justice, which must, despite its blindfold, see the person as well as the case. The point is that a seeker of justice and a patient waiting patiently for quality treatment must not be reduced to a mere number or a mere statistic. Bernard Lone, the Nobel-winning, prize-winning cardiologist, expanded on this idea in his book, The Lost of Art Healing. He wrote, "Of all the science that a physician acquires, of all the skills mastered, listening is by and far the most difficult. This seemingly simple act requires consummate artistry. For doctors, listening is an exhilarating act of discovery. For patient, it identifies the healer. There is a difference between a doctor and a healer. These two observations belong together and when read together indicate that the art of genuinely and patiently listening is the most elementary and valued act even in the context of cancer prognosis. It costs little, if not nothing. It requires no equipment, no funding, no policy directive. And yet, in the experience of every patient, it remains one thing they remember above all else. Today, if I were asked to name one quality that this gathering most embodies, I would say it is hope. Not the hope of wishful thinking, but the hope that comes from knowledge, hard work, patience, and perseverance. It is the determination to keep searching for answers and possibilities until every reasonable option has been explored. I think it was the great Thomas Edison who said that when you have exhausted all the possibilities, remember this, you have not. Keep searching for what you have been looking for and you will find it. This hope is not merely an abstract ideal. History shows us why it matters. In his book, The Emperor of All Maladies, described by the author as the biography of cancer, Siddharth Mukherjee reminds us that progress in medicine has rarely come through a single dramatic breakthrough. Rather, it has been built through the years of perseverance, patience, and determination of those who refuse to accept any existing limits. You all know better that less than a century ago, childhood leukemia was almost always fatal. Yet a handful of physicians persisted despite repeated setbacks and skepticism. The advances we discuss today are possible only because they believed that the limits of the present knowledge were not limits after all of what could be ultimately achieved. In another book, Song of the Cell, Siddharth Mukherjee describes the human body as a community of cells working together in harmony. Cancer, he explains, arises when some of those cells stop serving the larger whole and begin to act only for themselves. What struck me about this idea is how deeply personal this disease is. Cancer is not an outside enemy. It arises from within the very body that the medicine seeks to heal. That reality places a unique responsibility on physicians who must care not only for the disease but for the person living with it. I'm sure that many senior oncologists here learned this lesson long before reading it in any book, through experience, if not some mentor, teacher, or a patient. Sharing those experiences with younger doctors may be one of the most valuable forms of teaching of all. And this is where summits and the conferences you host matter, and they matter very much. Another subject which I'm sure you would deliberate on is the impact of artificial intelligence, AI, on the medical profession and on the treatment techniques. Dr. Advani has touched upon this. We are living through a moment when AI has begun to transcend the boundaries we once drew so carefully between professions and domains. AI reads radiological scans. It searches in a matter of hours through volumes of research literature that would have once taken a scholar a lifetime to absorb. And so I find myself asking a question, which I suspect many in this hall have already asked. If a machine can now help a researcher sift through millions of molecular combinations to find the one that binds a particular tumor, can it also not help the same researcher to find a cure that is not merely effective but also affordable? One that does not remain, as so much of the science still does, out of the reach for a patient in, say, Khunti or Gadwa. These are the districts in my state. It is truly beyond us. Is it truly beyond us, as a country with no shortage of scientific talent and no shortage of need, to build that capacity for ourselves, rather than wait for it to arrive from elsewhere and priced for someone else's economy? I do not ask this question rhetorically alone. I ask it because I genuinely believe that the honest answer is, yes, we can. It is not beyond us, provided we have the institutional will to invest in it with the same seriousness that we bring to everything else that we consider a national priority. But at the same time, we also cannot afford to forget that a tool like AI, however sophisticated, is only as wise as the judgment that wields it. The algorithm that flags an anomaly on a scan still requires a physician's trained eye to confirm it. AI may accelerate the search for a cure, but it cannot on its own decide who deserves to receive it or ensure that the state delivers it where it is needed the most. That remains, as it has always been, a question of judgment, guided by policy, resources, and will, and not mere technology. I say this not to counsel any hesitation, but only to emphasize that technology must remain ever subservient to judgment, never its substitute, in medicine no less than in law. There is another issue that deserves our attention. In his book, 21 Lessons for the 21st Century, Yuval Noah Harari asks us to imagine a future in which technology can detect illness long before the symptoms appear. Such advances hold great promise, and early detection can save lives. But they also raise important questions. What happens when a person is constantly told what may go wrong with her health? Who should have access to this information? And how should it be used? These are not just medical questions. They are also questions of privacy, autonomy, ethics, and individual freedom. These are areas where medicine and the law must interact. As technology becomes more powerful, it will be essential to ensure that medical data remains protected and it is used properly and responsibly. The law too must play an important role in addressing these challenges, and that role may arise sooner than we expect. In fact, it has already arisen. Friends, you are gathered here not because the war on cancer has been won, but because you are committed to continuing the fight. Every day, through your skill, dedication, and compassion, you bring hope to countless patients and their families. Across this state, and indeed across our country, that work is carried out quietly by medical professionals like you, who rarely seek recognition, yet they so richly deserve it. The law exists to ensure that no person is denied what is justly theirs. I would draw a parallel. Medicine at its best exists to ensure that no person is denied the years that are justly theirs. They are different instruments, but I believe they serve the same devotion and help reach the same destination. I thank the organizers of Cancer Summit too for the honor of being allowed to speak from this platform, even though I am from outside your discipline. And you may also consider my thoughts to be rather jejune or juvenile. But on behalf of every family that has ever waited in a hospital corridor for a prognosis, and on behalf of my own, I offer my salutes and deepest gratitude to every medical professional, scientist, researcher, paramedic, nurse, and caregiver for their contribution to mankind's war on cancer. I am confident that despite all the hurdles, we shall overcome someday. May this summit and the work that follows bring this state and our great nation closer to the day when cancer diagnosis and affordable treatment are not met with despair, but with calm, evidence-based confidence that every patient in every corner of Jharkhand and our great nation patiently awaits and deserves. I wish this summit every success. Thank you very much, and Jai Hind.
Thank you very much, Lordship, for your insightful and inspirational address. And your valuable thoughts have enriched this summit and encouraged us to work together with greater determination. Thanks once again. हमें विश्वास है कि इस समिट में होने वाला हर मंथन भविष्य में बेहतर स्वास्थ्य नीतियों, आधुनिक उपचार, समय पर पहचान और अनगिनत मरीजों के जीवन में नई उम्मीद का प्रकाश लेकर आएगा. As we come to the end of this inaugural session of Ranchi Cancer Summit, I extend my heartfelt gratitude to our honorable chief guest, our guest of honor, and all the dignitaries present on the dais. And with these words, all of you are requested to please rise for national anthem.
जन गण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उज्जल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे.
बहुत बहुत धन्यवाद. मुख्य अतिथि महोदय का हम करते हैं एक बार तालियों के साथ हम धन्यवाद करें. बहुत बहुत धन्यवाद सर. लॉर्डशिप का हम बहुत धन्यवाद करते हैं आपके प्रेजेंस के लिए. बहुत बहुत धन्यवाद लॉर्डशिप. बहुत धन्यवाद हमारे गेस्ट ऑफ ऑनर का. बहुत धन्यवाद हमारे स्पेशल गेस्ट महोदय का, हमारे सभी डिग्निटरीज का, और हमारे बाकी सभी अतिथियों से निवेदन है यहीं बने रहेंगे अगले नेक्स्ट सेशन के लिए. ऑल ऑफ यू आर प्लीज बी सीटेड हियर फॉर द नेक्स्ट टेक्निकल सेशन. नेक्स्ट टेक्निकल सेशन अब हम प्रारंभ करेंगे। आप सभी से निवेदन है, कृपया अपनी अपनी जगह पर आ जाएंगे। हमारा नेक्स्ट सेशन अब प्रारंभ होगा। I would like to invite Dr. Nisha Maheshwar for the next, Nisha Maheshwari ma'am, for the next technical session. You please continue.
Thank you so much, ma'am. So after the inauguration ceremony, let us now take our program forward. May we take like 1 minute to please settle down so that we can proceed with our scientific program. So our next speaker for today is Dr. Anbasaran Sekhar. Sir is an associate professor from ACTREC, Mumbai. The topic he's speaking on is RET-driven cancers, evolving paradigm in precision oncology. May I also have the privilege to call upon our chairpersons for today, Dr. Amitesh Anand, Ranchi, Dr. Deepak Agarwal, Ranchi, Dr. Nishit Kumar, Ranchi, Dr. Manu Goyal, do we have our chairpersons in the hall? So give me 1 minute. Can I please call Dr. Sneha Jha ma'am to chair the session, if you're okay with this? I think, sir, we can proceed with the session.
I think they have sent to you separately. They have also sent to you. Sure. Okay. Good evening, everyone. At the outset, I would like to thank Dr. Satish Sharma and the organizing team for giving me this opportunity. This is a sponsored session from Lely's team. And today's topic of discussion will be within the scope of indication approved in Indian scenario. So I'm Dr. Anbarasan from Tata Memorial Hospital. So as we navigate the molecular landscape of modern oncology, we are moving from an era of anatomical classification and broader histopathological classification more deep into an era of precision oncology. Today, we are going to focus more into highly driver of oncogene called as RET alterations, and I would like to walk you through this
pathway mainly regarding RET-driven clinical cancer in this situation. In this, we are going to primarily discuss about highly specific RET inhibitor called selpercatinib and what is its clinical implication on patient outcome in in thyroid as well as in lung cancer. Basic introduction about RET proto-oncogene. Basic introduction about RET proto-oncogene. It is located in long arm of chromosome 10 and it contains 21 exon. When we speak about RET alteration, primarily we are discussing about point mutation which is within the RET protein, or it could be in the form of fusion-related gene rearrangement where RET can fuse with other chromosomal part of gene in this situation. When it comes to point mutation, we have specific cancer like lung cancer and non-medullary type of thyroid cancer, that is papillary cancer, these are the cancer which are having higher incidence of RET-related point mutation, and some rare cancers like pancreatic or ovarian cancer, rarely we can see this RET point mutation which occur in less than 1% of situation. Second important thing is RET fusion. This RET fusion seen in one of the rare cancer, that is medullary thyroid cancer. Even though it is a rare cancer, it holds up to 60% of sporadic situation of medullary thyroid cancer have RET fusion will be seen, and also in hereditary more than 90%. This we need to remember about it. As for the medical oncologists as well as pathologists in the panel, I would like to discuss about very crucial point, how we are going to do with tissue sampling and testing methodology with regarding RET testing. When it comes to RET testing, immunohistochemistry is not a specific marker. It is not an optimal screening modality of testing. Why so? Because it has lot of false positivity due to variable expression of RET protein, also lot of background noises happening. So IHC is not the ideal method to consider RET testing in population. Next, we have availability of FISH as well as RT-PCR based detection. But these modalities we can use only we know the fusion partner with the RET oncogene. If we know the fusion partners, then we can very well use this in this situation. If we don't know the fusion partner, we are using to test in a rare cancer situation, then this may not be the ideal modality. Then comes the NGS testing. RNA-based RT-PCR is the RNA-based NGS testing is the ideal modality. Why? Because it avoids long repetitive introns, which leads to missing of RET fusion. This will be avoided by RNA-based NGS testing, which will be the optimal modality for identifying RET-related fusion in the malignancies. Right? We have discussed about molecular patterns of resistance. Now we are shifting gear from molecular pattern towards the clinical trial. Here we discuss how this mechanism shifting towards efficacy in first-line setting in the patients. Now we are going to see about lung cancer changes. Little bit of background with regarding RET-positive lung cancer. When it comes to lung cancer, in overall, when the patient is non-specific cohort of RET-positive lung cancer patient, what we have standard of care is immunotherapy along with chemotherapy. In this situation, the median PFS is only 9 months and overall survival which is less than 2 years of duration. Another one important drug we use in RET-positive indication is cabozantinib. When we treat these patients with cabozantinib, even again, it has not shown very good improvement in this situation. There is a huge unmet need in this situation. That's why selpercatinib come into the picture. Selpercatinib is a small molecule inhibitor of tyrosine kinase, which has a specific binding towards ATPase binding domain of tyrosine kinase. It has two advantages because it is small molecule, it can easily penetrate into the brain. Second advantage is it binds closely to the ATP binding domain of tyrosine kinase inhibitor. So resistant mechanism are often minimal in this situation. This leads us into the clinical trial setting. Initially began with LabTak07 study, where we introduced selpercatinib in advanced non-small cell lung cancer patient, as well as other tumor agnostic purpose also. What is the primary endpoint here is objective response rate. Here the objective response is close to 80% when the patient is treatment naive in the situation. Even those patients who are already treated with platinum-based chemotherapy, close to 60% response rate is achieved. One good thing is this response rate is translated into survival advantage also, which is reflected in both median progression-free survival as well as overall survival. This led into the another important phase 3 randomized study, LabTak4301. In this study, they randomized non-small cell lung cancer patients who are RET positive into treatment of physician choice. It could be either platinum-based chemotherapy or platinum-based chemotherapy along with immunotherapy. And the experimental arm contains selpercatinib. there are two important advantages. One important advantage is those patients who progressed on control arm, they have given option of continuing self-percatinib during the time of progression. And the primary endpoint of this study design is progression-free survival, and the key secondary endpoint include overall survival, duration of response as well. Coming to the baseline characteristic features, this study has included good amount of Asian population into the study design. Coming to the very important part, that is progression-free survival, with the arrival of self-percatinib in red-positive non-small cell lung cancer, the progression-free survival more than doubled, which improved to 24.8 months in comparison to chemoimmunotherapy arm, where it is only 11.8 months. And more importantly, this PFS advantage is seen across all subgroup of population in this situation. We have discussed about PFS advantage. This is reflected in other key secondary endpoint like overall survival as well as median duration of response. Another important aspect for medical oncologists, not only systemic control is very important, we need to control intracranial effect also for the durable response in the population. Especially this red-related non-small cell lung cancer, higher incidence of brain metastasis in this situation. Again here, self-percatinib scores very well, showing a higher response rate of 85%, with more importantly, CR rate close to 35% in this situation. And this response rate translated into durable response also. When we started these patients on self-percatinib, there is delay in intracranial progression in this population. And more importantly, coming to the quality of life, we need to balance when the drug is taken for a long period of time, whether it is translated to quality of life or not, it is showing good amount of improvement in terms of quality of life by reducing the pulmonary toxicity. Safety profile is also very good. In spite of the drug is taken more than 70% of duration compared to the control arm. We have seen about lung cancer. Now we move into the thyroid situation, how this RET inhibitor progress in thyroid cancer. When it comes to medullary thyroid cancer, it has shown very good response rate. In LabTak07, it has shown PFS advantage with an hazard ratio of 0.28 in comparison with cabozantinib. And it is benefit is seen across all subgroup and is reflected with other key secondary endpoint as well. Coming to the safety profile, it is much safer compared to the rest of the other cabozantinib or vandetanib in this situation. Coming to the another important study, non-medullary thyroid cancer related, like in papillary thyroid carcinoma and other situation. Again, LabTak01 is the study where they provided tissue agnostic in this situation. There were close to 66 patients enrolled in the study design, and there was equal number of patients who were previously treated as well as those who are treatment naive taken into the study design. And the primary endpoint here is overall response rate. Again, almost 100% of patients shown tumor shrinkage with usage of self-percatinib in this situation, highlighting how good is the drug in terms of efficacy in those population with rare cancers. Coming to the recommendation, the recommended dosage is 160 mg twice a day for adult more than 50 kg and 120 mg twice a day for patients who are weighing less than 50 kg in this situation. Coming to the final point, this self-percatinib, which is showing dramatic improvement in this situation, has 4 important indications. One in red positive advanced non-small cell lung cancer, and second important thing in red fusion in medullary thyroid carcinoma, and it has a tumor agnostic approval as well in papillary thyroid carcinoma, and this tumor agnostic approval is seen in children age group also who are aged more than 2 years of age. If they lack the systemic option, then definitely we can consider self-percatinib in this situation. With this, I would like to conclude. This self-percatinib has definitely shown a very good improvement in all this situation, and definitely comprehensive gene profiling as well as this precision-based treatment improving outcome in this population. Thank you, organizer, for everyone giving this patient opportunity. Thank you.
Thank you for this nice presentation. Any questions from the audience? So we can conclude this nice talk. Thank you.
Thank you.
बोलो ना, मैम को बोलेंगी। तो वहीं से बोल दो ना, माइक दे दो मैम को, वहीं बैठे बैठे बोल दो। माइक दे दो।
May I now request our next speaker, Dr. Amitabh Upadhyay, sir, HOD and Chief Medical Oncology, TMH, Jamshedpur.
So good evening and thank you organizers for preponing the session which was scheduled to happen tomorrow. So quickly coming to the topic. So I'll be discussing about the role of immunotherapy in early triple negative breast cancers. And as we all are aware that breast cancer shows a lower estimated new antigen burden. So this is shown in this graph that the breast cancer is somewhere in the middle. It's neither highly antigenic nor very low antigenic. So it's having in the lower range of this neoantigen burden. Now coming to our topic, that is triple negative breast cancer. So TNBC per se has an
Over to you, sir.
I'll request Dr. Deepak, Deepak, please be the chairperson, and Dr. Kundu, Dr. Parag. And Sanjeev sir, please. Sir was late.
Yeah, good evening, everybody. First of all, let me thank Satish for organizing an excellent meeting, and thanks for inviting me. I was told to talk about the surgical management of oral cancer. I said that just talking about the routine surgery, rather than that, the entire theme of this conference is basically immunotherapy, targeted therapy. It's a precision medicine. So let's talk about precision surgery rather than just talking about surgery in head, neck, oral and oropharyngeal cancers. So we all know that oral cancer, thanks to the tobacco chewing habit of our Indian patients, is #1 cancer in Indian males. Almost 30% of all the patients that we see are of oral cancer, and we see almost 3,90,000 patients per year. Sadly, almost 2/3 of these patients present in a locally advanced stage even today, and in spite of having whatever advances in the treatment, the survival of oral cancer hovers around 50 to 55% 5-year survival. Now, majority of these patients are treated by surgery as a primary modality. So we'll end up doing major resections, and that has a significant impact on the quality of life of our patients, including the cosmesis, speech, swallowing, mastication. So definitely now the concepts have changed from radical surgery to the precision surgery. How it has changed, that we'll see. Though I'm combining the oral and oropharyngeal cancers together, as you can see that these are almost like chalk and cheese. Though they are just next to each other, their etiology is different. In the Western world, almost 90% of oropharyngeal cancers are HPV positive. Good that we don't have those many. But their presentation is different. And the survival is different, which is very good in HPV positive oropharyngeal cancers. And the modality of treatment in oral cancer is predominantly surgery, while because of the open surgery had shown a very high morbidity in oropharyngeal cancers, we've been always treating them with chemoradiation. However, now with the invent of transoral robotic surgery, even surgery has a role to play in oropharyngeal cancers, and that we'll see. As I said, the head neck cancer itself, the treatment has evolved from the days of radical surgery to organ preservation, and then now to the era of minimally invasive and the precision surgery. So how it has moved? Let's kind of in one slide, I can tell you the whole treatment of oral cancer or oropharyngeal cancer started way back in 1906 when George Cryle described a surgery which we all call it as a commando surgery, where you need to do a wide excision of the tumor with a hemimandibulectomy, because that time it was thought that the lymphatics pass from the primary through the periosteum of the mandible to the lymph node. So every patient you have to take out the half of the mandible. You need to do a radical neck dissection, which obviously had a very high morbidity. And in those days, there was no primary reconstruction done. It was done as a secondary reconstruction. Then in 1970s and 1990s, we slowly realized that to cure cancer patients, you don't have to be that radical, and came concept of organ preservation. So not only in laryngeal and hypopharyngeal cancer, in oral cancer, we realized that many of these patients, we can excise it by peroral excision, doing conservative surgeries like marginal mandibulectomy or mandibulotomies. Even the radical neck dissection, we realize, has unnecessary high morbidity. Therefore, in node-positive patients, we started doing modified radical neck dissections or MNDs. And in node-positive patients, and in node-negative patients, we started doing selective neck dissection. Then came era of advanced reconstructive surgery, where the previously done local flaps and PMMC flaps we replaced by doing free flaps, and even now they form the basis of our treatment, where we do radial forearm flaps, the anterolateral thigh flaps, and free fibula flaps. And post 2010 onwards, we are now in the era of minimally invasive and precision surgery, where we are doing surgeries like sentinel node biopsies, we are doing robotic surgery, now we are also doing a kind of AI-assisted surgery and 3D printing. So my focus of my talk is going to be on what we are doing in last 15 years from 2010 onwards. So there are 5 kind of pillars of precision surgery where the real advances have taken place in last 10-15 years. One is achieving a margin. So what advances have happened in the achieving a good clear margin? Second is the management of neck node strategy which has changed. In reconstruction, there are various advances which have taken place. It's not only functional reconstruction, but a functional rehabilitation. And finally, we all know that there are various technological advances like sentinel node biopsies and robotic surgeries and AI-based surgery, how it has come. So first, coming to the margin, we all know that margin positivity is one of the most important prognostic factors in oral cancer next to the nodal status. And in node negative patient, the incidence of local recurrence is only in tune of 10 to 15% compared to node positive, it goes up to almost 65%. So previously we used to just rely on the final histopathology report, then came the frozen section. There was also doubt how do we exactly do frozen section, and now it has been clearly defined that we need to take at least 6 margins in frozen section: anterior, posterior, medial, lateral, deep, radial, etc. And it has been proven that the specimen side frozen section margins gives a much better assessment than the body side assessment of the frozen section. Now for routine frozen section, we have gone ahead now in last couple of years in the era of the fluorescence guided margins, like using a ICG, using optical coherence tomography, you are using a confocal microscopy, or even using now there is a technique called as a AI assisted digital pathology, where you just scan the specimen and within 10 minutes you get the pathology report. Now this is very important in context like India, which has a high incidence of field cancerization, and therefore getting clear margin becomes many times difficult just on visualization. Just to add to it, even narrowband imaging and intraoperative ultrasonography to get the deeper margin is also being used. Next is the management of neck node metastasis. Now there is no doubt that in node positive patients you need to do a neck dissection. In advanced T3, T4 patients you have to address neck. But there was always a kind of a doubt, what do you do in T1, T2 and 0 patient? And we always doubted whether we should keep it under observation or whether we should be doing a neck dissection. And that doubt was kind of resolved once and for all by the famous N0 trial done at Tata Memorial Hospital by Dr. D'Cruz et al. Now I'm proud to say that I was part of that investigators at my stint at Tata Memorial Hospital, and it clearly shows that the elective neck dissection improves survival over prophylactic, elective neck dissection improves survival over therapeutic neck dissection, and it saves life. Now it saves lives in patients those who have micrometastasis, and that incidence is around 20%. But that makes that in 80% of the patient will end up doing unnecessary neck dissection with all its morbidities. And there came the role of sentinel node biopsy. Now sentinel node biopsy was always there in, I would say, in breast cancer, melanoma for almost last 20-25 years. But in head and neck, or oral cancer, its role was not clearly defined. And now it's been proven by multiple randomized controlled trials, the SENT trial, the Japanese trial, a European trial, that definitely there is a role for sentinel node biopsy, wherein we inject a technetium-99 sulfur colloid, we do a SPECT scan, and the node which picks up on a gamma probe intraoperatively, we just pick up that node, send it for frozen section, and if that is negative, you don't need to do a complete neck dissection. Obviously, the final histopathology is it's a gold standard. And with that, almost 80% of the patients, you avoid doing a conventional neck dissection. Now, even we are doing it routinely at our hospital, at Kokilaben Hospital, and done more than 100 patients. And we have realized that the detection rate is more than 95%. The negative predictive value is also very high. And as I said, it detects micrometastasis in around 20% patients, so 80% you are able to avoid the unnecessary neck dissection. So that's what one more advantage of sentinel node biopsy, that in some patients you will also detect a contralateral neck node which you would have otherwise missed in a conventional neck dissection. Next is the role of robotic surgery. Again, robot was there in urology or uro-oncology for a prostate cancer and for gynecological cancers. They've been using it for quite some time. But what is its role in head and neck? Now, in addition to robotic neck dissections and the thyroidectomy, the real role of robot in head neck is transoral robotic surgery. Obviously, in addition to the advantages of magnification and the 7 degrees of freedom and superior stability that everybody knows, the most important advantage of transoral robotic surgery is in HPV positive oropharyngeal cancers, where you can use it as a de-escalation strategy. And now we know that there is not only one robot, but there are multiple robotic systems which are available. Da Vinci itself has come with the latest system, and you have a single port system, you have various Indian robotic systems and flexible robotic systems which are available. So as I said, its role is mainly in HPV positive patients, like the way it is used in PATHOS trial in de-escalation. As I said, reconstruction is one more thing where the advances have taken place. So we moved from delayed reconstruction to primary reconstruction in a form of DP and PMMC flaps, now to free flaps, and now also have gone to a stage where we do a sensate flap. We have a motor flaps which are there. We can do an intraoperative flap or a postoperative flap assessment, vascularity assessment by doing ICG injections. So there are various, and there is new now concept of what is called as a jaw in a day. So we'll see that. Again, I said functional rehabilitation is as important as functional reconstruction. So speech and swallowing rehabilitation. Now, speech rehabilitation is not important only in laryngectomy, but also in glossectomy. A swallowing assessment by doing modified barium swallows and fees functional endoscopy. There is a role of prosthodontists and maxillofacial surgeons doing various obturators and various trismus devices, as well as shoulder rehabilitation and a neck rehabilitation by doing a physiotherapy. So all these have advanced in last 15 years. So these are various dysphagia management and swallowing rehabilitation strategies that we follow. These are certain speech rehabilitations we follow, policies we follow. And with that, you can make out that the quality of life of our patient definitely had shown a much better outcome compared to what we were doing in the past. So these are various emerging precision technologies which are there. As I said, fluorescence guided surgeries and others are already being discussed. One more is what is called as augmented reality. So the tumor is superimposed on the mandible, so you know exactly where to take cuts. As I said, intraoperative ultrasonography I have already mentioned. One more thing is for a reconstruction, instead of you take bending plates and using, you have a prefabricated titanium plates which are kind of specific to patient's anatomy. By using a 3D printing, you can use it not only to take cuts, or not only to kind of do a preoperative planning to take cuts, as well as to make those prefabricated plates. So as I said, there's a concept of jaw in a day. That means you do a tumor ablation, you put in a free fibula flap with a prefabricated plate, so the contour is exactly maintained based on the 3D reconstruction which you are using, and then you do a dental rehabilitation by putting in implants intraoperatively. Now, not that we are routinely doing these are newer technologies. Because of cost implications, these are still, I would say, practiced at a few centers and not been regularly being done. So now gone are the days where a head neck cancer was operated by one surgeon sitting in some nursing home or a small hospital. Now it has become a multidisciplinary care, not only of a surgeon, radiation oncologist and a medical oncologist, but also of a reconstructive surgeon, a maxillofacial surgeon, a prosthodontist, a speech swallowing rehabilitation, a psycho-oncologist. So this is a teamwork that had changed the outcomes. So I'll conclude that the surgery still remains the treatment in oral cancer, but gone are the days where we were doing a radical surgery, a commando surgery. In fact, the name commando has been changed to composite resection, but commando surgery. Now we do a conservative surgery. We do so many of these precision techniques to give the best quality of life to our patients. Thank you.
Thank you, Doctor, for saying.
Oh, that itself was working, I suppose.
Yeah. Any question from the house? Anyone? Surgeon, Dr. Avinav, who is doing recent robotics to that. Do you want to anything add?
Oh, okay, yeah. Yes.
Only remember that the bladder cancer, when you do cystoscopy, one of the very prevailing and very tough surgery, and many of the time what happens is that you miss CIS. When you employing AI and robotics,
yes,
do you think the procedure has advanced too much fold, and still there is some lacuna which could be over the time it could advance, and we can find some very precise surgery where there is no chance of a margin even to miss out?
No, that's what. So the robotic surgery has definitely made various advances. We know that the way intra-abdominal surgery has changed by robotics, perhaps head and neck, the scope is little lesser compared to intra-abdominal surgery because of the limited space which is there. Plus, a lot of patients in India, we see that they have trismus, so we don't have that much space to go in. But yes, robotic surgery has given us, we are able to reach areas which we were not. Basically, the role of robotic surgery where you were not able to reach comfortably by open surgery or a laparoscopic surgery. Imagine radical prostatectomy prior to the days of robotic surgery was such a morbid surgery. Now in a day, our uro-oncologist is doing 4 or 5, he's doing it. So that's the kind of a thing which has happened. A one-day surgery previously, and now in a day you can do 4 or 5, and the precision is very good kind of. Integrating AI, yes, it will help us in where the deeper structures are, where the vessels are, where to take the margins, superimposing the imaging on that, and many of these features are already there. One thing which is still lacking in robotics is having a tactile sensation. And that, whatever, finally human will remain human and a robot will remain a robot. So that's some difference which will always be there.
Yeah, good, sir. Question is that previously we used to see the PMC flap, now come the free flap. So regarding cosmetic point of view, so what is the future? How means the future that we will be able to give more cosmesis to the patient regarding reconstructive methods?
No, that's what. So there was a time when we were doing PMMCs in majority of the patients, saying that that's a workhorse of our reconstruction. Now the whole scenario has changed to such an extent that we say, oh, in almost every patient we'll put in a kind of a free flap because it gives better cosmesis, it gives better function, especially anterior mandibular reconstruction. Okay, if you are doing a posterior mandibular, it's a posterior segmental mandibulectomy, then whether you do anterolateral thigh flap or a PMMC does not make much of a difference. Perhaps, yes, ALT will give a better cosmesis slightly, for a shorter period of time, but it does not give that much advantage. Yes, there have been advances in the free flaps, like as I said, sensate flap, motor flaps. The disadvantage being majority of these patients are going to require adjuvant radiotherapy. So then attaching a nerve or a sensory or a motor now does not make much of a sense because that radiation does not allow the nerves to grow and the results are not. But in benign cases, yes, definitely role for sensate flap, motor flaps, using ICG to see the vascularity of the flap on table. So these are new things which are there. You can do a dental implant again on table, but the problem being, again, it increases the cost. And if you think that, oh, if this gets infected, his adjuvant therapy is going to get delayed, and you don't want to take that chance. But yes, the newer and newer technologies are
nowadays, we are seeing the lots of the patient is having the RMT involvement or the ITF involvement. The approach with the new adjuvant, the approach has been changed? Because once we are in the student, the trismus is there, a doctor try to avoid for the surgical reconstruction of the involvement of the RMT or ITF involvement.
Yeah.
So with the adjuvant, neoadjuvant therapies, are you seeing any changes in the treatment options or modalities?
Yes, definitely. Neoadjuvant chemotherapy has made a lot of differences. One is in borderline resectable cases, especially ITF involvement. If it is high ITF going right up to the base of skull, it's not going to make a difference. But it's a borderline just going supra-notch, what we call it. In those patients, a neoadjuvant chemotherapy has definitely shown excellent results. Second, in mandibular preservation, some tumors which are close to mandible but not involving mandible, there is a role for a neoadjuvant chemotherapy. And definitely now with the keynote 689, there is evidence of adding immunotherapy in a neoadjuvant setting.
Thank you. Any more question from the house?
So we'll take the question. We are running very short of time. Can we invite the next speaker, please? So thank you. Great.
Thank you, Dr.
Thank you.
Thank you very much. Big round of applause for him. Our next speaker is a renowned medical oncologist, Dr. Joydeep Ghosh. He is a senior consultant of medical oncology of the Apollo hospitals. We'll request him for the innovation to impact role of Opdita or nivolumab in non-small cell lung carcinoma. Thank you.
Good evening, everyone. So I'll be talking about role of nivolumab in non-small cell lung cancer. This is a sponsored session. So it largely finds two places in the treatment of non-small cell lung cancer. You have the role of nivo in the curative setting, which is the neoadjuvant treatment, where it is given in combination with the platinum-based doublet, as well as in the metastatic setting, either in the first line with combination of nivo plus ipi, or the combination of nivo ipi with chemotherapy followed by maintenance, or as a second line after they progress on the first line platinum-based treatment. So we'll go ahead with all these clinical trials. So let us first discuss the Checkmate 816 trial, which was trying to see if nivolumab improves the overall, it improves the outcomes in patients who have resectable non-small cell lung cancer. The patients had to have a stage 1B or up to 3A with no mutation, driver mutation. They were randomized into neoadjuvant chemotherapy alone versus chemotherapy plus nivolumab. And then surgery was done within 6 weeks after treatment, and then optional adjuvant chemotherapy or radiotherapy. The primary endpoint was progression-free survival. Sorry, the primary endpoint was pathological complete response. And you can see that patients who received nivo plus chemo had a path CR of 24% compared to only 2% with chemotherapy alone. And if you look at the path CR based on the baseline stage of the disease, almost all the stages, be it 1, 2, or 3A, almost all the stages had a significantly higher improvement in the path CR rates. Also, the depth of pathological regression was much higher with the addition of nivolumab to the standard chemotherapy regimen. Also, the secondary endpoint was long-term outcomes, and the event-free survival, the 4-year update showed that the arm which received nivo plus chemo had a median EFS of 43 months compared to only 18 months on chemotherapy alone, and which has a favorable hazard ratio of 0.66. Coming to the OS data, there was a significant improvement in the overall survival. The statistical, the hazard ratio was 0.7. And at a 4-year time point, 70% of the patients were alive with nivo plus chemo versus 57% with chemo alone. So definitely there is significant improvement in the long-term outcomes, and the outcomes did not differ based on what kind of surgery was done. Almost all the types of surgeries, their outcomes were good, including pneumonectomies. These are the safety summaries, nothing new to add here. So this trial told us that combining nivolumab with chemotherapy in the neoadjuvant setting improves the path CR rates as well as it improves the long-term overall survival. Coming to another trial, the Checkmate 77T, it is more or less the similar study, but here the only difference was that in the adjuvant setting after the surgery, nivolumab was continued as a maintenance for 1 year, but in the previous trial, the maintenance was not given. Otherwise, it is more or less a similar study. And if you look at the EFS overall as well as by stage, so patients who received the nivo chemo, they had a 18-month EFS of 70%, which was almost 20% higher compared to chemotherapy. And that also applied to stage 3 more prominently. Stage 2, it was more or less similar, but stage 3, definitely the long-term outcomes were way better compared to chemotherapy alone. Also, the investigators tried to look at the PDL1 expression, whether it affects the outcome. So PDL1 more than 1, the hazard ratio was strongly significant, 0.5. But when it comes to PDL1 less than 1, the hazard ratio was 0.73. Although the trial was not specifically looking at a particular subset, these are all post-hoc analysis, so we cannot derive any robust This was the Kaplan-Meier curve, and which showed that the median OS was almost 16 months versus 11 months with chemotherapy alone. So with this trial, the investigators concluded that Nivo-EP plus chemo followed by Nivo-EP maintenance can be one of the standard of care, even for those who do not have a PDL1 expression. Coming to the other study, the CheckMate 227 trial, where there were two parts, the PDL1 expressors, the PDL1 non-expressors. All the two patients were randomized into 3 groups, Nivo single agent, histology-based treatment, because both squamous and non-squamous was included in the study, and one arm was Nivo plus EP. So there was a dual primary endpoint for Nivo-EP versus chemotherapy for PFS in high TMB as well as OS in the PDL1 more than 1% population. So if you look at the median overall survival in the Nivo-EP arm, it was 17 months. In the chemotherapy arm, it was 15 months. 2 months improvement in the overall survival, but that was statistically significant. Also, the response rates were much better, 23% versus 6%. Coming to efficacy in the less than PDL1 1% population, here also it was found to be efficacious for both squamous as well as non-squamous, more prominent for squamous rather than non-squamous. And PDL1 more than 50%, here also the difference is significantly there, 21 months versus 14 months. Coming to the 5-year update, these are the overall survivals. So more than 1%, Nivo-EP 17 months versus 15 months, and in the less than 1% population also 17 months versus 12 months. So definitely this combination is one of the standard of care for patients whom we are considering a pure IO based regimen where we are unable to give chemotherapy or patient not willing for chemotherapy. PDL1 does not need to be a deciding factor for giving this regimen. So with that, I wish to conclude. Thank you.
Thank you, Dr. Jaydeep Ghosh, for nice presentation. What is your personal preference in Nivo, EP, Nivo chemo, or Nivo pembro in neoadjuvant setting?
In the?
In neoadjuvant setting.
Neoadjuvant setting. So I usually taking cost also into consideration, I usually go for the combination of Nivo plus chemo in the neoadjuvant 3 or 4 cycles followed by surgery, and then I don't give the adjuvant Nivo.
If it no financial constraint.
Good evening, everyone. So it's our privilege to call the moderator for the session, Dr. Amit Kumar. He's a consultant pediatric hematology and oncology, Jayaprabha Medanta Super Speciality Hospital, Patna.
Good. Yeah. So good evening, everyone. So this is the last panel discussion of the day, and I'll invite my panelists, Dr. Gunjesh and Dr. Sanjeev, please. And thanks, Dr. Satish, for this opportunity. So this is a short panel discussion on the new molecule that is serplulimab, the new IO, and I think the most cheapest and the most cost-effective one, and how does it behave in the real world. So we start with just a case. A 57-year-old ECOG PS1 smoker who initially presented with left chest side chest pain with 3 months prior to the presentation, And on biopsy, it was a malignant round cell tumor, which was found to be synaptopositive along with TTF1 and INSM1. And the CT scan of this patient showed a left upper lobe primary mass lesion with a cervical lymph node and a pericardial deposits. So it was found to be a stage 4 extensive stage as, say, small cell carcinoma lung. So the patient was initially started on the usual chemotherapy, that is etoposide cisplatin. After 6 cycles, after 3 cycles, there was a response. After 6, again a progression after a few months. Then the second line irinotecan, third line docetaxel. But still the patient is having a preserved PS. So coming to Dr. Gunjesh, so how would you like to now approach to this patient? Small cell extensive stage lung cancer, initially on etoposide, second line irinotecan, third line docetaxel, with a preserved PS still.
Hello. So we can try already received 3 lines of chemotherapy, and again is a immunotherapy naive patient, have not received. So I can give single agent immunotherapy like serplulimab or atezo or durvalumab can be offered. Otherwise, irinotecan has already been, everything has been used.
Has been used in this patient. Dr. Sanjeev, any changes from your side? Yeah, so I'll say not much time, so only 1 year from his diagnosis. So still he is progressing radiologically more rather than symptomatically. Yeah. Yeah, so I think so. Definitely, tarlatamab is an option, but not in Indian settings. The cost and other thing is something difficult. So this patient was initially then given, has been re-challenged with again carboplatin since 6 months has last of the platinum-free interval, and post 3 cycles, the follow-up PET CT of this patient shows a complete metabolic remission. So there is a very good response to etoposide and serplulimab in this patient. And this is the scans you can see, the pre-intervention scan and the post-intervention. So there is a almost complete metabolic response happening with this. So at the 4th cycle, this response was seen. So the data regarding this, it has been shown in the last year ASCO only, that the Astrum is 005, which has shown that you start with serplulimab with chemotherapy, the median OS increases from 11 months to 15.8 months. So, and at 4 years, still 21% of the patients are surviving. So, Dr. Gunjesh, so your thought process on a small cell lung carcinoma with extensive stage. So, 4-year survival, are you ever thinking of any patient?
No.
So, definitely. Dr. Sanjeev, any patient in your practice going till 4 years for a small cell? But still, in this trial, 1 out of 5 patients is surviving with 4 years. So, some changes has happened with the addition of immunotherapy with chemotherapy. So definitely few patients are doing good with this. So if we have a cross-trial comparison with the other molecules which are being approved like durvalumab or atezolizumab, serplulimab has shown a better survival going to 16 months around as compared to 13 months in the other subsets. And the 4-year survival has been reported to around 22% in this with maintaining duration of response. And with the ESMO MCBS score, it is going up to the level of 4. That is, there's improvement in the median overall survival along with the quality of life. So this drug has been approved in that. If we see, there's a head-to-head trial also, serplulimab versus atezolizumab, which is happening, and it has in combination with carbo-etopo in the first-line setting of extended-stage small cell lung cancer. So this trial also has shown 13% low PD-L1 advanced metastatic presentation. Even they are found to have a better response with this. So with this, I'd like to conclude. Yes, ma'am. So earlier, all the trials of immunotherapy has got the similar comparator arm. So if we see all studies have been done in the same setting with the chemotherapy in one hand and chemo plus IO in the other hand. So more or less, these study design are very good. The only caveat is these studies are being done only in a selected population, that is either in only the Chinese population or East Asian population, and not generalized to the whole world. Yeah. So that's the main limitations. Otherwise, we need more real-world data regarding this. And there's one study which is going on in the small cell, which they have comparing it with atezo, and it is showing a benefit even with serplulimab as compared to atezo. Okay. So I'd like to thank my panelists.
Thank you, Dr. Amit. That was a wonderful panel discussion. Bearing in mind the scarcity of time, may I please request you to continue with the talk, the next topic you are having.
Next slide. Slide. Yeah, so the next topic is about the ALK positive metastatic non-small cell lung cancer and the utility of a molecule that is ceritinib or Spexib. So what we have seen the ALK, in the lung cancer, we have got many driver mutations apart from EGFR, ALK, ROS, RET, MET. So, and apart of this, the best response which we have seen in the last few decades is about the ALK positive tumors. So the best response in non-small cell is only seen in the ALK positive, that the patient may be now going up to 10 years, earlier 10 years down the line where the survival is less than a year. So this ALK is being identified in something around 5 to 6% of non-small cell cases. And they are being seen in younger patients, never or light smokers, or those with an adenocarcinoma histology. And during the evolution, so we have seen the earlier molecule which has came as crizotinib, then come the second generations like ceritinib, brigatinib, alectinib, and now we have third generation lorlatinib, and now it's the time for fourth generation like TPX013, which is being coming. So later generation TKIs, which has now come, has produced a longer PFS and better intracranial control, because these any patient with ALK positive, the chance of developing brain mets is more than 50% in their lifetime. So ceritinib, which is a potent second generation ALK inhibitor, has shown around 20% greater ALK inhibition as compared to crizotinib, and it has retained its activity in all the ALK kinase domain mutations and have a better intracranial response rate as compared to crizotinib. So there are initial trials, the ASCENT, which is the first in human experience, which shows that in the phase 1 human trial has shown the safety and tolerability of this drug, and the maximum tolerable dose of 750 milligram once daily has been done. And it has shown the median PFS has increased from 6.9 months to 18.4 months. There's 3 times increase in the PFS with this molecule initially, with a rapid tumor shrinkage and sustained response, which is maintained over time with this drug. Post-crizotinib, when this was also used, it had shown a response in almost all the patients who were better overall response rate, and which is going up to 38.6%, with the intracranial overall response rate 45%, and clinically it has been shown to have a rapid and durable response despite prior chemotherapy and crizotinib failure. So, and the most important is the intracranial disease control rate, which is going up to 80%. In the treatment-naive setting, ASCENT-3 trial was studied in around 124 patients. They have also used 750 milligram once daily fasting doses, and around 40% of the patients have brain mets in this setting. And the tumor response rate is around 67%, with disease control rate going to 90%. And there is a tumor burden reduction of 95%. So the median PFS is going with 17 months, and the median OS around 51 months. So it's more than 4 years OS, which was initially getting with this molecule. ASCENT-4 then come, which is a phase 3 first-line trial, which has also compared with chemotherapy, this ceritinib, and showing a similar median PFS of 16.6 months in this subset of the patient, with a duration of response going up to 24 months. Median OS not reached in this initial studies when it was being, the paper was being published, and treatment beyond progression. So 49% of the patient even continued ceritinib beyond progression and have found to have a durable clinical benefit and disease control with this. Thereafter come the ASCENT-5, which is the phase 3 post-crizotinib trial, which has studied in comparison with chemotherapy, ceritinib has been given in the second-line setting. And even in the second line, it has shown an overall response rate of around 40%, with disease control rate going 77%. If we look at some special population groups, especially those with CNS, so I've said it is more than 50% of the patient have a CNS mets with ALK positivity. This molecule produces an intracranial overall response rate of around 28%, and with the whole body disease control rate, it is around 67% in this. Leptomeningeal disease, even that gets controlled around with disease control rate of 67%. So once a patient develops a leptomeningeal disease, it's very hard to control with a limited survival, but even with that, this molecule has got an effect. If we go for a subgroup analysis with brain mets across the trials, all trials show something around 45 to 50% intracranial response with this molecule. The important thing is ALK resistance mutation. So once the patient progresses on an ALK inhibitor, there is some mutations which develops, and this resistance mutation post-crizotinib are mostly L1196M or G1269A, with ceritinib having a potent inhibition even on this post-crizotinib setting. And the only thing is G1202R mutation, where it doesn't have an activity and where we may need lorlatinib and other drugs for this. So ceritinib overcomes multiple crizotinib resistance mutations, enabling effective post-crizotinib treatment. And even if we see Asian population and non-Asian, it has shown to benefit in both the subset of the patient with equal important. And if we go up with the performance stage and the age subgroup, or both have got a similar benefit across both the subset of the patient. The ASCEND-8 is the other study which has now the practice changing, that the dose has been decreased to 450 mg from 750, and it is given with food as compared to the early fasting stage, and it has shown to have a similar benefit as compared to the 750 mg of the dose. Important thing is one have to learn to manage the toxicities, which are most commonly diarrhea, nausea, vomiting, transaminitis, hyperglycemia, fatigue, and QTc prolongation, which happens with this drug. So this may lead to treatment discontinuation in something around 7%, but with the dose reduction, this has further decreased to 6% of the patient, which require a treatment discontinuation. For diarrhea, you may need early antidiarrheal initiation, hydration. For nausea, vomiting, prophylactic antiemetics. And further, there may be a dose modification, a stepwise reduction from 450 to 300 to 150 mg. And you have to monitor the baseline LFTs and the ECG of the patient, along with lipase amylase, has to be done in this subset of the patient. Look for any bradycardia. Rarely one may have pneumonitis, and one should know that ILD can happen with this drug also. So one have to look for that. So the treatment sequencing is still, ceritinib is being listed as a first-line treatment option or after crizotinib progression. So it can be used in the subset of the patient. So for advanced ALK, you may have either alectinib, brigatinib, ceritinib, crizo, or lorlatinib now. And on progression on ceritinib, again lorlatinib is the initial treatment. In Indian context, cost is a major issue, and most patients are not affording lorlatinib or alectinib. In those patients, ceritinib is the first line, and I'll say the maximum patient in India is still on ceritinib because of the cost effectiveness of this molecule. So for key takeaway, ALK testing is mandatory for all patients, and most patients can be given only 450 milligram of ceritinib with improved GI tolerability, making it a preferred drug. And treatment sequencing should incorporate, if a patient progression, you should go for a ALK resistance kinase mutation domain testing in the subset of the patient. With this, I'd like to thank you all. Thank you.
Thank you, sir, for the talk. And moving to our next talk, we have Dr. Amrit Kaur. She is a consultant molecular pathology department of genetics and molecular medicine from Kokilaben Hospital, Mumbai. And she'll be talking about role of new biomarkers in GI cancer. I welcome Dr. Amrit Kaur, ma'am.
Good evening, everyone. I suppose it's a time for dinner, and we have a gala dinner here. So I will just try to make it as short as possible so that you guys won't have to wait for a longer time. So I will not talk about all the trials or everything which has been spoken so much in detail. My only priority is to let you know which test is the best way to handle your treatments, because in the era of targeted and immunotherapies, you need to rely on the markers which will help you to decide the treatment in different cancers. And today I'll be taking up on GI cancers. In GI cancers, we have the stomach and gastrointestinal in one category. Then we have a colorectal in the second category. So in spite of all the markers, I will just take you through not only the somatic testing, but also the germline testing, which we totally miss upon when we do have, when we are treating the patient. Because if the patient is MSI high gastric or colorectal cancer, there is a probability of, looking into Lynch syndromes, those germline cancers, which could probably, lead you to save so many other patients, which might be MSI high or maybe a Lynch syndrome cases. So it will be an overview of all the holistic biomarkers, which includes both the somatic and the germline cancers, which will be dealt in this particular 10 to 15 minutes, which I'll be very, very quick. So we know what are the principles. We have these many markers: HER2, PD-L1, MMR, BRAF, NTRK, CLDN1, which is the new one. And then we have the molecular testings. So the testings, what test to order is something very, very problematic, what needs to be done, because tissue is an issue, and I think people have spoken a lot about it. So if it is like a limited resource setting, you can go for 1 or 2, 3 tests, but NGS is the way forward, because it not only gives you about the mutations or the amplifications, it also gives you information on the fusions and the probably the other, translocations which could be possibly the cause of that particular driver mutation in that particular cancer. So NGS is a way forward. The values of immuno-oncology markers like TMB, PD-L1, and MSI give us the holistic approach to all of these cancers. So what are the principles of systemic therapy in gastric cancers? We do need PD-L1 testing, which is based on CPS scoring in gastrointestinal cancers, and we do need the dMMR to start yourself on the immunotherapy options. And then in the second and third line settings, we need that RET, and MSI and TMB, just to understand if we have any other options. So PD-L1, we have CPS scoring. It is based on the staining of the tumor cells along with the inflammatory cells, and the CPS score cutoff of 10 and 5 is being validated, and we have to validate very effectively for reporting in the molecular pathology lab. So I will not get into the details of this. Yes, TMB is something very, very important. TMB is about considering the number of non-synonymous mutations. When we call it synonymous, I'm sure it is like the same mutation, which could be, may I just, say hello to those guys on the last? Yeah, I won't take more than 5 to 10 minutes, but it will be great if you are able to, listen to 1 or 2 things here. So non-synonymous mutations which are present, which leads to the high TMB and which gives a very high efficacy for the immunotherapies. So every cancers have different types of cutoffs, but the mean cutoff of 10 is considered, for all the cancers and even in GI cancers. HER2 signaling is very, very important to understand. It activates your RAS and the PIK3 pathway, but very important to understand the mutation and the amplification of HER2. Mutation is a point mutation which is picked up on, most commonly on NGS, but when we're talking about the amplification, it is picked up on IHC, and FISH is the gold standard, and this is what is confusing. We have reported many cases of HER2 +1, which is usually a mutation, because amplification will give you +3 or sometimes, +2. So this is what we have to understand. The treatment parts are different. The diagnostic category is different. And CLDN1 is also something which we have to look forward, NTRK. MSI story is very important, because how many patients with MSI high turns into Lynch syndrome? It's around 30 to 40%. So we have to do MSI testing by PCR or by IHC. How many of them, whatever is available for the patient. CTC for monitoring perioperative, is significant, and then we have to monitor the patients post surgery. So FGFR2b is a new biomarker which is, letting us know how to, because there's a targeted treatment available. This was our data which we published, and we had the TP53, which was a very classic mutation, and we did compare the co-mutations and the MSI stability with the mutations which are more common among them. So in the colon, we have a POL-D or POL-D1 or a POL-E mutation, which is very, important because it gives you options for immunotherapy. I will not get into the details. PIK3 mutation in colorectal cancers gives you option for aspirin. Then multi-panel gene testing for hereditary cancers, which includes all these genes which has been introduced in 2026 by ASCO. And because there's a different risk factors associated with it, but in your clinical practice, if you have a colorectal cancer, please ask for the history of any adenomas or polyposis syndrome, because you might be missing on any one of these, because the patient needs to be put up on prevention or surveillance programs in the future as well. So the principles ask for the proper history, look for any polyposis, look for other family members or any cleft palate if we are looking to CMMRD in case of Lynch syndromes. So the criteria are no longer useful. It's a, MSI is, all universal testing. Germline is almost universal testing in colorectal cancers. For that, genetic counseling is specifically very, very important. We need to sit with the patient, understand what type of somatic testing, what type of germline testing the patient needs, and based on that, we should be able to help the patient and guide it in the right direction. So I will just say cascade testing, reproductive options are available for the patient if the patient is diagnosed with MSH2 positive. So, we had some patients in which the children, they refused to undergo, they said they won't marry because the children will also have that MSH2 gene and they will be a part of Lynch syndrome. But now the reproductive screening options are available for even cancer patients. So that's a new introduction which has been included. And with that, I think I have finished my time. I have just concluded everything what has been taught in the morning. But germline testing, universal germline and somatic testing is the way forward. It's not about tumor-informed or not, but we need to understand that the patient is not, we are not missing the patient with any germline mutations, because the risk increases, the prognosis varies, and the treatment options are also available in those cases. And I thank you so much for your patient listening, and thank you all.
Any questions from the audience?
Hi, Dr. Amrit. It was a good talk. I think you put everything together. You had so much to say. This is a quick question because you're talking about germline cancer and TMB. I would like to ask you one question where, we had a lot of research made on how TMB is being calculated. So when there are smaller panels, the TMB is only calculated for those 500 genes. So initially when it came up, there was also another company which is called as Nant Health, who published data saying that they do a tumor normal and they calculate the TMB for 19,000 of all the exonic genes, like the non-synonymous mutations, and that becomes a more gold standard to identify if they are eligible for immunotherapy, right? And we are also talking about germline. So when you talk about TMB, right, especially subtracting all the non-synonymous mutations which are there in the, that's how do you what's your take on that? Because germline testing is very important. And in the TMB part, have you, thought about it? Because here germline subtraction is all mathematically done for all the 500, only the somatic tests, right? So right now, our tests don't take germline into consideration. It's only with the VAF that we are able to, work with that. But I just want to know what is your take on that.
Yeah, I totally agree. sometimes a VAF is higher and which might not be predictive of the germline mutation present in the patient. So the one thing which I do is I calculate the tumor percentage. If the tumor percentage is 70 to 80%, and if I get a VAF of 50%, so I will not put up a note saying that you have to go for germline testing. But if I say the VAF was 20%, the tumor percentage was just 20%, and I get a VAF of 50%, obviously I'm looking at a germline mutation in that particular case, and then we call back to the patient and understand if the patient has a particular type of cancer in the family. Sometimes we have a Lynch syndrome, one with endometrial, one with the breast, one with the ovarian, and one with the classical colorectal. So if the history fits in, and I have a 50% VAB with 20% tumor, so probably we are looking at a germline thing. And TMB, I feel, yes, it needs further standardization, because whatever the data which we have and the cutoffs which we have usually do not fit into all the classical tumor types. And I see that melanoma and GI, even colorectal have a quite high TMB. It goes more than 10, and even lung cancers also. So probably 15, 20, based on further validation, we can divide them according to the different tumor types. So that's a smart thing to do right now.
Thank you so much. Yeah.
Any more questions from the audience?
So we request the chairpersons to conclude the session.
Thank you.
So I think that's it. So I would like to thank you, ma'am, for
so
this insightful lecture in such a short span of time. Thank you, ma'am. Thanks.
Thank you.
So thank you, the respected chairpersons, for moderating this session. Thank you, ma'am, for, of course, you did it very well. So with this, we conclude the day 1 of Ranchi Cancer Summit 2. Thank you so very much for your kind presence throughout the day. And we close this, the day 1 academic feast. And we request everyone, please to come join us for a dinner at Vatika and enjoy some music also. Tomorrow again, we start the session sharp by 10 a.m. So thank you so much, and please do join, for dinner. Thank you.